A very good morning to all our esteemed dignitaries on the dais, off the dais, respected speakers, distinguished delegates, and all our dear participants. Somewhere, something incredible is waiting to be known. With this quote of scientific curiosity, the management, staff, and students of the Department of Oral Pathology and Oral Biology extend a very warm welcome to one and all for the International Conference on Craniofacial Pathology and Biology. To invoke blessings and begin this auspicious event, I kindly request everyone to stand for the Tamil Thai Valthu.
நீராறும் கடலுடுத்த நிலமடந்தை கெழிலொழுகும் சீராறும் வதனமென திகழ்வரத கண்டனிதில் எக்கணமும் அதில் சிறந்த திராவிடனல் திருநாடும் தக்க சிறு திரை நுதலும் தரித்தனரும் திலகமுமே திலக வாசனை போல் அனைத்துலகும் இன்பமுற எத்திசையும் புகழ் மணக்க இருந்த பெரும் தமிழனங்கே தமிழனங்கே உன் சீரிழமை திறம் வியந்து செயல் மறந்து வாழ்த்துதுமே வாழ்த்துதுமே வாழ்த்துதுமே.
There's a famous saying, in the right light at the right time, everything will be extraordinary. Lighting the lamp signifies the triumph of knowledge over ignorance. I kindly request everyone to join with us for the digital lighting of the Kutuvelakku. I now invite Dr. Ramya Ma'am, Professor and Head Oral Biology, the Organizing Secretary of ICCPB, to deliver the welcome address.
Good morning. A very warm welcome to our most respected and inspiring Chancellor, sir. Our respected Vice Chancellor, sir, who is a very vibrant personality, and our ever-smiling and always positive Registrar Ma'am, our beloved Dean Sir, whose visionary leadership has taken SDC to great strides, our most respected oral pathologist, G.S. Kumar Sir, and the respected team from IAOMP, the guiding stars behind Oral Pathologists of India, President Dr. Nadeem Sir, and Guru Raja Sir. And a very warm welcome to all the respected seniors, esteemed speakers, colleagues, and my dear participants. It gives me immense pleasure to welcome you all to the 4th consecutive edition of this conference. What began as a shared vision 4 years ago has today mattered into a most vibrant academic platform that reflects consistency, commitment, and collective growth. Over the 4 years, we have not merely continued this initiative, we have evolved in many ways. Each edition has meaningful improvements in the depth of discussions, quality of deliberations, and the impact of outcomes. We have instituted awards to recognize excellence in the field of oral pathology, which is the first of its kind in the world. And we have derived consensus statements in the most important, highly prevalent diseases, oral diseases, that contribute to clarity and in practice and research. And most importantly, we have created a dedicated research group that fosters sustained collaborations beyond the conference walls. This journey has been possible only because of the unwavering support of our leadership, which is highly proactive and visionary, which anyone can even dream of. The guidance of our advisors, the dedication of our organizing team, and the enthusiastic participation of scholars and students alike, both national and international forum. What truly defines this forum is its spirit of dialogue, of shared learning, and advancing our discipline with purpose. As we embark on this new year's program, we look forward to insightful sessions, constructive debates, and collaborations that translate knowledge into meaningful progress. Be ready for very interesting announcements that keep coming on the way. Once again, I warmly welcome all of you to be a part and celebrate this enriching conference experience. Thank you.
Thank you, ma'am, for those gracious words of welcome. We now move on to the landmark moment of this conference, the release of the consensus report and the grand launch of an important award. I invite Dr. Pratibha Ramani ma'am, Professor and Head, Department of Oral Pathology, the Organizing Chair of ICCPB, to kindly take over.
Good morning to one and all. It's always a pleasure, and I have the blessings of God because I have the very man who has made everything possible today for the department, Dr. N.M. Veerayan sir. Like, he's the father figure of our department. Anywhere in India, I can proudly say that we were the first department to be fully equipped with all the equipments thanks to his vision around 15 years back. He had the confidence in us as a team, and he gave all the facilities 15 years back, which has now grown into a big tree, and we are all bearing the fruits of the tree under our great visionary, his own son, Pro-Chancellor Dr. Deepak Nalaswamy sir. He has taken beyond the vision of sir, and we are what today? We are #1 in India and of course in the world because of the great vision of what sir has had around 30 years back. So that is the mainstay of what is the leadership is very, very important. That is what I mean, I'm emotional as always when sir is on stage. And it's my proud, Ramya has given a welcome address, but it's my duty to welcome our VC, our Shija ma'am, Dr. Aravind, and from the association we have Dr. Nadeem Jeddi, who is the president of Indian Association of Oral and Maxillofacial Pathologists, and Dr. Gurraj Rao, who is the secretary of Indian Association of Oral and Maxillofacial Pathologists, and our evergreen Dr. G.S. Kumar sir. He is a pioneer. He is the second batch of MDS who has, along with my own great teacher, Dr. T.R. Saraswati, batchmate. So he's my teacher, my guru, and I feel honored to have him on stage. Thank you so much, sir. And what is the important thing is that the consensus meeting. This is a dream of our Pro-Chancellor, Dr. Deepak Nalaswamy sir, because he always believes he's a strong clinician, and he always believes that there should be a translational research, that whatever we do, oral pathologists should not be only as a person writing articles and sitting backbenchers. He always felt that there should be a consensus forum where we deliberate on both clinical as well as histopathological aspects, and very important is management aspect, especially in diseases in India, and that was the main brainchild of our idea of having a consensus meeting in the last forum, where we had a discussion on oral submucous fibrosis. We know it is the mainstay disease in India, and there was a consensus meeting, and really we are proud and honored and even grateful to Indian Association of Oral and Maxillofacial Pathologists for publishing the same in the forthcoming issue, and we are ever, it's I think first of its kind, and the association has been so supportive, and we had all the eminent persons who have done a lot of work, who had come here, had been a part of the deliberations, and we have now come out with the publication format of it, which we humbly request our Chancellor along with the dignitaries on the dais from the association to release the consensus report, which has come as a publication in our own journal. So this is something which is first of its kind, and we kindly request the dignitary on the dais to release this consensus report. And for the second consecutive year, again, we have a panel. The consensus is very important because it forms a landmark for any publication, for any reference, for all clinicians as well as for researchers. So this is something which we have been dreaming of, and it has come to reality. And next and most important thing which we would like to announce here, it is from the our own Chancellor. It is because being a dental surgeon, sir, as I told, he has a very special place for oral pathologists in his heart, and so he has decided to introduce an award that will be Dr. N.M. Virayan Award, recognizing top 5 oral pathologists worldwide. So this is, we will be we will put the criteria and all the necessary requirements along with our association, Indian Association of, we request your guidance, and we'll frame criteria in such a way that we try to get the best and give this award to the most deserving person. And we are extremely thankful to Chancellor, because to recognize oral pathologists itself is something big, and him recognizing, giving an award his name, we are extremely grateful to you, sir, and very honored. And please give a standing ovation for sir for giving this wonderful opportunity to all the oral pathologists across the world. Thank you so much, sir. We are always indebted to you, sir.
Thank you, ma'am. We shall now proceed with the felicitation of our esteemed dignitaries. I kindly request our Dean, Dr. Arvind Kumar sir, to felicitate Dr. Nadeem Jedi, the President of IAOMP. I now invite Dr. Nadeem Jedi sir to address the gathering.
A very warm welcome to one and all gathered here. It's indeed an honor to be here as the president of the association. My first and foremost thanks to the founder chancellor, Dr. Virian sir, the respected dignitaries, other dignitaries on the dais, principal registrar, Madam Kumar sir, Dr. Gurraj, and off the dais I can see some eminent pathologists here, Dr. Rajiv Desai sir, Dr. Dinakar, Dr. Nirmal, Dr. Shamla Ravi Kumar, Dr. Bharati. So it's a wonderful fraternity we have, and I thank Ramya Malini and Dr. Pratibha for always inviting us and keeping us in the loop. As an association front, we are always here to help Saveetha and to collaborate and to do a lot of things good for the association. And previously, I was the secretary of the association, and I think I tried my best to do a lot of work for the association. Now, which is carried forward by Dr. Guru Raj, an eminent person from Madurai. So he is taken over as secretary. I wish the program a grand success. Thank you.
Thank you, sir, for your valuable words and continued leadership. Now, I kindly request our Dean to felicitate Dr. Guru Raj, the Secretary of IAOMP. I kindly request Guru Raj, sir, to address the gathering.
Good morning, most respected Chancellor Sir, Vice Chancellor Sir, Registrar, Dean, President IOMP Dr. Nadeem Sir, Pratibha Ma'am, Ramya Ma'am, the senior most oral pathologist Dr. Raji Desai Sir, and all the colleagues of the dais. See, first of all, though I am working in a college at Madurai for 25 years, still I dream that can I get a placement in this type of college because of the academic heights that with the help of Dr. Viren sir, they have achieved actually. Morning, in fact, we have seen that entire campus. Little bit, we feel that something we cannot express. So, and that too, if you see the topic today, say Lychnard reaction. See, what do you mean by that? When you see a case of Lychnard reaction, we should remember that you know very well that, okay, patient is having some sort of drugs or something, so he must be hypertensive. Be careful with your routine procedures. But now the debate is in such a way that whether the carcinogenic aspects and all. And the two, Raji Desai sir is going to play today and you are going to enjoy. Those who have not attended the lecture, kindly be sincere and try to enjoy that show actually. So, with this great opportunity, I congratulate the entire team, Pratibha Madam, Ramya Madam, and all the other team for this program to go for a grand success. Thank you.
Thank you, sir, for your words. I kindly request Dr. Monal, sir, to felicitate our Dean. I now request our Dean, Dr. Aravind Kumar, sir, to address the gathering.
Very good morning, dignitaries on the stage, off the stage, and students and faculty members from the various dental colleges as well. It is like immense pleasure for me to address the group of oral pathologists coming here all the way across India, coming here and to attend a conference here, which has been successfully conducted for the past 4 years. And unless we have that determination to conduct it in a way, people will not come across India to attend this conference. I'm very happy to see lots of people join this conference and attending this type of conference, which is going to be a next level conference, which is going to take oral pathology to the next level. And briefing about Saveetha, welcome. I take this opportunity to welcome all of you to Saveetha Dental College, which is a college which is created by the dentist for the dentist. So we should all be proud about this thing because we are here to do anything for dentistry. And you would have seen the campus and you would have seen the facade before. That is basically telling to the world that we dentists are one community and we are having a religion by ourselves and we are worshipping our profession and we are proud of our profession. And this is how we should think about a dentistry to and we should only take our profession to the next level, because other people, other specialties are not going to allow us to grow again. So this is where we have to tell the community that, you know, we are one step ahead of all the other professions, and we are doing something really great in dentistry rather than we talking bad about dentistry. So please go around the college, look around what we are been doing in terms of dentistry in all the specialties across dentistry. We have the best equipments and the best research facilities. So please go around the college, students and faculties from various colleges, and you will appreciate what has been happening here. And any sort of training you need be in oral pathology or in, you know, any other fields of dentistry, we are more than happy to host all of you here, and take this opportunity to just go around and make the best use of this conference. And best wishes to the oral pathology department for conducting this conference for the consecutive 4th year. Best wishes. Thank you.
Thank you, sir. Next, I would like to call Dr. Ramya ma'am to felicitate Shija ma'am at the registrar of our university. I kindly request Dr. Shija Varghese ma'am to address the gathering.
A very good morning, respected Chancellor Sir, Vice Chancellor Sir, and all the dignitaries on the dais, faculty members and students. I'm very happy and proud to stand before you, and first of all I want to congratulate the department to conduct this conference 4th time consecutively. This conference always, as far as I know, that oral pathology department, as Pratibha mentioned, see, from the beginning our department, oral pathology was the best department. We were fortunate to get samples across India for the pathological examination, and we were fortunate to have all the best facility in the department. So at a time, that is in the beginning of our college, oral pathology was the research department of our college, and from that we have moved a lot, and now the Saveetha become a research center. And that is our vision of our chancellor and pro chancellor, was that introduction of this oral biology as a separate department. That was also one of its kind, and that made us to think more laterally and start more courses that also actually make our research more deeper into the basic things. And with that start of the department, only this conference was started, and they are always, they bring all the best academicians and researchers for this conference. And I know that this conference, definitely all the students, you are going to benefit from that. Please make use of this conference, and I wish all success for this conference. Thank you.
Thank you, ma'am, for your gracious words. I kindly request Dr. Monal sir to felicitate Dr. Ashwani Kumar sir, the Pro Vice Chancellor of our university. Vice Chancellor of our university. Vice Chancellor of our university. I kindly request Dr. Ashwani Kumar sir to address the gathering.
Good morning all, Honorable Chancellor Sir, dignitaries on the dais, the visiting oral pathologists from all across India, faculty members, students, ladies and gentlemen. It is a great pleasure and honor for me to say a few words on the inauguration of this conference. Saveetha University, I'm very proud that I'm the Vice Chancellor of a university in which the Saveetha Dental College is a flagship institute. Topmost, it started with the dental college, And maintaining excellence over decades is no means a easy task. And we have been adjudged one of the best in the world, and there is a reason for that. A lot of dedication, a lot of devotion, a lot of investment of resources, and maintaining those standards of teaching, clinical practice, and service, and with all humility and I would say ethics, as well as concern that we have for the patients. Oral pathology, we do cancer surgeries free. We don't charge anything. Cleft surgeries we do free. So a lot of empathy in this institution embedded in our social service that we do in the form of dental practice. So, and a very landmark institution. Every other day we make records. And I think in the last 1 month we have made about 10 records, 10 world records. These are world records, benchmarks, which our students are making. And so they go, when they pass out, very proud at the undergraduate level or the postgraduate level, when they go and practice in the real world. I mean, they have something to show to the world that we are one of the best institution, and I personally got that person can say that so many opportunities to do maximum number of extractions, for example, during practice, and different kinds of benchmarks that they have created for themselves. So I'm very proud standing in front of you, and I really want to thank our dean for maintaining such high standards, and please keep maintaining that. And I think the most satisfied, if anybody is, that our founder chancellor sir is the most satisfied person, because he says I wanted to create a model dental college, and he has remarked recently that I feel now that we have a model dental college which is one of the best in the world. So wish you all the best during the conference, and I hope I echo the sentiments of our Arvind sir, that please make best use of this opportunity, interact, visit our labs, and see state-of-the-art labs in the Spark building, and you will realize that how much we give importance to the innovation and research and innovations, and also product development. That building will be the one where the student can enter with an idea and come out with a product. That's the main aim. So wish you all the best. Thank you very much.
Thank you, sir, for your encouraging words. Next, we will move on to the next event, the announcement of Lifetime Achievement Award. I kindly request Dr. Pratibha Ramani ma'am to announce the Lifetime Achievement Award.
Thank you once again. Actually, this award is given by the International Orofacial Biology Group, and it's been given as a part of, in recognition of an outstanding achievement. And it was a great pleasure actually having a chit chat with Dr. G.S. Kumar sir in the morning, that it seems he had a dream to do oral biology. And it so happened that he's been awarded by this forum of orofacial biology group, which I think which he had dreamt as a young dentist at that point of time, to get it from an institution which is the only institution in India which is having this course, oral biology course, and given by an international orofacial biology group, is something, I think it's God given, it's by the grace of God. So God is always around and He blesses our thoughts. So positive thoughts are very, very important. Talking about Dr. G.S. Kumar sir, he's a doyen in the field of oral pathology. He's the second batch of MDS. As I had told, he's the batchmate of my guru, Dr. T.R. Saraswati. And sir has been in Dharwad for close to 20 years. I think at that point of time, they were the only institution who were having frozen. So Saveetha soon followed, and we also ensured that we had the better version of the frozen microtomy, and we had. And it's been a pleasure, because sir is a full-time academician right from 1984, and he worked in CODS Manipal, SDM Dental College, and sir also served as a visiting professor in University of West Indies. He had undergone at that point of time in the late 80s molecular biology training in King's College of London. And sir has been, I think, very, as a postgraduate, I've been inspired by him because he was the one who had already told about collaborative work with people around the world. He told, write and collaborate and you'll get published. I remember still sir telling, when we had asked something about some rare cyst which we had in Saveetha, he said, you collaborate with the authority, Shear in at that his counterpart Altini. So I'm sure Dr. Rajiv Desai sir also remembers we had a meeting here and we had a publication with him at that point of time, and that was the great idea of Dr. G.S. Kumar sir. So his vision was also beyond that age, and so it's really proud for me to have sir here. Sir has, of course, been the president of our Indian Association of Oral and Maxillofacial Pathologists. He has, and most important student, sir is the editor of Orbans, Oral Histology and Embryology. He has been the Senate member of Tamil Nadu MGR University, member of various boards across India and across membership across various professional bodies. And he has been awarded the fellowship by the IOMP, Best Teacher Award from the Tamil Nadu Dr. MGR Medical University. And he is like sort of a guardian for our association. So we are truly honored to have sir, and personally it is my privilege to have you at Saveetha Dental College on behalf of the group of Orofacial Biology group to give this honor of outstanding achievement, a contribution and pioneering in research and a lifelong dedication to the field of oral pathology and oral biology. If I would like you to add along, because you need it, sir, you have edited the Orbans. So you can always have that part of it also, and this award will add an icing on the cake for you. Thank you so much, sir. We request our Honorable Chancellor to felicitate Dr. G.S. Kumar, sir, with the award. Dr. G.S. Kumar, sir, to give a few words of your wisdom, sir.
Respected Chancellor Sir, respected dignitaries on and off the dais, distinguished audience, good morning to you all. Little too emotional, and I guess I need to speak, so I got paper written down. I hope I won't falter, and that will be memorable as well. This is a memorable moment in my academic career, especially if it comes after retirement, somewhere in 2020-21. After retirement, you feel happy if someone stops to greet you. More often, Others have no time for you. If someone honors you, someone honors you, I'm more than happy. I'm elated. And if this honor comes from the India's best #1 dental college and 13th in the world ranking, my elation becomes ecstatic. So I need really to thank the management and the staff of the Saveetha Dental College from the bottom of my heart. I chose oral pathology as a career not because I like the subject so very well, but because my professor, Dr. Vishwanathan, was a very fine gentleman, very learned, sincere in his work, and very affable, unlike many of his colleagues of the time. I imbibe these qualities and pass it on to my junior colleagues. I don't call them as PG students. Some of the honors I received either because I happened to be at the right time, at the right place. Default option, perhaps. And others came naturally to me. Behind this was my very simple recipe: sincere hard work and dedication. Teaching is my passion. Even now, I don't get an audience, but take it to spirituality, a natural course to atone for your sins. Thus, attain status, if not for a blessed figure, at least a blessing figure. Hence, God bless you all. All the best for the young men and women, and a very big thank you again for all those who made my day. Thank you very much.
Thank you so much, sir. At this moment, I have to tell about another important person who's a part of our institution, our advisor, sir, our former Vice Chancellor, sir, Dr. Rajagopal, sir. He's the thick and thin of this institution. The growth of this institution is always by his side with Chancellor, sir, and he's, I think, been in all the 4 years he has come for this inauguration ceremony, and we are really thankful to you, sir. Sir is so humble, he did not want to come on to the stage, but sir, it's our duty to welcome you, sir. And we also welcome Dr. Isaac, who has come from University of Oribro. He's a part of this orofacial biology group. He is going to give a keynote, and we're extremely grateful to you. And of course, to all our speakers, like I mentioned before, Dr. Rajiv Desai, sir, Dr. Shashidhara, Dr. Dinakar, Dr. Nirmal, Dr. Bharati, Dr. Arvind Babu, and all the, across everybody, and our own Shamla ma'am. She's been here, and it's always a proud privilege to have ma'am. She always comes here. And we have Dr. Ranganathan, sir, who will be joining us soon. And we have a elite list of pathologists who will be joining us for the consensus meeting. And also I would like to keep it on note, apart from the offline registrations, say around 350, we have close to 700 registrations online, and it's going live online. So it's really a honor, and thank you one and all, and thank you so much, sir.
We now move on to the next event, the Expert Award Ceremony. I kindly request Dr. Abhilasha ma'am to announce the list of awardees.
I'm very happy and proud to be here and announce the awards for the outstanding contribution to the field of oral pathology. These people have been trailblazers in oral pathology, leaving a lasting impact in this dental science. They have elevated the oral health through their passion, expertise, and innovation. So, the first award we would like to announce goes to Dr. Bharati ma'am. Ma'am is the professor and head of Government Dental College, Chennai. We're very happy to have you, ma'am. We request Chancellor, sir, to kindly give away the award. The next award is to Dr. J. Dinakar. Sir is an oral pathologist, again the Dean of Ragas Dental College, Chennai. We are very proud to have you here, sir. The next award is to our very own Dr. Madhavan Nirmal, sir. Sir is the Professor Head of the Raja Mutaya Dental College, Chidambaram. Sir has come all the way. Thank you so much, sir, for being here with us. We request the audience to please applause. The next award is to Dr. Gururaj, sir. Sir is here with us. Sir is the Professor and Head of CSI Dental College, Madurai. Sir is also the Secretary of the IAOMP. Sir has been kind enough to be here with us. Thank you, sir. Next, I welcome Dr. Shashidhara, sir, Professor and Head of Coorg Institute of Dental Sciences. Sir is our favorite oral pathologist and sir is always here to encourage us. And today sir is receiving the award. We are very happy and we would like to give him a good round of applause. Based on other credentials, we have also appreciated and awarded a few more faculty from various colleges. So first of all, it's from our college, Dr. T.N. Uma Maheshwari ma'am, who receives the Best Innovator Award in Oral Biology. Ma'am is the Professor and Head of Academics of Oral Medicine Department. Next award is to Shamala Ravikumar ma'am. Ma'am receives the award. Ma'am is the senior most oral pathologist. Ma'am has been a teacher for all the teachers over here. So ma'am receives the award for excellence in oral pathology teaching. Ma'am is the Professor and Head of Adi Parashakti Dental College. Thank you, ma'am. Next, we would like to give the award of the Best Researcher Award above 35 years to Dr. Arvind Babu, sir. Sir is the Professor and Head of G. Balaji Dental College. Sir has always been with us. He's a supporter of our department. And sir now receives the award for Best Researcher. Congrats, sir. Now, I would like to welcome another very important oral surgeon from our institution, Dr. Gideon Arularasan, sir. Sir receives the Best Oral Cancer Surgeon Award. Sir is very active in oral cancer surgeries and he's treated so many patients. Thank you, sir. I welcome Dr. Lakshmi R. from the Department of Periodontics, SRM Dental College. Ma'am receives the Best Researcher Award above 35 years in the field of oral biology. I'm proud to say that ma'am is also an alumni of our college. Thank you, ma'am. Now I welcome Dr. T. Maheshwaran, sir. Sir receives the award for the Distinguished Peer Reviewer of Dental Researcher Award. Sir is a professor in the Adi Parashakti Dental College and Hospital. Thank you so much, sir, for coming. Now I welcome Dr. Aditya B. He receives the Early Researcher Award below 35 years in the Department of Oral Biology. Sir is an early researcher and senior lecturer from Adi Parashakti Dental College and Hospital. I also welcome Dr. Kokila Shivakumar. She receives the award of early researcher in the Department of Oral Pathology. She is a reader from Adi Parashakti Dental College. Welcome, Dr. Kokila. Alumni of Saveetha Dental College. Now I welcome Dr. Janani I. She is a reader in the Adi Parashakti Dental College and Hospital, a very enthusiastic teacher. So she receives the Best Oral Histology Teacher Award in the Department of Oral Biology. Welcome, Dr. Janani. Now I welcome Dr. Priyanka Choran, professor from the Department of Periodontics, SRM Dental College, Ramapuram, and she receives the Best Innovator in Oral Biology Award. Welcome, Dr. Priyanka, and I'm also very happy and proud that she is also an alumni of our college, and she's doing very well. Next, I welcome Dr. Gauri S. from the Department of Oral Pathology, Adi Parashakti Dental College and Hospital. Ma'am receives the Best Oral Pathology Teacher Award. Congratulations, ma'am. Thank you for being with us, ma'am. Thank you, ma'am. I now request Dr. R. Ragini from Mada Dental College. Ma'am is a professor in the Department of Oral Pathology, and ma'am receives, again, Best Oral Histology Teacher Award. We're very happy to have ma'am with us. Ma'am has been my teacher when I was an undergraduate as well. But not that old. I welcome Dr. V. Pungodi from the Department of Oral Pathology from Meenakshi Ammal Dental College and Hospital. We're very happy to have her here, and she receives the award of the Best Innovator in Oral Biology. Moving on to the postgraduate awards, Dr. Chemmalar from Meenakshi Ammal Dental College receives Best PG of Oral Pathology Award based on her credentials. Next, Dr. Shweta SR from Adi Parashakti Dental College also receives a Best PG of Oral Pathology Award. Undergraduate awards. So I request Parinita Yadav. Oh, sorry, I think they are not present, sir. So with this, we conclude the award. She's there? Parinita, you're here? Please. Parinita Yadav from RV Dental College, Bangalore. She receives the Best Undergraduate in Oral Biology Award. Next award goes to Shreyas Basavaraj Dalawai. He receives from RV Dental College, Bangalore. Thank you for coming all the way. He receives the Best Undergraduate in Oral Pathology Award. Congratulations to both of you for receiving award in such a young age. Thank you.
Dear participants of the International Conference of the dignitaries can please take this seat. Participants of the International Conference of Craniofacial Pathology and Biology, we have a very interesting announcement, and we've been really in very high spirits for the past few days. We thought we will share it with you all, those who are watching it online and offline. So Saveetha Dental College has been honored with an exemplary educational institution award at the global level at the edX Summit, which has been happening for past 30 years. This global prize recognizes the institutions which demonstrates excellence in education, integration, impact, and holistic student development. Being selected among institutions worldwide reflects the collective commitment, academic rigor, and visionary efforts of our leadership. The award was presented at edX Dubai, which is the world's largest dental conference, which had around 89,000 visitors, 3,500 exhibitors with representation from 177 countries. And among this very, very extraordinary, massive group, we won the Exemplary Institution Award, which set us clearly high at the global map. This award ceremony was a very big event and of unimaginable scale. The honor also included a cash prize of Arab Emirate Dirham 20,000 with a global prize trophy, and above all, it strengthened our international recognition. This achievement is a reflection of the far-sighted vision and steadfast guidance of our Honorable Chancellor Sir and Pro-Chancellor Sir, whose belief in excellence, innovation, and people has shaped Saveetha's journey to global recognition. And let's celebrate this moment. Please put up your hands.
Of Medical and Technical Services from the Republic of India.
As we share this proud moment with all of you.
And the British University in Egypt from the Arab Republic of Egypt. Ladies and gentlemen, the Al-Shimmari and Al-Madani Global Prize for Exemplary Educational Institution is awarded to Saveetha Institute for Medical and Technical.
Now, I kindly request Dr. Nadeem Sir, the President of IAOMP, and Dr. Gururaj Sir, the Secretary of IAOMP, to felicitate our beloved Chancellor Sir. I kindly request Kumar Sir also to join along and felicitate. I kindly request our beloved Chancellor, Dr. N.M. Veerayan Sir, to address the gathering.
Good morning. all of you are alert or gone to sleep? Good morning. I am very, very happy to be here with you today. And you all talk much about the college and the achievements. These achievements happened only because of the hard work done by our staff and students. Our part is very little in all these achievements. Our staffs and students play a major role in getting all these things, especially the world records, world #1 college and India's #1 dental college. All these things happened only because of the staff. And especially the oral pathology staff, I should appreciate. All of them, I can't say what to say, but they are very dedicated, and at the same time they are very, very much aggressive in getting things done. Especially the HOD, Dr. Pratipha, if she wants something, she will not leave me until I give it to her. Not only that, she will say, I will get it back in 5 years' time or 6 years' time, and she will definitely do it in 3 or 4 years' time. Very sincere people, very hard working, and it is not on our command or our request. They do it on their own. They treat their department as their own department, and they do everything, whatever necessary to become a good department. That way I should congratulate the oral pathology staff. And this award also they only mooted, and I said, okay, we will do it. Something we should do like Stanford's 2% scientist. In oral pathology also you must have good recognition all over the world. Then they said, we will do it. If they say they do it, definitely I know it will be perfect and pakka. No, nobody can point out any finger on us. Such a beautiful, wonderful staff. I really congratulate for them and thankful to those people. This conference also will be a very eye-opening to many of you, and I wish and pray God that this conference will be a lifelong, cherishable conference. Thank you very much.
Thank you, sir, for your visionary and inspiring address. There is nothing more important than expressing our words of gratitude. There is always something in our life to be thankful for, and today is one such wonderful day to be thankful. I kindly request Dr. Monal, sir, to deliver the vote of thanks.
Good morning. Good morning. As we come close to the sessions, it is my privilege to propose a vote of thanks. First and foremost, I express my deep sense of gratitude to our respected leadership for their constant guidance, vision, and unwavering support, which continue to inspire us to raise the standards of academic excellence years after years. We profoundly thankful to our distinguished chief guests, esteemed speakers, for sharing their time, wisdom, and invaluable insights. Their presence and scholarly contributions have truly enriched this conference and set a strong intellectual tone for the deliberation ahead. I extend my sincere appreciation to our advisor, panelists, experts who played a key role in shaping the scientific content, consensus discussion, and research directions of this conference. My heartfelt thanks to organizing committee, scientific committee, all subcommittees whose meticulous planning, dedication, and teamwork transfer this vision into reality. Your behind-the-scene efforts deserve special recognition. I also thank all the delegates, researchers, faculty members, students for their constant enthusiasm, participations, thoughtful engagements, and commitment to learning, without which this conference would have not have its true purpose. Lastly, I acknowledge every individual who contributed directly or indirectly to success of this event. Your collective efforts truly reflect the spirit of collaboration and academic integrity. With this, I once again thank you all and wish you everyone successful insight and memorial conference. Thank you.
Thank you, sir. I kindly request everyone to rise up for national anthem.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
I kindly request everyone to stay back for oral path, oral biology department photo with the dignitaries. I kindly request all the awardees also to join the photo session.
All the awardees, you can come for the photograph.
We request our chief guests and guests of honors and the speakers, distinguished speakers, to join us for the tea at Mirage Hall.
Been a proud privilege for me on behalf of Saveetha Dental College to welcome the panelists for today on a very, very interesting and apt and the most debatable topic because it involves probably three branches or three clinical branches as we consider oral path also as a clinical branch, and it's been a controversy over after WHO has considered this lichenoid group of reaction as an OPMD. I'm sure many of us are here beg to differ on that aspect based on the clinical experience, but of course WHO being the superior authority will have their own justifications for the same. So we thought it would be an ideal topic of discussion. Like last year we had something on oral submucous fibrosis, which is a well-established entity, and just that we needed certain consensus on certain aspects, which we were grateful to all the panelists last time. We had chaired by Dr. Ranganathan sir and Dr. Vinay Hazare sir and an eminent group of pathologists who were involved with the consensus which we have published. And so this time we thought we have a different perspective and involve not only oral pathologists, of course, who are the mainstay and of giving the diagnosis aspect, but two people who come across, think whether to do a biopsy or not, and obviously the most important part, they do the treatment aspect. I'm sure we know patients with lichen planus or a lichenoid reaction keep coming back to the clinicians, both to the dermatologist and to the oral medicine specialist, and probably one part of it is played by the oral pathologist when we are following up on long-term patients on looking in for dysplastic reactions. So the panel here comprises of eminent oral pathologists who have been working on this, who have been a part of the WHO. We have two dermatologists who are clinicians, who are practicing clinicians. They are not anyway involved, they only give lectures, but they are pure clinicians. So it would be a very, very important aspect which we will be getting from them. And of course, our own experience with our Saveetha, we have our oral medicine team, Dr. Aravind and Dr. Uma. Dr. Aravind and Uma see quite a bit of cases, and they refer, they do biopsy, and it's a coordinated work which we do in Saveetha. We work as a triple O, and so we are also called in. It's not that we are not involved in the process of diagnosis. So in that way, we thought we should involve a team which would give a very good aspect of it rather than just going in by articles or manuscripts. We wanted very much a clinical aspect. We wanted to see patient aspect because now articles and the data is available for anybody and everybody. Only thing which is lacking is the clinician expertise. So in that way, we thought this would be a very apt topic. I'm really honored to welcome Dr. K. Ranganathan sir, Professor and Head, Department of Oral Pathology. Sir will be initiating the discussion and would be giving the concluding marks. Of course, I would be here as a moderator just questioning and having my, as always, silly or doubts which I usually have. It's also a pleasure to welcome, and all of us here do not require any, sir doesn't require any introduction, Dr. Ranganathan. He is a Professor and Head Department of Ragas Dental College. Sir is the Secretary of President of International Association of Oral and Maxillofacial Pathologists. He's been past president of our IAOMP. He is also a very important member in most of the governing councils across all internationally across the globe for all oral pathologist forum. And it's indeed a proud privilege to have you, sir, because it is very important to have your perspective being a clinician as well as an oral pathologist. In the similar lines, we have another very eminent personality, a vibrant who shares same birthday as me, Dr. Rajiv Desai, sir. Maybe the same. He is Professor and Head from Nair Dental College, and sir has also been another person who is, and he is also has a clinician as well as an oral pathologist, has done a lot of work in this regard, and it's indeed a proud privilege to welcome you, sir. And online, we have two more pathologists who are there, like three more pathologists rather. Dr. W.M. Tilakaratne, he is a world authority in this lichenoid and dysplasia associated lesions and is a part of the WHO team. So sir is joining us online, and Dr. Thomas George, again from University of Malaya. He's also professor from in the Department of Oral Pathology. And of course, we have one more practicing oral pathologist and implantologist who is joining us today, Dr. T.V. Narayan, who will be joining us online. So sir is an oral pathologist, but a clinician too. So the entire team is comprised of oral pathologists who are practicing too. So that is the most important aspect. And it's also our proud privilege to welcome two dermatologists here. As I had mentioned, Dr. Anand N. Sir is also, we welcome you onto the stage, sir. He's finished his post-graduation from JIPMER, and he's currently practicing. He has his own dental setup and does a lot of work, research work also, along with a very busy clinical practice. We are indeed honored to have you here, sir. It's also my proud privilege to welcome Dr. V. Vijay Karthik. He's also a practicing dermatologist at the Kaveri Hospitals. He has done his post-graduation from Kasturiba Medical College, Manipal, and he's also a full-time practitioner. And it's also my proud privilege to welcome, as I had mentioned, Dr. Uma Maheshwari and Dr. Aravind M. from our own Department of Oral Medicine to share their insights into this very pertaining topic of, is lichenoid reaction truly an OPMD, and our thoughts on this process. So I hand over the mic to Ranganathan, sir.
Yeah, thank you. Very good morning to you all. Thank you, Dr. Pratibha, for the kind introduction. It's really a pleasure to have our colleagues, Dr. Raji, our colleagues from oral medicine, Anand and Dr. Uma, and Dr. Vijay and Dr. Anand from dermatology. Thank you for having given us this opportunity. As usual, you know, the way this started, I should give a quick history. Dr. Pratibha calls me one day and says, let's do something on lichen planners. I said, yes, we can do. And then it starts like, we can do. And then she says, okay, why don't you give me the questions? And then I get, it's always a pleasure to work with Pratibha. Now, the good thing is, I'm a little bit scatterbrained, so I just give her all the details randomly, and then she compiles it and gives it back. Thank you for that. Thank you for being very patient with me. We are running a little bit late, and our colleagues from abroad are a little bit restless, so I'm going to go through quickly. What I was supposed to do was, let me take a step back. We had about 6 different areas we wanted to focus as far as lichen planus and lichenoid lesions were concerned. I was supposed to give an introduction and actually state the problem and where all the issues are currently as far as these lesions are concerned. Keeping that responsibility in mind, it's not moving. it's on Zoom. Okay, go. Okay, thank you. Thank you very much. All right. These were the 3 questions which I was supposed to take on myself. This was initially 6 questions, and we both sat together and cut it down to 3. And I thought these 3 were also pretty long-winding, so let me just summarize this for you. What I did was split it into smaller bits so that it addresses most of the problems we have. Are oral lichen planus, lichenoid lesions, and lichenoid dysplasia the same lesions, or are they different? If they are different, how do you define them? Are they potentially malignant? What do we think of it currently? If they are potentially malignant, do you have the same risk across the board? And if there is epithelial dysplasia, how do we approach it? Do we treat it like lichen planus or lichenoid lesions with dysplasia, or vice versa? Now, this is an article way back in 2003 by Van der Mage and their group. They addressed this problem way back in 2003. If you see this, sorry about the black square there, they had actually proposed a set of criteria to distinguish between oral lichen planus and oral lichenoid lesion way back in 2003, almost 2 decades ago. And it was very clear. If you look at the box at the bottom, it's a combination of the clinical features and histological features. If both of them are very characteristic, it becomes lichen planus. If either one of them is doubtful, it becomes lichenoid mucositis or lichenoid lesion. It goes by different terms. Different people use different terms. Oral lichenoid lesion, oral lichenoid mucositis, lichen planus-like lesions. You have a wide variety of terminologies. Let's call it OLL, oral lichenoid lesions. So from 2003, now we have the current definition by WHO. It's a chronic inflammatory disorder, and I'm not going to read the entire statement. You're all aware of this definition. Let me highlight the important points. It is inflammatory, probably an autoimmune origin. It's bilaterally symmetrical. These are the 2 most often mentioned facts, and I think our colleagues in oral medicine will agree to that. And that's the basis for treatment and diagnosis, the fact that it's inflammatory and the fact that it's bilateral and symmetrical most of the times. Then you have oral lichenoid lesions which resemble lichen planus. So what are the key features in this? They lack the typical clinical or histological features. These are usually reactive. They are also inflammatory, but not autoimmune like lichen planus, but reacting to something local or to some extent something systemic. They are usually unilateral, but we see cases which are in multiple sites also. And they can usually be resolved by identifying and removing the cause for this problem. And you have a whole bunch of lesions under it, like lichenoid drug reactions, lupus, chronic graft-versus-host disease, chronic ulcerative stomatitis, a more recently described entity, and contact reactions to various agents. So this fall under the group of oral lichenoid lesions. Then what about something which looks like lichen planus or lichenoid lesion but has dysplasia? Where do you bin this? Are these variants of these 2 lesions which we saw earlier, or something entirely new? So this discussion started way back in 1985, and I'm sure those of you who work in this field know Khrushchev's and Eisenberg's article. This was the seminal article. We all go back. It is a pivotal article where this concept of dysplasia and lichenoid lesions came through. So what if you have lichenoid features clubbed with atypical features? Do you call it lichen planus with dysplasia or something else? And they put in the term called lichenoid dysplasia, and they call it a separate entity. So they propose the fact that if there is dysplasia, we're going to call it oral lichenoid dysplasia and not lichen planus or lichenoid lesion. So that was the concept in 1985, widely followed for very many years. Currently, we have this concept. I've summarized all that has happened in the past couple of decades, and we have 3 groups of lesions. The first one is oral lichen planus. It's a chronic T-cell mediated inflammatory condition, typically bilateral and symmetrical, and should not show any evidence of dysplasia. If it shows dysplasia, by definition, it's not lichen planus. Lichenoid lesions caused usually by a trigger factor is usually reactive to something local or systemic, and usually resolves if the trigger is removed. The tricky part is identifying the trigger. And oral lichenoid dysplasia, once again, goes by different names. It's primarily a dysplasia with an inflammatory response to dysplasia. That's what we mean. So these are three separate distinct entities. And this is very important if you're going to understand anything moving on. So lichen planus and autoimmune condition, the typical clinical and histological features. Lichenoid dysplasia, usually a reactive lesion, may look like lichen planus but has its own clinical and histological feature. And any lesion which has dysplasia and an inflammatory reaction mimicking lichen planus or lichenoid lesion becomes oral lichenoid dysplasia or oral epithelial dysplasia with lichenoid reaction. Different people use it in different ways. Is this concept clear? This is the fundamental crux of understanding these three groups of lesions. And this is the current definition from WHO. You can quickly read it. I'm not going to go through that. But what is important is this is a challenge in accurately diagnosing epithelial dysplasia and lichenoid lesions. There are a group of lesions called proliferative verrucous leukoplakia, which in its initial stages, because it's multifocal, it can be bilateral. And because you have plaque-like lichen planus, you can mistake it for lichen planus and the fact that it's bilateral. But it's actually a type of leukoplakia with a high degree of malignant transformation, in the early stages at least. So this can often be mistaken for lichen planus, and many studies have done that. And that is why you get very high malignant transformation rates. And this, the inflammation, the band-like inflammation is secondary to epithelial dysplasia. There is something going on with dysplasia in the surface mucosa, and the tissues reacting to that. In lichenoid lesion, it was a triggering factor like contact stomatitis or some other chemical agent or a biological agent. But here, it is the dysplasia itself which is triggering the inflammatory reaction. So the inflammation is secondary to the dysplasia, unlike the other two lesions where the epithelial changes are secondary to the inflammation. And so this is the great question. In either these two lesions, lichen planus and lichenoid lesions in one group and dysplasia with lichenoid inflammation, inflammation is the trigger, but which came first? In the dysplasia components, the dysplasia was there initially, followed by the inflammatory reaction. In the other two lesions, the lichen planus and lichenoid lesions, the inflammation triggers changes in the epithelium, which you see classically in your histopathology under the microscope. So is this concept clear? So this inflammation and epithelial changes are like the egg and the chicken analogy we draw for so many things. So which came first, which follows? So with regards to malignant transformation, do these actually become malignant? Are they two different groups of lesions, or are they a spectrum? Or is that a fact that when you have chronic inflammation, like we know in the skin in certain contexts, the chronic inflammation triggers off dysplastic changes? This is what is going on. Is this a spectrum? Okay, this is one of the articles which is often quoted, which very clearly says that there is sufficient evidence to indicate that there is an increased risk of oral cancer among patients diagnosed with oral lichenoid lesions. So yes, they do have by themselves a chance of malignant transformation. And that is why if you compare the 2017 classification of WHO to the current 2022 classification, in 2017 you had only lichen planus under potentially malignant disorders. Today, we have both oral lichen planus and oral lichenoid lesions coming under the category of oral potentially malignant disorder. Now, these are a few studies. There are multiple studies, and what I did was just took the Q1 and the Q2 journals and about 4 studies which sort of summarize what exactly we know currently, and this is what I'm going to present today. A bunch of cohorts which have been systematic reviews and umbrella studies and meta-analysis. Let me just summarize them for you. Now, this is the core conflict in oral lichen planus. There is a group which says that no, lichen planus does not become malignant. There's a good systematic review by Kai et al., and I'll show you that so that you can go and look it up. And there are cohort studies from New Zealand and Italy which says that no, by themselves they have a malignant transformation. So the central question is the risk of malignancy intrinsic to lichen planus, or is it because it mimics other conditions which are by themselves potentially malignant? So this is the article by Kai, and this is what it says. In their cohort which they reviewed, there were 10 cases of squamous cell carcinoma and apparent lichen planus lesions. And they found that 3 of them were oral squamous cell carcinoma in different sites from where the lichen planus was. Let's not talk about the field theory now, but that's their contention. And 2 of them, looking back, were actually early proliferative verrucous leukoplakia, which I alluded to a few minutes back. And 5 of them were actually leukoplakias misdiagnosed as lichen planus. And so they claimed that, yeah, what looks like lichen planus becoming malignant are probably those which have been misclassified. And that's why you're seeing the malignant transformation. But what is hard to ignore is these studies from New Zealand and Italy, where they actually follow up lichen planus for long periods of time and show that the malignant transformation rate ranges anywhere from between 2.4 to 2.8%. Why is there this discrepancy? One factor for this discrepancy, in addition to the classification, is the fact that you need to follow these lesions for a long period of time. Now, if you look at it, the mean time for transformation is about 103 months, which is about 8.5 years. Most of the studies follow them up for a few months or for a year or two. They may not become malignant in this short period of time. So, though there is one big bulk of opinion saying that it's probably because they are misclassified, no proper inclusion or exclusion criteria. Another side of the story is if you follow them up for sufficiently long periods of time, yes, lichen planus may have malignant transformation rate. It'd be interesting to see what the dermatologists think, because they see a lot of lichen planus over long periods of time, including our oral medicine folks there. And this is an umbrella study of a lot of systematic reviews which was published recently. And once again, I will not belabor you by reading the whole slide, but there is a huge list of lesions, huge list of cohort from different investigators across the globe who say that yes, there are situations when you use strict criteria, you can still see that lichen planus or lichenoid lesions can have malignant transformation rate, but to a lesser extent. I'm quickly going to read what this summary of this umbrella study is. Out of 8 systematic reviews, the malignant transformation ranged to a max of about 1.5. And he looked at meta-analysis of 10 good quality studies. The transformation was around 2.28%. All these studies highlight one fact. Irrespective of whether it's lichen planus becoming malignant or some other becoming malignant which looks like lichen planus, they all have dysplasia. Whether dysplasia started de novo or it was transformed over a period of time due to other factors is something which we still need to study. And this is one of the recent studies by Lee and his colleagues for both lichen planus and lichenoid mucositis. And if you see carefully, the first bar shows oral lichen planus with a malignant transformation rate of 0.94%, classified correctly. And even if you use strict criteria and call them oral lichenoid lesions, the transformation rate is still 1.95%. Whereas if you take those with epithelial dysplasia and what looks like mucositis, then you see that there's a huge jump in the malignant transformation rate of almost 6.31%, almost 6 times higher than the other 2 lesions. And this summarizes some of the key articles. When you use the strict criteria, the transformation rate is less than 1.14, and probably over many years, 7 or 8 years, if you don't treat them or treat them appropriately. Whereas strictly follow the criteria, yes, and if you strictly classify them separately as lichenoid lesions with dysplasia, then the malignant transformation rate just jumps. So the summary of all these facts is that you need to make sure whether these are lichen planus, lichenoid lesions or dysplasia, which means you have to fall back on biopsies, which means hopefully I answer one question from the oral medicine folks. Do you need to biopsy all sorts of lichen planus? Yeah, probably yes. Unless you have extreme Superman skills and can see into the tissue. You probably need to do that. And the critical factor for this jump in malignant transformation rate is the presence of epithelial dysplasia. And we have some experts going to talk about that shortly. Are there any other factors other than epithelial dysplasia? If I say that, yes, you said lichen planus and lichenoid lesions over a long period of time can become malignant. Are there some other clinical factors? Yes, there are a few clinical factors. For some reason, in some cohort, particularly in Italy, women seem to have a higher transformation rate. Concurrent use of tobacco and alcohol, higher transformation rate. In the Mediterranean regions like Italy and some places like Japan, the presence of hepatitis C virus, higher transformation rate. There are reports linking certain types of autoimmune thyroid disorders with a higher transformation rate. And of course, this we all know as clinicians, certain sites have got a higher risk like lateral surface of the tongue, floor of the mouth, and similar sites. Okay, now this is supposed to be for discussion, so I'm just going to go through this quickly. If you have time, we'll go through this. if you have got the gist of what I have been presenting, are we underestimating malignant transformation? If so, why? Are we overestimating malignant transformation? If so, what is the reason? Is there a difference between studies which are population-based and individual-based in your day-to-day clinic? Can you apply population data to what you do in a clinical data? Is that really applicable? We're always told that individual medicine is different from public health medicine. The criteria are different. The approach is slightly different. And what are the regional variations in baseline risk? I'm just going to read the points and we can discuss this later in the interest of time. The reason for underestimation is criteria, exclusion criteria, inadequate follow-up. Like I said, it takes many years for transformation, and the quality of the study, which is pretty obvious. The reason for overestimation is diagnostic mimicry. For example, proliferative varicose leukoplakia, which in early situations can be bilateral and can mimic lichen planus, and population incidence discrepancies. Like, for example, there's one well-known study which says that if you apply the 0.38% transformation data from the United Kingdom and then apply it to local population, the amount of cancers is way higher than what cancers actually reported from UK. So you can't directly collate population data to individual data and then try to, draw inferences for management based on that. And SIRS, not the SIRS which you're all talking about currently. That's totally different. This is standardized incidence ratios. And when you do that, you see that discrepancies crop up. And individual red flags like red lesions are especially very erosive and atrophic areas, like in planus we normally say have got a higher malignant transformation rate. Specific subsites like tongue and floor of the mouth. And when you compare population against individual risks, habit, especially in countries like India and Southeast Asian, if you use areca consistently, how does it influence lichen planus? Viral prevalence, hepatitis C virus, which I just mentioned, and gender paradoxes, particularly in countries like Italy, there seems to be a higher transformation in women. I don't think there are very many studies doing that in India, so that's a good study to do if you are a student and you want to take that up. And finally, coming to the conclusions, yes, there is a baseline risk in oral lichen planus between 1 to 2.8%. Applies on how strictly you apply the criteria and how long you follow up these lesions. Red and erosive lesions have got a higher risk, and if they have epithelial dysplasia, histologically they have a higher risk. And I like this. Don't get hung up on the name lichen planus and lichenoid lesions. Look at it clinically. And just because it looks like lichen planus is not something which you should not follow for long periods of time. One disclaimer. I made all these slides and pumped it into an AI program and asked it to summarize. These are the 4 points it picked up. Sometimes AI works, I guess. I'm extremely scared of using AI. It picked up the 4 points and I was thinking, how do I conclude? Because like a smart guy said, Pratibha, everybody has to give 4 important points. I was working late last night and I didn't know what to do. So yeah, it's helpful sometimes. Not in diagnosing clinical lesions, but in making slides. Okay, let me stop here and thank you all, and let's hope we have a very good discussion.
Thank you so much, sir, for that brief insight on the controversial topic. I think we can take forward from there. Going on to the next speaker who is going to come online, it's going to be Dr. T.V. Narayan, sir. And the questions which we have actually sought his help was on the classification and the terminology. So what were these 3 questions basically? Where should lichenoid reactions sit within the OPMD spectrum? And should all oral lichenoid lesions and oral lichen planus be considered as a single or one entity or as a distinct OPMD by themselves? The second was, is the term itself very heterogeneous? And lastly, do current WHO or national OPMDs classification actually address a risk stratified consensus is more realistic than a universal definition? I think Dr. Ranganathan sir has already set the ball rolling by giving so many aspects, and it's on to Dr. T.V. Narayan sir.
One second.
I can hear myself.
sir.
Can you hear me now?
Yes, sir.
All right. Okay. Again, thank you so much for the invitation to be part of this symposium, so to say. Pratibha, it's always a pleasure to interact with you, and it's really nice that you involved me. And thank you so much, Dr. Ranganathan, for that fantastic introduction. It actually really sets the keynote literally for what's to follow. And believe me when I say this, we have not interacted at all about what we are saying online out here today. But you will find that a lot of things that I speak resonate very closely with what Dr. Ranganathan just spoke. So without much more ado, I will go ahead and speak to you about what I'm supposed to speak to you about. Before anything, I must pay homage to these three people who have great impact on my way of thinking of a lot of things. And they would have been they would have really enjoyed being out here discussing this, because these were things that they love to talk about themselves. So having said that, let me go and get into the topic proper. So I'm just going to show you a few clinical images and some histopathology here. And this is what we know as classic lichen planus. Bilateral lesions, though you're seeing one side right now, with the striae, the classic striae of the white striae there, and a very lichenoid band-like inflammatory infiltrate restricted to the lamina propria, liquefaction, degeneration, and all of those features that Dr. Ranganathan spoke of as strict criteria for diagnosis of lichen planus. On the other hand, you also see lesions like this, which are closely related to silver amalgam restorations, most of the time unilateral, not only to silver amalgam, but also to porcelain fused to metal. So if you think that you have porcelain there, the metal underneath does the same kind of damage, and that it does cause these sort of reactive lesions. And if you thought that gold is such a noble metal, it does not have such impact. Unfortunately, gold does the same. So with that sort of a lesion, many a time what you see is a lot more of inflammation, a lot more of the zone of connective tissue that is involved with the inflammation. The inflammatory exudate tends to be more admixed. There may be more than just lymphocytes out there, and a lot of neutrophils and so on. But and you may not see the classic features that we described for lichen planus. And these are what we group largely in this umbrella term of lichenoid lesions. And then you have these sort of cases. This is one of, this was a long-standing lichen planus patient. She was being sent to me back and forth from a private practitioner here who was trying to handle it on her own. Eventually, the patient decided she was not, she didn't want to take any more medication, so she ended up with some homeopath. And eventually, there is a transformation into squamous carcinoma there. And so, in my career over the last 30 years or so, I've seen maybe about 15 cases of actual oral lichen planus transforming into squamous carcinoma. So it's not merely in literature, but in clinical practice as well, that we actually see this sort of transformation occurring. So that brings us to the position of oral lichen planus and oral lichenoid lesions in the group of oral potentially malignant lesions. And the oral lichen planus was there in the previous classification as well. Lichenoid lesions were added in 2020. And there are a couple of references out here for you to go back to look at them to understand why the inclusions happened. Having said that, one of the questions that Pratibha had sent me was, where should lichenoid reactions sit in this OPMD spectrum, and should we consider oral lichenoid lesions and lichen planus to be one entity, or should they be distinct? And like Dr. Ranganathan said, the term is, it's very heterogeneous. It's just an umbrella for idiopathic lichen planus, contact reactions, reactions to drugs, reactions to flavoring agents in various these things. But if you look at the transformation rates of lichen planus versus oral lichenoid lesions, different systematic reviews and meta-analysis come up with very, very different numbers. For instance, this one from the on the left-hand side from Akbari's group shows a variation of 1.1% for lichen planus versus 2.5 for lichenoid lesions. So it just does show a uh, significantly more higher risk for lichenoid lesions. Whereas this other one from Spain, from Angel Gomez, Gonzalez's group, shows that they are very similar in transformation rates. So there has to be something that some common ground that we can find to try to understand how to group these in this whole spectrum of potentially malignant disorders. So, as Dr. Ranganathan indicated already, the type of clinical type of lichen planus or lesion, whether it's atrophic, erosive, along with smoking, alcohol, and HCV, all of these increase relative risk, and that's something that's well known. This is an interesting systematic review with meta-analysis from Hong Kong, which again Dr. Ranganathan alluded to. And this is what he was talking about, that the presence of epithelial dysplasia now increases that risk of malignant transformation uh, manyfold. It's about 6 times what it is for lichen planus and about 3.5 times what it was for or lichenoid lesions. So if you start looking at these lesions, there seems to be one common ground that we are arriving at, and that is the presence of epithelial dysplasia and a few clinical features like the kind of the lesion that we are looking at clinically. So when it comes down to taking the heterogeneity of this term, lichenoid region, is it just too heterogeneous for risk assessment, and should we be considering them as distinct diagnostic? Should be considered as specific diagnostic criteria. So, like Dr. Ranganathan said, this lichenoid dysplasia, the term, was described way back in 1978 by Khrushchev, and like he said, we all grew up, with these articles of Khrushchev and Eisenberg, and the inclusion of lichenoid dysplasia as a term, and the debates that have gone on over the years around this term. And personally, I feel that it's something that just adds to confusion as far as these lesions go, and that as of now, there are two groups of people, two schools of thought with regard to using this terminology of lichenoid dysplasia, and I believe that we should discourage that term, and we should not be precluding the diagnosis of lichen planus if dysplasia is present. Instead, we should be precluding the diagnosis of lichen planus if dysplasia is present. Instead, use the term, instead of using lichenoid dysplasia, the term oral epithelial dysplasia with lichenoid features seems to be a more realistic, more uh, let's say, more appropriate term as far as one group goes. On the other hand, there are those who believe that you should not be precluding the diagnosis of OLP if dysplasia is seen. And the reason for this, that once you take away the name of the fact there's dysplasia here, and change the diagnosis from oral lichen planus to something else, you are downplaying the risk of malignant transformation of oral lichen planus by itself. And as Dr. Ranganathan indicated, dysplasia may develop in oral lichen planus over a period of time. And this is something that we've seen if you've followed up oral lichen planus over a long period of time. And so the risk of transformation of lichen planus once you have dysplasia there actually goes up more than 5 times that of OLP without dysplasia. So where does this bring us as far as the current WHO and national OPMD classifications lie? What are the inadequacies in the current framework? The current framework requires that the criteria that are proposed by Van der Meij and Van der Waal, they imply that OLP is a purely benign lesion, and when you have to assign uh, potential malignant potential for malignant transformation, you need you I mean it is all ascribed only to oral lichenoid lesions. Now this is something that most meta-analysis, especially those which have followed up lichen planus over long periods of time, completely refute, which means that at this point, perhaps the strict criteria under which we were making the diagnosis of oral lichen planus would put OLP as a non-potentially malignant disorder. However, we do know that there is enough gathering evidence to show that there is a potential to malignant transformation. So as far as risk stratification goes, we should be looking at a more risk stratified consensus. This is a more realistic and clinically useful way of approaching the problem than based solely on clinical morphology. And if you saw those clinical photographs or the histology, except for the squamous carcinoma, there's very little for you to choose between one and the other to call it lichen planus or lichenoid reaction, unless you have a definite source of an irritation of like the restorations over there, which you could attribute the changes to. But even in many cases where you have bilateral lesions and you have several silver amalgam restorations, it's very difficult to make that call. As far as dysplasia is concerned, I think we have concluded pretty much that the presence of epithelial dysplasia is the most significant indicator of risk, particularly histologically. As far as clinical risk, goes, the better indicators are the site of the lesion, like the tongue, the clinical appearance. Erosive and red lesions are at higher risk. Patients' habits, like smoking and alcohol consumption, and HCV status. Infection with HCV has been identified as a very significant risk factor in malignant transformation in OLP patients. So now comes that question whether we should be separating these entities out or should we be unifying them. And me, as somebody who deals with clinicians, as a clinician myself, I find, that's my alarm to say that my time is up. I find that most clinicians are very confused as to, first of all, with identifying anything. So if you are going to throw different terms at them, saying that there is something known as an lichen planus, there's another thing known as chronic ulcerative mucositis, there's another term like oral lichenoid lesions, they are really not tuned to to accepting that. So if we are able to give them I feel that the best way to get this across clinically to those who come across them on a day-to-day basis is that we should probably look at the context. I mean, in this context of potentially malignant disorders, to try to unify under the umbrella of maybe something like oral lichenoid conditions, but with or without dysplasia, which means that, and like Dr. Ranganathan said, should we be telling our oral medicine colleagues whether we need to biopsy every lesion or not? It will mandate the need for biopsy for all lesions, and then the risk downgradation can be avoided. Because once you do biopsy and you find dysplasia, we know that whether it is a lichen planus or a lichenoid lesion, whichever whichever part of that spectrum it belongs to, the presence of dysplasia makes the risk of malignant transformation manifold. So from the context of getting down to brass tacks and those kind of grassroots clinicians who do not have the training or the understanding of different types of lesions, who really do not delve into literature so much. Perhaps the best way is to try to unify it and put it under one umbrella with this caveat of with or without dysplasia. And I think we will be much better equipped to handle what comes along, because I believe that clinical management should prioritize the risk stratification based on the presence of dysplasia and specific risk factors, rather than relying on these terminological distinctions. This is a few articles that I went through, and I must acknowledge the help of Dr. Shashidhar in sending me some of these articles, because I was at an end as to where to source them, since I do not have any institutional affiliations anymore. Thank you all. That's my time as far as I know. Thank you so much.
Thank you so much, sir. I think we have gone into the controversy per se. You have started with the unified concept, sir. We have certain clinical experiences, like a very known case of a person who was diagnosed with lichen planus of skin, and then subsequent, a very close relative of mine. But she developed laryngeal CA, which was a sort of a verrucous carcinoma, treated by surgery, pull-up surgery, and had undergone tracheostomy, and all the what can I say, the worst quality of life she has had. And 18 years later, she developed a secondary CA in the buccal mucosa, because that was the only one which was left. And subsequently, 1 year later, she had Mets in the lung, and she passed away. The only one instance she had lichen planus was probably the 20 years back. Only one instance. She never had any remission or thing, and the biopsy was, the confirmation of the biopsy of verrucous carcinoma was done pretty late, so with no oral manifestations, but all the manifestations of lichen planus was not even there, and entire manifestation was only in the head and neck region. So what is your comments on this particular such cases?
I think, like Dr. Ranganathan said, that field theory thing is another monster. I think this is one of those unfortunate ones where, I have seen cases like this, right? Diagnosed with oral lichen planus for years together, lichen planus, multiple biopsies. At some point, there might have been dysplasia, which was not obviously not reported at that point in time. And eventually turning into squamous carcinoma, maybe 18, 20 years after the first diagnosis. But this, this relative of yours, that's a very unfortunate this thing, because it does. I guess that's one of those where
Sir, the
it
thing
just
here
gets
is
away.
she was anemic. Do you think so? What I'm trying to get in here is her is other systemic factors. Like, I feel anemia, as sir had very correctly mentioned, studies should be on, especially in women, and long-standing anemia. I think at some point of time she had hemoglobin levels of 5-4, for which thing. post which I think she developed the second recurrence. So do you think in
Yeah.
this part of the spectrum, when we are dealing with case like lichen planners or lichenoid reaction, whatever terminology we use, do you think the role of the of assessment, general assessment, is paramount important?
Course, of course. And then, we also must understand that 15, 20 years ago, people were not looking at things like HCV. What was her HCV status? Because that would again increase the risk of squamous carcinoma in a patient like that. So we really do have, if you start to look at cases like this, the number of different factors that have gone into the development of tumors of this nature uh, are very difficult to enumerate. But yes, I think there has to be some kind of impetus towards looking at other systemic factors like nutritional deficiencies and anemias and so on in all these patients to see if there are other aspects uh, of risk that are involved in this.
Any other question from the audience? Dr. Dinakar.
Good morning, Dr. Narayanan. I'm Dr. Dinakar, Principal, Ragas Dental College, and a proud student of Dr. Ranganathan, sir. You're a practicing implantologist added up along with the oral pathology, so I think this will be the right question to you. Like, see, as a practitioner, we get a reference from other friends after a implant, just adjacent to the implant, there is a lichenoid or lichenoid reactions like lesions. And
Yes.
most probably it is after the placement of implant, maybe a year or two later. So it's for the person who is referring, they have placed the implants like that. So we cannot put the blame directly on the implant like that. So we always suspect that it could be the reason. So how to go about as a practitioner, your inputs for that?
It is. So I mean, we've been, fooled to believe that titanium is this brilliant material that nothing happens around titanium. And in fact, I do believe that we are going to look at one explosion of titanium related pathologies in the years to come, because the last case that you saw in those the photographs that I had posted right in the beginning, that case turned into a squamous carcinoma after an implant was placed, right? Pardon me? Can you hear me? I can hear somebody else speaking in between someone. Anyway, so that was that transformation happened after an implant was placed. A lot of things that are involved here, which are actually beyond the scope of this particular meeting. But yes, there are the metallurgy of implants, the kind of the kind of alloys that are used, aluminum and vanadium. Are all, and titanium particles are found in epithelium around implants, the mechanical wear, the tribocorrosion that takes place. All of that can lead to these sort of thing. And in Ghaziabad at the last national conference, just as I was leaving, Dr. Ranganathan alluded to particle induced carcinogenesis. And I do believe that the squamous, that particles of titanium and these alloys can lead to similar reactions, and eventually it's finally irritation, and eventually can turn into carcinomas, if any. There are lots of reports of squamous carcinomas around implants now.
Thank you so much, sir. I hope you are in the loop. We will move on to the next speaker, Dr. W.M. Tilakaratne, sir. We are really honored to have you, sir. And sir, we have asked him three questions which are more pertaining to histology and histopathological aspects. So the questions were, can histopathology alone reliably stratify malignant risk in lichenoid reactions? And how should dysplasia be interpreted when it occurs in a lichenoid background? The second question was, when epithelial dysplasia is present in a lichenoid background, should it automatically place the lesion in a high-risk OPMD category or just an inflammatory artifact? Lastly, how should we address diagnostic challenges, including masked dysplasia, inter-observer variability, and conflicts between clinical and histological diagnosis? We are indeed honored to have you here, sir, as I'm sure you were a part of this discussion in WHO, which had included this particular lesion in the OPMD, and we are truly honored to have you here, sir. Thank you so much, sir.
To Dr. Pratibha, let me share. Can you see my screen? Am I audible?
Yes, sir. Yes, sir.
Right. Okay. I think I'll be very short. I think most of the things that I was thinking of talking about, I already mentioned.
Sorry to interrupt, sir. Can you please change to full screen mode?
You can imagine the difficulties that we had when we were doing the WHO classification from the two talks that you already heard. Now, please remember when I say things, the WHO classification, although three of us did it together, they are consensus opinions, not necessarily individuals on individual basis. Three of us agree for every single thing. If you ask me in this context, in relation to oral lichenoid reactions and oral lichen planus, some of the things that I believe and practice over the years, although there are controversies around the world, lichen planus, there is a cohort of people who do not believe lichen planus is pre-malignant. If you ask me whether I believe, I do believe lichen planus is pre-malignant, but not to the extent that people think, much less than that. So reasons for that already mentioned, because of the heterogeneity of the studies and poor selection criteria, etc. And I do believe both lichen planus and lichenoid lesions that we included this time as an OPMD, they both transform in varying degrees into oral squamous cell carcinoma. And also, I do believe lichenoid dysplasia is not an entity. We don't encourage, we don't teach our students, the postgraduates, on lichenoid dysplasia. They are merely dysplastic, truly dysplastic lesions with lichenoid infiltrate. So what we need to remember is the no sooner we see dysplasia in a lesion, whatever the label that you are going to give, it becomes OPMD. So that is the reality. And the problem is now even the criteria that are put forward by different groups. We know the three things that we use, most people around the world use, are these three studies, right? WHO Collaborating Center classification in 1978, and Vandermeerje and our friend Van der Waal, etc. In 23, and the American group, our friend Susan Muller and others. So those three studies, the articles clearly describe what are the features that should be there to diagnose lichen planus or lichenoid reaction. There are clinical criteria, there are histological criteria. Remember, you can never ever diagnose lichen planus or lichenoid reaction. If you do so, you might by chance may be correct, but you are bound to get it wrong. So therefore, diagnosis of this group of lesions, actually as Dr. Narayan said, that this group of diseases, lichen planus, lichen lesions, graft versus host disease, I call them as lichenoid diseases. So if you do not get the clinical and histopathological together, you're bound to get it wrong, right? So therefore, most of these issues can be solved, whether it is research or diagnostic, if you get this diagnostic criteria, both histopathological and clinical together. In other words, if you get the diagnosis out of clinical pathological correlation, I think most of the time we can get the correct answer. But however, now you all know, even in the WHO classification, and also these two last publications, they say something in relation to dysplasia. The presence of dysplasia is an exclusion criteria to diagnose lichen planus, which we have argued enough on this aspect. But you need to remember one thing, you can't have both. You can't say OPM, oral lichen planus is an OPMD, and at the same time, one cannot accept the fact that presence of dysplasia is an exclusion criteria. If it is OPMD, as both previous the Ranga and Dr. Narayan said, if it is OPMD, if it is undergoing malignant transformation, at one time, one day, it should get dysplasia, right? So if you are going to exclude the presence of dysplasia as exclusion criteria, then I don't think we are scientifically correct. Then altogether we should drop lichen planus from OPMD list. They are my personal ideas, please remember. And of course, again, this was alluded to. Now, if you have clinical picture on your left side, like this reticular pattern and, you know, all the white striations, etc., and supplemented by the histology, we know all characteristic histopathology, band-like lymphocytic infiltrate, associated apoptosis and liquefaction degeneration of basal cells, etc. Now, if those things, together with this clinical picture present, we know it is lichen planus. So the problem is, some lichenoid lesions can present like band-like lymphocytic infiltrate, right? So that you need to remember. That is why we need to have a clinical pathological correlation. Now, on the right side, if you see there's a large amalgam filling, there's a white lesion, so we know it is a lichenoid reaction due to amalgam. And again, we have textbook criteria, but textbook criteria are not present in everyday reporting life. Now, you can see the immune infiltrate. It is, in the case of lichen planus, it is purely lymphocytic in classic cases, but here it is a mixed infiltrate, mostly lymphocytes and plasma cells. Remember, plasma cells. Now, these plasma cells are not only present in the upper corium, but they are present in the lower part of the corium, especially around vessels. Now, if you have that perivascular plasma cells and other attributed features of lichen planus like, so they are more lichenoid lesions, right? So not all lesions, or majority of lesions follow this pattern. So that is where the problem is. That is why our selection criteria should be very strict and stringent, especially when you try to follow up these patients in order to find malignant transformation. That is why the previous speaker said these studies are very heterogeneous. Yes, that is the problem we had when we tried to come up with the malignant transformation rate of lichen planus and lichenoid reactions. The studies are very, very heterogeneous. Not only that, there are a lot of lesions, diseases, identifiable, definable diseases, which can show lichenoid features like proliferative varicose leukoplakia. One thing that you need to remember, at one stage, don't be surprised when you do the biopsy and send to the pathologist and biopsy report comes as lichen planus. After some time, the patient starts developing a lot of lesions, then only both clinician and the surgeon think, the pathologist think, yeah, it is a wrong diagnosis, now it is PVL. And lichenoid reactions, discoid lupus erythematosus, graft versus host, chronic ulcerative stomatitis, true epithelial dysplastic lesions, mucous membrane pemphigoid, all these lesions at least one stage can look like lichen planus, right? So you see how difficult and complicated and complex the problem is. Now, this is what at the moment acceptable, depending on the literature, not very refined literature, very heterogeneous literature we have. Lichen planus, malignant transmission is around 1%. I would like to believe it is even less than 1%. And lichenoid lesions, it is definitely more than lichen planus. So one thing that I believe is malignant transmission potential is there in lichen planus, much less than lichenoid lesions, but the idea, the opinion that some people have that lichen planus never transform into malignancy is something that I do not believe. The questions that were posed to me: can histopathology alone reliably stratify malignant in lichenoid reactions? Answer is a big no, right? So actually, the both previous speakers mentioned what lesions are high risk, right? As I showed you earlier, there's a big histopathological overlap, not only with lichenoid lesions, like lichen planus and lichenoid reactions or lesions, but also with some other lesions, right? So therefore, histopathological overlap is a big problem. So therefore, please remember, histopathology alone is not enough, right? Not enough. You need to get the clinical factors, more importantly. Clinical factors, mostly the risk habits, location of the lesion. Usually there is lichenoid lesions or lichen planus. The tongue lesions probably have a high chance of transmission according to what is available to us in terms of literature. And the clinical appearance that also mentioned, the ulcerative erosive lesions, whether it is lichenoid or lichen planus, have a high chance of transmission. So therefore, when you get the biopsy report, so unless I have the 100% good proper history, clinical history, I will never give the bottom line diagnosis lichen planus or lichenoid reaction separately. I always tell, because histopathological features can be similar in both these lesions in the majority of cases. Therefore, we pass the ball to the clinician saying these histopathological features are consistent with either lichen planus or lichenoid reaction in the appropriate clinical context. That is the most important one. So the clinician should compare all the bilateral lesions, no history of drugs, no amalgam fillings. Now we know in the context it's lichen planus. Now we have similar histopathological report, but patient has known amalgam, the obvious amalgam or other restorative material filling, or it has the history of medications which can cause lichenoid lesions. So then you know whether it is lichen planus or lichenoid reaction. But when it comes to malignant transmission rate risk, please don't assess it only by histology. You need to think of the other clinical parameters, especially the cases with mild moderate epithelial dysplasia. But if you have a case with severe epithelial dysplasia, irrespective of the clinical features, the sites or the habits, we know that has a much higher chance of transforming into cancer. Now, there are a lot of systematic reviews, the follow-up studies, etc., on lichen planus and lichenoid reactions. Even this one, now our friend Gonzalez Moltz and his group, they have done a lot of work on this lichenoid lesions. So what they have shown is also what we have been discussing, the previously two speakers and also myself. The malignant transformation risk factors, they identify as tongue, the location, that is something that I believe. And the atrophic areas, erosive areas, yes, correct. And the risk habits like tobacco, alcohol, betel quid, chewing, etc. When they have those things, and also hepatitis C virus infection, when they have risky habits or risk-related factors, these, in addition to epithelial dysplasia, the chance of malignant transmission definitely can be higher in those patients, right? So that's something that we need to remember. Risk assessment should not only be based on histopathology alone. This another study, I think this paper was shown earlier, and again, it shows the same thing. All the findings that are here, because the same authors, are very much similar to the previous one, and it shows lichenoid, lichen, lichenoid reactions and lichenoid lesions have a much higher transmission than lichen planus. And also, now the problem is they have looked at studies taking into account lichen planus with dysplasia, lichenoid lesions with dysplasia, and without dysplasia also. But only thing is, now that kind of studies are very sparse. That is what we need. In the last slide, I will show you how we should plan a multi-center, multi-country research. And how should dysplasia be interpreted? When it occurs in a lichenoid background. How should dysplasia be interpreted when it occurs in a lichenoid background? As I said, it's very important to interpret the clinical-pathological correlation, right? So that's very important. And whenever you see dysplastic changes, now please remember that should not be disregarded them, assuming that they are merely reactive or inflammatory changes. So that's very important, right? So that is something a lot of people tend to do. Dysplastic changes are disregarded, thinking that they are inflammatory changes. But if they are reactive or inflammatory changes, the experienced pathologists most of the time can recognize them, right? True dysplasia is not very uniform. You have the abrupt changes, you have multiple patterns, etc. But inflammatory changes are usually, you see, restricted to the inflammatory area. It disappears when inflammatory area stops. That kind of features are very helpful to decide whether it is inflammatory or whether it is true dysplasia. Now, one thing that you need to remember is absence of basal cell degeneration in a lichenoid lesion may suggest that is true dysplasia. So if there is no basal cell degeneration, that we cannot diagnose as lichen planus or lichenoid reaction, that is probably a lichenoid looking lesion having true dysplasia. So therefore, this is the exercise that one has to do very, very carefully. Right. Then another question posed to me: when epithelial dysplasia is present in a lichenoid background, should it automatically place the lesion in a high risk OPMD category, or could it represent inflammatory artifact? Now, I think I alluded to that. Now, whenever epithelial dysplasia is present, whether it is a lichenoid background or not, so it becomes OPMD, right? OPMD, and also we know with the present current research that we see, it is the presence of dysplasia which is important, not the degree of dysplasia, right? Because any degree of dysplasia can transform into cancer. So therefore, what's important is to identify whether there is dysplasia or not. It is a critical decision, right? So if those people who have read the Oral Cancer Prevention Handbook by IAC, WHO, so I have produced a diagram on dysplasia, complexity of dysplasia management. I advise you, because that book can be downloaded freely from the IAC website. Please look at how difficult this management of dysplasia is, right? So I have given a schematic diagram explaining the complexity of that. how should we address diagnostic challenges, including mass dysplasia, interobserved variability, and conflict between clinical and histopathological diagnosis? Now, I will start from the bottom. Now, the conflict between clinical and histopathological diagnosis. Now, this happens, as I said earlier, when we do not have the correct clinical pathological correlation before signing out the report. Now, before you sign out the report, whether they are dysplasia or not, whether it is lichenoid or not, please get all the information possible, if possible, the clinical pictures. I usually entertain all the clinicians, our oral medicine, oral surgery colleagues to send the clinical picture to the pathologist. And he or she, together with the history that you provide, can come to the histological diagnosis correctly, right? So that's very, very important. And also we know the inter-observed variability is a big problem in dysplasia grading, right? So we have done a lot of work on that area. And even now, a couple of my research projects are on that. And we did looked at how we can reduce the inter-observer and intra-observer variability in two national studies. We did it taking all the reporting oral pathologists in Malaysia and published. You can read it in the Journal of Oral Pathology and Medicine. And also we have just completed one study taking all the oral pathologists in Iran to one study. And what we did was we calibrated the pathologists. So that is the best way to reduce inter and intra-observed variability. I advise the professional bodies on oral and maxillofacial pathology in different countries to embark on calibration studies. Now, we have shown the kappa values improved drastically for both WHO grading as well as binary grading after calibration. So that is the way, only way, one of the ways in which, one of the most important ways in which we can reduce inter and intra-exam variability. And also you can do this within the departments. Now, not all oral pathology departments in the world practice in that. Never send a dysplasia report out without having consensus with the other colleagues in the department. So then you calibrate yourselves at least within the department. When one day when you try to look at what the diagnosis between pathologists, if you are in the same department, you should have more than 90% agreement, right? Otherwise, it's not acceptable working in the same department. So that will happen if you look at just briefly in few seconds, so a couple of minutes, every single case of dysplasia that you report into observed variability that can be avoided, so you can come to a very good agreement, right? So I think mass dysplasia or inflammatory dysplasia, I told you how to diagnose. So the true dysplasia have in most cases multiple distinct patterns. So that is a very important thing to decide. Yes, this is true dysplasia. And also the abrupt patterns is a common thing in dysplasia, not throughout the length of the epithelium. If you look at, you will, in most cases, you will see different grades of dysplasia or different histopathological features. So that way, you can definitely identify whether it is reactive or inflammatory changes or true dysplasia. Now, in short, if you want to stratify the risk of dysplasia, again, I'm reiterating, degree of dysplasia is very important. If severe the degree of dysplasia, higher the chance of transmission, it's a red flag. And the abrupt transition from dysplasia to no dysplasia, again, some dysplastic looking areas, etc. So that is again I open to tell you that it's a true dysplasia and going to transform. And of course, the location of the lesion, as I said earlier, and habits, etc., they are very, very important, right? So the and also this one of the diagnostic challenges is as we were discussing, this degree of dysplasia, variability, etc. Now, I advise to do targeted biopsies when you are following up patients and use adjunct agents, the well scope or tolidine blue or something. And also, if you have facilities, at least do one immunomarker like P53, because P53 will most probably tell you it is dysplastic rather than reactive. And also the review among the pathologists in the department and calibration again is very, very important. Finally, for future, this for the future, right? So if you want to solve this problem, never-ending problem of lichen planus, lichen lesions, whether they are OPMDs or not, whether there is true dysplasia or not, I think we need a very good study, very well planned, prospective study, like the study that India did long time back in the Trivandrum study on OPMDs. So we need a long-term study of that nature, having different samples, different groups, right, different cohorts. Now, this is one example where you can plan a study. You can have 6 different samples, sample of lichen planus, clinically and histologically proven. Remember, clinically and histologically proven without any ambiguity, without dysplasia. And that you can divide into 2 with habits, without habits, right? So then sample of lichen planus, clinically and histologically proven with dysplasia here, with habits and without habits, right? So we are addressing all corners of these diseases if you have that kind of samples. And the similar sample for lichenoid lesions and lichenoid reactions with dysplasia and without dysplasia, with habits and without habits, right? Then sample of conventional dysplasia with lichenoid infiltrate, with habits and without habits. And then last one, the sample of conventional dysplasia without lichenoid infiltrate, with habits and without habits. If you try to match most of the factors possible, I think the study will become even more valid. If you can age match, you can site match, if you can the gender matched, and if you can the dysplasia grading matched, I think that kind of a illustrative study will answer most of the questions that we have no answers with at the moment. Right. With that, I'll stop because time is a factor. Thank you very much.
Thank you so much, sir. I have Dr. G.S. Kumar, sir, who has a very pertinent question, sir, please.
Sorry, I'm out of touch with the subject for more than 6 years, so I may kindly be excused if it's a very fundamental or... Okay. So, it was my dissertation study as well, way back in 1984. So, we observed the atrophic epithelium and the antivision correlation, which was very important. Then the second thing is, there were few studies of eosinophilic infiltrate and mast cells in lichenoid reaction being very allergic reaction. In third, in all my studies, I never, between skin and the mucosal lesion, I never found sour tooth ridges. I never found a typical band-like infiltrate in all my cases. If it was ulcerative, it was all dispersed, and plasma cell was an usual accompaniment along with lymphoids, with lymphocytes in my infiltrate. So these small observations, I think we should go on to some markers to identify between these two conditions. Basically, we have a lot of problems in oral pathology, giving a proper name. That's what really matters. And degree of dysplasia is well known and should be appreciated. And I would play more emphasis on variability in cell size and nucleus than basal cell degeneration, in my opinion. Thank you.
Sorry, Pratima, I really didn't understand the question because it was breaking. Can you just ask me
No,
the
sir, it's only
question
a
that he
comment,
asked?
sir. It was only a comment, sir. It was not a question. It was only
Ah,
his.
yeah, right. All
Yes,
right, all
sir.
right. It was breaking.
Yeah,
Right, all
yeah,
right.
yes, sir. Yes, sir. Thank you so much, sir. Now, going on to the next speaker, Dr. Rajiv Desai, sir. I think sir has the questions on his own in the slides, and I'm not taking much time and giving the mic to sir.
Now, I am doing lichen planus since my PG days, 1992. And this controversy is not changed only. Since Erasmus Wilson, he did it in 1869, and Montgomery did it in 1924 when he reported first case of cancer in lichen planus. तब से अपन उसको चबा ही रहा है. You know what I'm trying to say? Now, I'll be very honest. I will not go with literature. I was talking to Dr. Ranganathan just now. People talk about evidence, evidence, evidence. But there is no true evidence of evidence-based studies. If you tell 10 liars together, that lie becomes a truth. So I want you to believe in your personal experience. I will not say this side or this side, both sides. My side is very, very clear. So they are the clinical pictures. You say how many cases I've seen? Roughly about 1,000 cases. पहला तो मेरा problem lichen planus इससे है कि we have seen, I have not seen very few true lichen planus like what dermatologist says. And if you read literature, they say 50% of the skin lichen planus shows oral manifestation, but 15% of the oral lichen planus shows skin manifestations. I don't know how to interpret this. That's one. Second, for me, most of the cases are oral lichenoid drug reaction. Most of my patients, I'll say 80% of my cases are associated with diabetes, blood pressure, thyroid, etc., etc. And we assume that these lichenoid drug reactions causing these lichen planus-like lesions. Now, ideally speaking, we cannot stop those drugs and say it has gone back, like amalgam removed, and lichen planus become normal. It's empirical. सोच लिया है अपन ने कि these drugs causes lichen planus, and we said एक और नया नाम दे दिया lichenoid drug reaction, but we treat them as the same. So my say is very simple. True oral lichen planus is not potentially malignant. I wanted to say this since last 32 years, but I never got guts. But lately, we put this article in our journal. I've sent this same article to oral diseases. I got approved till R3, and this article got rejected. And I don't want to name it, I don't want to show something. The same person has written, Dr. Shivpat Sundaram has written, sir, a note for this, and that person has said, very good over there. And he told him to, why don't you cite my article in that? So, for me, classical oral lichen planus is not malignant because, I'm telling very confidently, I don't believe in selling fear. I don't tell patient को तो मालूम भी नहीं रहता है कि potentially malignant होता है. वो तो बेचारा आता है तुम्हारे पास किसके लिए खाना नहीं खा सकता हूं. I cannot eat hot food, salty food, etc. मेरा काम है उसको अच्छा बनाना. लेकिन you put in his mind, these can become malignant. हो गया बात. So, one, I wish you. I've taken my sides in 32 years. Why? I believe in quotes, so my presentation is रहेगा. As a rule, men worry more about what they can't see than about what they can.
you are reading this from Google, he says, humans tend to overestimate risks when they cannot clearly identify them. The absence of information allows the imagination to fill gaps, usually with negative assumptions. You know what I'm trying to say. Now, third point. बहुत अच्छा था मेरा टाइम 80s में OPMD था ही नहीं दो नाम था पोटेंशियल मैलिग्नेंट लीजन स्पेसिफिक निकाल दो काम हो गया मेरा पोटेंशियल मैलिग्नेंट कंडीशन में कुछ नहीं कर सकता हूं लोग बोलते हैं बायोप्सी लेने का लाइकेन पेनिस से एसएमएफ से किधर से लूं राइट बकल मिकोजा लेफ्ट बकल मिकोजा टंग फ्लोर जिंजाइवा एंड हाउ मेनी टाइम्स एंड फाइनली दे आस्क वन क्वेश्चन तुम्हारा कितनी बार लूंगा मैं एंड आई शुड नॉट आई एम यूजिंग वेरी अनसाइंटिफिक वर्ड ओवर हियर बट ये घड़ी घड़ी बायोप्सी लेके तुम क्या उखाड़ लेगा what you if that thing is going to become cancer are you going to prevent it my question is that मेरा और एक क्वेश्चन है तुमको ये मेरे को क्वेश्चन पूछते हैं मैं 25 साल से क्वेश्चन पूछता हूं मोर क्वेश्चन देन आंसर्स whether to treat asymptomatic oral lichen planus or not I don't know the answer I don't know now the problem is what so I have raised the issue in oral path this gentleman Constantino editor has come out with one more new term मतलब कायकू इतना कम टर्म्स कम है क्या अपने को डेफिनेशन याद रखने के लिए और एक टर्म आया the problem for all of us is what John Mayer said Keynes said once the difficulty lies not in the new ideas but in escaping the old ones अपने को जो बोला गया बस बिलीव करते जाओ करते जाओ करते जाओ वो लोग ने ओकेसी को केसीओटी कर डाला और केसीओटी को वापस ओकेसी कर डाला if they can do this why they cannot remove OLP and make it normal if they say OLP is a minimum chance of undergoing malignancy why don't you remove it you want to put oral lichenoid lesion oral lichenoid dysplasia have no issues but why you want to blame एक क्लास में दो डफर रहेगा you won't call whole class डफर no so पूरा उसमें दो लीजन malignancy हुआ you won't call the whole lesion pre-malignant but the problem क्या है वो लोग ने बोला ना इसके लिए so personally for me there is no controversy because I have a strong objection for the same ये मैंने एयरपोर्ट पे लिखा है रंगा was asking me क्या मेरा नोट्स है मेरे को टाइम नहीं मिला ये मेरा फ्रस्ट्रेशन निकल रहा है 32 साल का so sorry I'm aggressive I feel there are people who love controversy probably they don't want the controversy to end only probably I should not again it's offensive but they enjoy it वही उसका वरना सब धंधा बंद हो जाएगा personally I have made a peace by not blaming true OLP as OPMD and I have succeeded in 35 years you ask me how many cases I have seen I've seen up till now only 200 cases of which one was having habit and one was an 80-year-old lady without habit so if something through your so-called OLP undergoes malignancy I will put it as a malignancy without habit baat khatam we got habit and non-habit over there so thank you once again Pratibha where we are I think Ranga sir also has raised the issues if I'll ask you how many leukoplakia have you seen many how many lichen have you seen many how many SM have you seen many how many you followed where you followed sir and how many have undergone तुमने कितना देखा है इधर सीनियर बैठा है कि how many lichen planus undergoing malignancy you have seen in 10 years 15 years so we have to create data remember that much आज data ही बात करेगा publication ही बात करेगा and I'll just we have done a study low prevalence amalgam भी बदना मत करो okay rubbish what we need is this we all speak in different languages इधर तमिल उधर महाराष्ट्रन उधर किधर हिंदी etc this is the need of an hour if you really want to do it all O should sit together and come out with uniform universal pro forma we should speak what I'm talking oral medicine person supposed to understand what I'm talking that's why this confusion is created So please, if someone wants to really work on it, work on, I'll say WHO also should work on OPMD universal proforma. I'll tell you what I do. In my clinic mein lagaya maine. That's my clinic. I've written over there. Please don't Google. That is also in all different languages. Urdu bhi hai usme. Because they come. I have my proforma. I'll tell you what I wanted to share when Pratibha said, I don't want to go what people said, I want to share what I do in my practice. That's my proforma. For me, stress is very important. Sleep is very important. And nowadays people talk about sleep and stress in psychosomatic disorders. My first thing is sleep. I don't know how many believe it. And we did melatonin. That's my proforma for the steroid. Even if I get topical steroid, take proforma. I take sign. Photographs के लिए भी sign. ये सबका sign है मेरे पास. ये मेरा patient को no one knows how to apply it. ए लगा देना दिन में 2 बार 3 बार कैसा लगाने का, खाने का, पीने का, क्या क्या करने का, किसको have you given ears to your patient with lichen planus? They need ears. वो लोग को तकलीफ है. I don't know what taklif they have. That's what you need in oral lichen planus. You have to give ears. So that's English, Hindi, all the languages what we do it over there. That's oral steroid when you do it. One of the most common, remember that much. One of the most common side effect of topical steroid is angina hemorrhagica bullosa. Remember, patient बोलेगा कभी-कभी कि खून आता है और निकल जाता है. So one of the common side effect of because atrophic epithelium, okay, the dentist का wife है. So what oral pathology like lichen planus has taught me in 35 years. It has taught me our life is much beautiful. It taught me empathy. It made me humble. अपना problem उसका सामने कुछ नहीं है. That's what lichen planus taught me. Remember that much. Yes. Pratibha has given answer. Question to me, which lesions are dangerous? I said, everyone has said, habit, babit, etc., etc. Tongue. But lichen planus occurs more on buccal mucosa, on gingiva. I have not seen a single case of gingival cancer. I'm talking about personal experience. I don't believe in others, you know. So, for me, for the students, my favorite slide, which I have not made it, Buddha says, do not believe in anything simply because you have heard it. Do not believe in anything simply because it is spoken and rumored by many. Do not believe in anything simply because it is found written in your religious book. Do not believe in anything merely on the authority of your teachers or elders. Do not believe in tradition because they have been handed down for many generations. But after observation and analysis, when you find that anything agrees with your reason and is conducive to the good and benefit of one and all, then accept it and live up to it. I don't want to be intellectual bankrupt. That's the term which Nassim Taleb has written in a book called Anti-Fragile. We should not become intellectually bankrupt. Use your brains, what you want to apply. See here, I am not saying, this is my opinion. To prove or disprove, you have to work in your way. So at the end of the day, true lichen planus, I don't believe. One more thing, biopsy is necessary. 2 reasons. वो display जाएगा तो बात ही बात है. नहीं आएगा. But my whole problem is, पहला, court of law. Patient can take you to the court के मेरे को बोला क्यों नहीं? अपन क्या लगा क्या लेने का? No, that's one. Second thing, for the long term, किसी ने 15 साल उसने किया है, follow up, then I would like to know what was the picture before 15 years before that. So, biopsy is important. 2. Third, biopsy is important because suppose patient को cancerophobia है, तो patient को तुम बोल सकता है कि आज तुमको कैंसर नहीं है. That does not mean तुमको कल कैंसर नहीं हो सकता है. That's what you tell patient. That's what you take them in confidence and make them life by making them eating good food. So my take, lichen planus is not potentially malignant. बाकी का जिसको biopsy, dysplasia, because they're totally different ball game. Okay, so thank you very much for this.
Thank you so much, sir. I think that has given, as always, a different perspective, and It is, I think the practical point of view has been very much addressed here, and I'm sure the two dermatologists there were enjoying the session as much as this, because knowing them, they are in the same mindset too. So I'm just handing over the two questions to our dermatologists, Dr. N. Anand and Dr. Vijay Karthik, who will probably take on the same stride or is going to have a different point of view.
No. We like the listen to this wonderful controversy which goes on. I wanted to quote something before that. He quoted Buddha. I want you people to understand two things. This is for the students here. I know you're getting so confused. Let me put it in this way. First thing you have in scientific research is a dogma, and the second thing you have is called a confirmational bias, trying to prove that the dogma is right. Right? The dogma is oral lichen planus is pre-malignant, and to confirm it, you bet so many things, but keep saying it could be the amalgam, it could be this, it could be that. Let me put it very straight. I will tell you what is lichen planus so that you understand the immunology of lichen planus before knowing what it is. Right? Lichen planus is a T cell related disorder. Let me be very clear. It's a T cell related disorder. All are agree. Right? So lichen planus of mouth is related to lichen plane of skin. Yes or no? Yes. Different statistics, different. Let's forget all those things. Lichen planus of the skin is traditionally self-limiting, clears by itself. Yes? So why not lichen planus of the mouth? Right? Now we come to the different part of it. Thank you, sir. Can lichen planus of skin become malignancy? It can become in a very, very rare circumstances of a hypertrophic lichen planus, which is primarily not a lichen planus, it's some prurigo nodularis, which is eventually turned malignancy. So in heart of hearts, when patient with skin lichen planus comes, we tell them, look, you can get lost, this is self-limiting, we'll treat you, go. That's all. When it comes to oral lichen planus, Dr. Joshi put this thing about Googling. I'm sorry, patient has already Googled before coming to you, so it's too late. It's too late for you to give a notice, right? Okay. So now coming to the biopsy. So do you know what are the factors for leukoplakia? The 5S. Yes? Please rule the 5S. The first is sharp teeth, syphilis, spice, which is panparag, etc., smoking, and sepsis. When I say sepsis, I mean microbiome. This is the very, very important topic, oral microbiome causing lichenoid dysplasia, right? So before you do a biopsy, this is, please listen, before you do a biopsy, don't do the biopsy in first sitting, first day. Please give a course of metronidazole and antifungal. Wait for 10 days, 15 days, then do the biopsy. Please do that. You do the biopsy on day 1, it will show some dysplasia, and anybody from Sri Lanka to Malaysia to United States can say this is oral lichenoid deaction going into dysplasia. Please understand that. True lichen planus, there's a 50% chance will disappear in 15 days time with this itself. Okay. Next is, this is the confirmational biopsy. We say that oral lichen planus is pre-malignant. Then why did you say that asymptomatic lichen planus need not be treated? This is a big controversy, right? On one hand, you are saying it's pre-malignant. On the other hand, you are saying you don't have to treat asymptomatic lichen planus. So that means symptomatic lichen planus is not lichen planus. Simple. That's all. So there is something beyond that. Third, let's come, since you are a pathologist, let's talk about histopathology. This controversy started in 2016 when the American Association of Oral Maxillopathologists said we don't agree with WHO. We don't want to agree with WHO. We are going to give a new view. If there is dysplasia, it is oral lichenoid dysplasia. It's not lichen planus. If there is a deep dermal inflammation around this thing, it is not lichen planus. If there are eosinophils, it's not lichen planus. If there are plasma cells, it's not lichen planus. I agree. As a dermatologist, I agree to all of you saying yes, because it doesn't happen in skin. When we see a lichen planus, I am a dermatopathologist by the way, so I see many slides, and I've seen more than 50,000 biopsies till date, so don't worry about that. Okay. So when you see this biopsy in cutaneous, the only difference you have to remember as oral pathologist is in skin, lichen planus does not show parakeratosis. Whereas in oral mucosal lichen planus, you will get a parakeratosis. It's very obvious the turnover rate is very high, so you will get parakeratosis. So here is the reverse. If you don't see parakeratosis in a lichen planus in the mouth, then you start suspecting something more. It is not. Why parakeratosis is not there? Smoking, what does smoking do? It reduces the parakeratosis, makes it more. The mouth starts resembling the skin. It doesn't no longer resemble oral mucosa. So once you don't see the parakeratosis, you know this is not LP, this is something else. Second, yes, we agree, liquefactive degeneration, a big question mark. Civet bodies are seen only in 13 to 20% of oral mucosal biopsy, whereas in the skin, it is very, very high. So here, it's not a marker, it is difficult. Liquefactive degeneration, yes, you see a liquefactive degeneration, you see a star-toothing, and then you won't see melanin here because it's different here. It's not easy to see the melanin, but if you see the melanin, you know it is a lichen planus. Now comes the problem, the conformational bias. The patients, you have assumed that the patient with oral lichen planus has no other habits. That's a big problem. Now if he has some smoking, it is going to show mite dysplasia. How do you differentiate? Very simple for us as clinicians. I was just telling you, Vijay, we won't be beating around the bush. If the lichen planus is supposed to be self-limiting, does not resolve with your conventional treatment over 6 to 8 weeks time, then we have to discard the word lichen planus and start saying this is not lichen planus, this is something else. And one more bias which you have is oral lichen planus is symmetrical. I'm sorry, dermatologists don't see symmetrical oral lichen planus because the reason you get this is something called Kubnerization. Kubnerization is occurrence of new lesions at sites of injury. And where else in the world do you get injured? People eating murukku, tatta, everything. What else do you expect in the mouth? So, okay, this is an injury, right? So you will get lichen planus only at the sites of injury. So the first bias which has already been triggered is symmetrical lichen planus. I'm sorry, we don't agree with that. Okay, so overall, all I want to do is, you guys, this is a huge clinico-pathological diagnosis. You cannot, it's like the blind man and the elephant. You are holding the tail, I'm holding the trunk. You have to sit together and say, this is a clinico-pathological correlation. And if I tell you that I am 100% sure that this is lichen planus and I treat it, I should be seeing the results. If I don't see the results, it's not lichen planus. Having said that, I have seen 4 cases of lichen planus progressing into malignancy, and I believe they are not lichen planus. Okay? I always say that lichen planus, 20 years patient, she's had, it's a very close friend of mine. She said she was diagnosed with lichen planus 20 years back. I said, where is the biopsy? She said, no biopsy done. First out, that's the biopsy gone, right? By the time it was dysplastic, surgery has been done, removed. Now she's got only 1/3 of her tongue and everything is dissected. Unfortunately, it's a well-differentiated squamous cell carcinoma. You cannot have chemotherapy, you cannot have radiotherapy, and there are no markers to diagnose this. The only marker which we can come close to is cytokeratin 5 or cytokeratin 6. Pan-cytokeratin will not help you, and if there are Ki67 will not help you because there won't be any much changes. It's very difficult to diagnose. It's a clinico-pathological correlation. Please understand that. So this is in short summary of oral lichen planus. From our point of view, I would love to, we have a problem. We know in our heart that oral lichen planus is not pre-malignant so easily, but the patient believes it is malignant and pre-malignant because they've already done their research. And last, regarding what titanium was mentioned, I have a patient with lichen planus of 10 years duration. I'll say question mark of lichen planus. Biopsy shows eosinophils and polymorphic and twins. So She was diagnosed as titanium implant allergy. We had to remove 18 of her titanium implants to make her fine. Remember, 18 implants had to be removed. And thanks to my Professor Patrick, who said, yes, Anand, you're right, remove it. And we had to remove 18. And after 10 years, she says, I am so much better after removing the titanium implants. So with this, thank you. I'll leave it to Vijay to summarize the further clinical part of it. Thank you very much.
Yeah, I think Anand has covered the dermatological perspective almost in full. Nevertheless, the questions communicated to me were, does over-treatment pose more harm than benefit in low-risk cases, and do corticosteroids reduce malignant risk or potentially mask early malignant change? Okay, treatment, the primary complaint, Dr. Joshi was also mentioning, they can't eat, so that reduces their quality of life in a big way. So for that, we have to address it. So there is no question of under-treatment here. We have to go all out in certain situations. So as Anand had mentioned, we have to tackle the candida part of it, the microbiome part of it. So the metronidazole goes in first, then the candida. Then if it is not coming down, the overall quality of life is reduced. We do use corticosteroids in short courses of 4 to 6 weeks to bring down the inflammation. And corticosteroids again, their main role is to improve the quality of life initially, bringing down the inflammation substantially. As all of us are aware of, any sort of uninhibited inflammation ultimately can cause dysplastic changes. So overall, corticosteroids does tend to bring down the inflammation and could potentially reduce the dysplastic changeover also. But continued long term, sometimes patients, what they do on their own, they keep on using it without consulting us, then it becomes a problem. But under supervised conditions, corticosteroids play a good role in reducing the overall inflammatory load and improving the quality of life. Then, how do we tackle relapses when corticosteroids are withdrawn? For oral mucosal lesions, nowadays, I think Anand would agree with me, we have got a good drug, acitretin. It is an drug with an anti-proliferative effect that helps a great deal in mucosal lichen planus. We have used it both in oral as well as genital lichen planus. Acitretin plays a good role in this scenario. It has got an anti-proliferative effect. So if at all we have got some concerns with the use of corticosteroids and their potential to mask the malignant dysplastic changes, acitretin is a good add-on option as we withdraw corticosteroids. We have used it in a few cases. Acitretin is a very good drug. It has got, sort of increases the concentration of T regulatory cells from an immunological perspective. So this aspect can be taken care of when we use acitretin judicially, a synthetic oral retinoid. That is of great help in this condition. So that should answer this question. Then the communication of risk to the patient. Yes, we should not, patient come to us having gone through all this either through Google or the recent one, ChatGPT. They have come with all the percentages which we are unaware of. Sometimes we get educated through them. All these percentages of turning into malignancy and all that. So communication, yes. Again, as one of the speakers had put out, habits, no habits. In a person with habits, an increased risk. Person without habits, just reassurance. And person with habits, ask them to quit those habits. And effective diabetic management again. Diabetic care again is important. I do go to a diabetic hospital. We do see a lot of cases there. Whenever the diabetic goes up, candida goes up. Candidiasis again, Kubner phenomena, again it triggers a lichen planus outbreak there. So candidal control very important. Proper control of diabetes, that is extremely important. Another important thing. And the question of rebiopsies, again we do keep following up these patients clinically. Nowadays we have got some additional equipments like dermoscopy sometimes, which we can use inside the mucosa also to see some patterns. If we see some patterns which are not conventional to lichen planus, we do counsel the patients for biopsy. Follow-up, very, very important. One of the very rare cases of oral lichenoid lesion which turned into malignancy. One lady was coming to me for follow-up for every year she used to come for follow-up. In the years of COVID, she didn't come for follow-up for 3-4 years. Suddenly she presented with an hyperplastic mass. When we biopsied, it turned out to be a squamous cell carcinoma. So follow-up, an annual follow-up is enough. We do look for conventional features. If they are absent, any change we notice to what we have seen before, serial photographs are useful. Dermoscopy is useful these days. That helps us to sort of stratify patients who need rebiopsies. To the best of my knowledge, there is no time interval. Anand, are you aware of any time interval where you have to repeat biopsies? I think it goes by clinical stratification, yeah. So so this is regard to the repeat biopsies. So again, then some question about patch testing. Patch testing, we do it on the skin, how far it is relevant to the oral mucosa, how significant it is. Maybe we get a positive patch test in the skin and we see something in the mouth, both correlate together. Maybe we can use it as an add-on sort of stratifying criteria, that's all. I don't think patch testing on its own is going to help us in OLL. So that is regarding the role of patch testing. So overall, treatment of lichen planus, quality of life is affected when oral mucosa or genital mucosa is affected for that matter. So we'll have to first treat the symptoms, then look for any abnormal features. Then there are other drugs which are there nowadays which are useful, which have got anti-proliferative effects also. That can to some extent take care of dysplasia also, as we have found out in our clinical practice. We don't have studies to back it up. Somebody could take it up as a study, acitretin, in this scenario. So this is in brief my view on the oral lichen planus from a clinician's point of view. Anything to be added, Anand?
Add a little more confusion to all of you. You are going to see a lot of this in future. What are we treating in cancer today is using tyrosine kinase inhibitors, okay? And I told you what is lichen planus. It's a T regulatory cell response causing apoptosis. So what is body trying to do? It is trying to actually prevent a cancer. Am I right or not? Right. And now we are saying that it is cancer. So what you are seeing in a lichenoid reaction is a reaction to the primary insult. What is the primary insult? The 5S and whatever extra you want to add today. So putting that as oral LP is very bad. That's number one. Second thing, what are you going to do when tyrosinase kinase inhibitors, imatinib, so many things, you can name it. I am a consultant to Cancer Institute Adyar. I see one case every other day of oral lichen planus, and personally, yes, my wife is a cancer survivor. She has oral lichen planus, and I was telling him acitretin improves her within 5 days. So there's a lot to it than just labeling it as malignant and p-malignant. There is much more than that. I think, as somebody said, it's a clinico-pathological correlation. First, diagnose the oral lichen planus properly before jumping to conclusion that it is something else. So you have to be dealing in future with lichenoid reactions due to imatinib and so many other things. There are hundreds of any of the tyrosine kinase can potentially cause, any of the pembrolizumabs, any of the newer one can cause lichenoid reactions in the brain. That's all. So
thank you so much, Dr. Anand, but I have a couple of questions to you. As far as oral lichen planus concerned, see, you had talking about melanin. So we have been taught, and we generally see in the regressing phase of lichen planus, as clinicians and pathologists, we tend to see a lot of melanin and melanin incontinence, which we consider to be a part of the healing phase of lichen planus. I think you had a different perspective as far as melanin was concerned in the skin.
no, it is difficult to see melanin in the oral mucosa unless there are some people who are pigmented in the mouth.
So generally in patients whom we see here in the resolving phase, or probably the remission phase, I can't even say resolving, the remission phase, we get to see melanin incontinence, and sometimes we even reassure the patient that this is in a remission phase, and we try to tell them probably if you're going to take care of yourself, and as he said, stress and all those things, when we counsel, we use this as a very important, histologically, melanin as a very important factor in counseling the patient. And second question is, doctor, that as I was talking about remission, in oral lichen planus, I'm sure my oral medicine colleagues will agree with me, after the remission phase, we have followed up a lot of patients with gingival lichen planus. They have the striae is still there, the Wickham striae is still there. We follow up patients. There is no symptom, But for 20 years, that stray and the manifestation of this bilateral presentation, which we feel is very important as we see a lot of patients of leukoplakia. So as a diagnostic point of view, it has been ingrained into us by our teachers that when you see a singular, if it's going to be unilateral, it's usually leukoplakia and plaque, because we don't get to see plaque-like lesions of lichen planus intraorally, very rare. So, and of course, habits make a lot of difference. So, 20 years, the Vicam stray we have still remains, but asymptomatic. Patient even doesn't have burning sensation. We have our own lab technicians whom we are following up almost for 18 years. After the first phase of treatment, she still has the lesions, but it's asymptomatic. So in those conditions, like I had given one example of a patient like after 18 years or so what would be your take on those? And they didn't have any skin lesions, only oral manifestations.
Very interesting. I give you first thing.
Because we have students here also, you need to be very careful. It's very, I think, inappropriate to compare oral lichen planus with skin lichen planus for the simple fact that what you said, there's a lot of microbiome in the oral cavity which is absolutely different from the skin. 90% of the time, the reason why oral lichen planus is symptomatic is because of superadded candidal infection. You treat that, most of the time the burning disappears. And
First treat, then do biopsy.
Yeah, I would agree with that. But I would again take up a point with you about giving Metrogel empirically. Because the first thing you're taught as far as oral microbiome is concerned is if you want to make it sterile, just wash with concentrated nitric acid. It's just impossible to make oral because you have what are called niches within the gingival crevice, which Metrogel will not address in the dose in which we give the patients. Yeah, so let me finish off that. So it would, yes, definitely there are similarities, but there are a lot of differences. So I would not equate dermal lichen planus with oral lichen planus. Second, regarding Koebner's phenomena, you cannot get an oral mucosa without Koebner's phenomena because by nature, frictions causes keratinization, and most of the oral mucosa is keratinized except floor of the mouth and some areas. So that would be a little bit difficult. Regarding the sawtooth rete ridges, it's a well documented fact that we do not see sawtooth rete ridges in the oral cavity because of superadded trauma and other conditions and a lot of chemicals to which the oral cavity is exposed. That's the other thing. I think the other point is melanin incontinence. You need to be very careful. You need to understand, sometimes we forget the reason why we tell these things. The reason why we say melanin incontinence is because of post-inflammatory melanosis, which happens in a lot of lesions, so we say it's post-inflammatory. But why it happens is melanin is a very heavy molecule. And when you get damage to the basement membrane, it's just melanophagous. It's not melanin in the pig. It's just melanophagous.
Exactly.
So, the thing is, you can see in the oral cavity, even if it's not pigmented, it's a misconception that you need pigmentation because of the epidermal melanin unit. Let's not go into that. It's totally different in the oral cavity. And something which you didn't touch on, but I think which you nicely touched on is parakeratosis. Parakeratosis is not hypercritical in the oral mucosa because the type of keratin you see in the oral mucosa is different from the complex which you see in the skin. Parakeratosis is not necessarily an indication of either malignant potential or non-malignant potential. Even in hyperkeratosis, sometimes you see in the buccal mucosa parakeratosis or no. So it's a little bit tricky. It's not necessarily equated to the turnover of epithelium, though it may be. And sometimes we see in the same mucosa, a part of it is parakeratotic, a part of it is hyperkeratotic, and part is normal. So there it may be a problem with the turnover, how rapidly it's turning over. So these are a little bit of a tricky things. And the other thing is we all need to be very, very careful. Okay? Absence of evidence is not evidence of absence. Please be very careful. And I agree with all that you people say because students are there. Yes, there is something called lichen planus, there is something called lichenoid mucositis, and there are fantastic treatment like the anti-proliferation drugs. And I totally agree, there are totally new bunch of drugs. We see a lot of lichen planus-like lesions after COVID vaccines. I see that in a couple of doctors actually. And thanks to the anti-fat drugs, Mounjaro and Ozempic, we are seeing a lot of lichenoid reactions in these patients also. So the list is going to be increased. We are not going to escape from that. My question is this, and because in the interest of time, because we could talk for a long time. Let's say even if there is 0.5% chance of malignant transformation, this is how I approach clinically. We tell them, yeah, it's just 0.5, it's probably because of habits. And I'll draw a tale of caution in this because the cancer which we see today, at least most of which I see today, is non-habit associated lateral surface of the tongue in younger patients. I can give you a list of 20 cases in the past of 2 years which I deal with oncologists. So it's very tricky. So just because we don't see it doesn't mean it's not happening out there, especially in India, because a lot of these go unnoticed. And the other thing which is very important to understand is just rephrase the question. I'm going to be a devil's advocate here. Rephrase the question. I say it's 0.5% lichen planus is going to transform. You tell the patient, 0.5%, come every 3 months, we look at it. I'll ask you if it's in your parent or in your mouth, what will you do? Will you wait for 3 months? I'm talking in a purely clinical perspective because this is not, because we're all talking about the realm of clinical practice. This is not a very scientific way of approaching the problem. What will you say? Doctor, just take it off. I don't want to take a chance because every day morning I look in the mirror and see it's increasing or not increasing. So you need to be careful what we tell the patient. That's why I made a point that personalized medicine is different from public health medicine and science. Please be very careful about it. And what we are telling here are tremendous experience in clinical practice and how we approach the patient. But there are different ways to approach the patient. But be careful of your fundamentals. And I think he rightly pointed out T-cell immunity. The problem is you mess with T-cell immunity, that is actually a protection for surface cancer actually. B-cell T-cell interaction we know, especially interleukin 17, which happens because of B T-cell and the Tregs. Tregs are very popular now in cancer and lichen planus actually. They are good for preventing against cancer. And I think that was the reason behind what Dr. Pratibha put as, if we put steroids, will cancer come or not? See, the point is, it works like this. And this is oversimplification once again. If you have fever, you take paracetamol, it works fantastically. But you keep taking paracetamol without anything, you're going to have hepatotoxicity. Paracetamol is a hepatotoxic. We have no doubts about that. In practice, it is always a balance between what benefit you get and what side effects are there. It is benefit-risk ratio. If the benefit is more than risk, use it. If the risk because of the drug is more than the benefit, don't use it. This is common sense in practice which I was taught by my teachers, because there is no drug out there which is 100% safe, including your paracetamol, which is a household name thanks to COVID. Yes, please take up all that which is being said, but just don't take up the point which strikes you, because students tend to do that. Lichen planus is not malignant, I don't need biopsy,
I'll clarify that. Every point
No, just let me finish it. Let me just summarize. So all which is being taken should be taken in the context of a clinical setting, and each of these statements is true. But take it in context. Don't take it out of context. That's my only concern. And look at the basics. Basics will never, and that's what Dr. Patrick used to say. I'm a big fan of Dr. Patrick and Dr. Janki. I've heard tons of lectures, I've listened to them. And it is very important that you understand that when something happens, you say why. T-cell inflammation, you suppress with retinoic acid. Retinoic acid receptors, you all know, during embryology, that's one of the things for segmentation and differentiation. And anything which messes up with differentiation is going to mess with proliferation, is going to cause shifts. We know cases where, for example, in the skin, retinoic acid, you get photosensitivity and other DNA-induced damage. So maybe the synthetic ones overcome some of those side effects when you use it in the mouth. I still remember a few years back when tacrolimus was introduced. I still remember dermatologists were very excited about tacrolimus and they used to prescribe. But when it was first introduced by GSL or GlaxoSmith, I don't remember, there used to be a small line not lent in the oral mucosa. But people were using it in the oral mucosa because it was effective on skin actually. And then, of course, people understood that it was not there. So all these things, please understand, let me just summarize in 3 points. Yes, each clinical situation is unique. Yes, there are evidences pointing to all this. In spite of clinical experience, you need studies. You need well-documented studies, long-term follow-up and cohort studies to justify what you're doing. And every patient is unique. What works for one patient will not work for one patient. The purpose of theory and deliberation is to take it as a yardstick and use your experience and temperance. And last but not the least, if you have any doubt, talk to experts like who are there on the dais today, or your guides or your teachers. That is a lot better than trying to interpret it on yourself. So that's just a word of caution. Thank you once again.
Yeah. First question, he said metronidazole is not empirical. Let me be very, very clear. Metronidazole is the only RCT done. Remember, randomized controlled trial for lichen planus. So metronidazole did not come as an empirical treatment. It came as a specific treatment for lichen planus here. Number one. Second, oral lichen planus, this is from the British Academy of Dermatology, has to be treated antifungal. So 2 things. Third, acitretin and retinoids are not procarcinogens. Let me be clear. Yes, you are right about the embryogenesis, but then we are not giving it for a patient in the childbearing age group. Fourth, your lichenoid dysplasia. You tell me how many 20-year-olds in your dental practice have you seen with a lichenoid dysplasia? It is usually a 40, 50-year-old woman or a man who comes with a lichenoid. That is where the controversy has all started. Last, the habits. These habits we have. What do you mean by habits? Smoking. That's all. That's all. We look at only two things, right? Do you know what is cinnamic acid, cinnamaldehyde? It's there in your cooking. It is pre-malignant, typically. It is present in toothpaste, dant manjan, you tell anything, it's present in every place. It's present in lipsticks, right? Okay, right. So there is the problem. So as he says, it's right. Don't just say to the patient, it is not going to become malignant, but don't be the devil's advocate and tell them that, oh, you're going to get cancer one fine day. That's what you need to understand that, okay? And yes, lichen planus by itself beneficial because it is fighting apoptotic. So second part you asked me, many years later, does it happen? Yes, we have memory cells in the skin. T regulatory cells work in the memory cells. Interesting. I will tell you the example. Your mom knows it better than me. I had lichen planus of the entire body following chikungunya. Okay? I had never seen a laryngeal lichen planus except my own larynx. Okay, I told the ENT specialist, do a laryngoscope, but show me. I know this is lichen planus in my larynx. Because my voice had turned hoarse. So I saw that, and there was another dermatologist. She said, yes, sir, lichen planus in the larynx, lacy network in the larynx. Okay, treated everything, it didn't disappear. 6 months later, I had a renal stone. Renal stone was operated, and 5 days after my renal stone, my entire lichen planus disappeared. Right? So you see where we are heading to. You have a T regulatory cells responding to some stimulus somewhere. You're only looking at habits and you're looking out in here. It is somewhere else. And 5 days later, and it is more than 12 years, I have not had lichen planus. But as Pratibha said, I can feel it. I can feel it in my mouth. It doesn't hurt me, but I cannot eat spicy food anymore. It's a little bit. I don't have lichen planus in the mouth, but my brain says when I touch that, there is something there all the time. So yes, the memory cells don't go away. Okay.
One more thing I tell in private practice, before starting, I don't know how many of you do general dentistry or not, no treatment should be begin in lichen planus patient without oral prophylaxis. Because all these maximum patients are having gingival lichen planus. Their most common complaint is what? Gingival bleeding, and they cannot brush. So the first and foremost thing I tell, see, I should not use this word, sir, but for me, oral lichen planus is not only bread and butter, it's a jam and cheese. Because I treat them by oral prophylaxis, I make gingival guard for them, which also, so it's a thing that oral pathology is not only biopsy and all over there. If you practice, yes, it is lucrative also, and I'll be very honest, lichen planus has fetched me enough that the whole experience is talking about my personal experiences. So please do oral prophylaxis first before starting treatment. Otherwise, your steroids will work only on the inflammation of the gingiva and not on the lichen planus aspect, because you get only gingival lichen planus. Okay?
I would request Dr. Aravind and Dr. Uma to summarize on the oral medicine point of view with regard that oral lichen alloid reactions, lichen planus, leukoplakia and early OSCC often clinically overlap. I think many of it was addressed by previous speakers, but it would be good if we could hear it from an oral medicine point of view.
A very good morning or good afternoon. And first, my apologies for not having a PPT because I just came back to Chennai today morning. And first of all, I'm very happy that I have found a very strong alliance partner in Professor Desa sir, who shares the same view on evidence-based practice like me. Thank you, sir. Okay, so most of the things has been covered by the speakers ahead of us. I would like to say what we do it in our department. Yes, we don't take a biopsy on day one. We remove the oral foci of infection. In our practice, what we have found is, yes, metronidazole is good, especially if it is a gingival desquamation without a typical lacy pattern or an erosive on the buccal mucosa. Our experience, which has been published also, doxycycline works better than metronidazole, with less side effects of an altered taste, which doxy usually does not have. So that's one protocol we follow. The second thing, respected Kumar sir made a beautiful point on mast cell degranulation. I think that's a concept which has been overlooked for many decades. It was first maybe thought about a lot during the 50s and the 60s. We tried to go back into it, and we have a beautiful PhD work by Professor Jayant Kumar, who is here, who proved the role of degranulation of mast cells. So we changed the protocol. In addition to doxycycline, what we add in the first visit, we added a course of antihistaminics, and by that causing 25 paisa per tablet, a cetirizine 10 mg. And by the end of 1 week or 10 days, the VAS score reduced from 10 to 6 or 5. That's a drastic improvement what we had. So try to incorporate an antifungal, remove the oral foci of infection, add these small things before you do a biopsy. Then the second thing the thing is given to me, yes, clinical diagnosis is sometimes confusing between a leukoplakia, a plaque-like leukoplakia, or is it a plaque-like lichen planus without an habit, or is it going to be a discoid lupus erythematosus exclusively with an oral involvement or a lichenoid reaction? With your clinical discrimination, you need to come to a conclusion. But the point of a malignant transformation from lichen planus, as a practicing clinician for over 25 years, I strongly believe, against my personal opinion, whether, first of all, before we go to that, we are saying a malignant potential of a lichen planus is somewhere between 0.44 to 2.78% over a 10-year or a 20-year. A malignant transformation of a lichenoid lesion or dysplasia is much higher. But in the so-called studies which the Western world has given us, how many articles are from the Indian population? It's absolutely zero. Everything varies. The culture, the way of life, the physical build-up. In fact, even the dosage for most of the drugs are based on the Western population or on the European population. Does it suit an Indian body makeup, our diet? So how many articles are there which reflect the India? Zero, absolutely zero articles in any of those systematic reviews. So we cannot blindly take it up. But of course, in our practice on a personal level, we have seen malignant transformation, but at a very, very negligible level. The question comes, is it the disease process itself? Is it an under treatment by us, or is it an over treatment by us? Because pharmacology or therapeutics works different in India compared to the other countries where I have trained and worked. Once a prescription is given, it cannot be refilled again without the physician's consent. I have n number of cases. The prescription which I gave in 2005, the patient still using in 2026 January, which I saw 1 week before. And the pharmacist also gives it. The second thing, the makeup of the patient. Our patients want overnight relief. That's natural human tendency. They come to you for 1 week, 10 days. You don't cure. They go to your neighbor. Then he sends to the next neighbor. So polypharmacy. So are we over treating, which is, because the golden rule is, it's a T cell dysregulation which your body itself has got the capacity to regenerate. are you altering the normal God-given mechanism of protection and trying to induce something? So that's my point. Again, we need to, this one. Third thing is, yes, steroids are our mainstay. I would openly say misuse of steroids by the patient themselves and practitioners who are not well versed, I would not blame them, who are not well versed in how to use a particular drug. Second thing is that our ego does not allow us to accept defeat. I would always try to equate lichen planus to trigeminal neuralgia. Fine, it does not react to gabapentin, dose increase. Sorry, carbamazepine. Increase the dose, increase the dose, increase the dose. It doesn't, add one more drug. Add the third drug. Add the same thing happens to lichen planus. So we have read there are so many drugs. So we start with corticosteroids. No. Then I go intralesional. No. Then I go to azothioprine. No. Then I go to methotrexate. Then I go to tacrolimus. Because evidence shows that beautiful results with calcineurin inhibitors. So are we over-treating it? That's a point which would not have turned into malignancy, has turned into malignancy. So are we to be blamed and not the patient? We need discussion. The third thing, sir bought a beautiful proforma on sleep, because any disease for which we don't have an answer, we put the blame on psychology or stress. The patient is stressed up. And of course, lichen planus has got a lot of positive, stressful conditions which trigger. What are we doing to address that in our treatment plan? We don't have it. And of course, post-COVID, the presentation of lichen planus is totally changed, which was usually considered 40s or 50s, is now coming in pediatric cases. We have seen about 7 or 8 cases of pediatric lichen planus over the past 2-3 years post-COVID. Housebound, not allowed to go anywhere. So what is this trying to teach us? So we have got more questions rather than concrete answers. I'd like to end up with my personal experience of malignant transformation. In my past 25 years of experience, I have had 5-6 cases of malignant transformation, 4 in my private practice, 1 here, and 1 more I'm waiting for the result from the oral pathology, which very clinically I am sure it has turned into malignancy. All these 6 cases have one thing in common. Lichen planus heals everywhere beautifully. Gingiva, buccal mucosa. Tongue lichen planus is difficult to treat. All these 6 cases, malignant transformation has been in the tongue. Point number 1. But I take the blame of it. When I changed the management from steroids or dapsone or azothioprine to tacrolimus, within 6 months or 1 year, it turned into malignancy. And of course, we have literature that calcineurin induces squamous cell carcinoma. So the question is it the natural progression itself, or it's an iatrogenically induced? So thank you all for giving me an opportunity to add more confusion to the debate. Thank you so much.
Dr. Uma, you have.
Stop.
Good afternoon to one and all present here, respected panel experts, offline and online, and dear students. I take this opportunity to thank Dr. Pratibha ma'am and Dr. Ramya ma'am to include me in the panel discussion. So before preparing the answer as a co-guide, I always respect Pratibha ma'am as a co-guide from my research scholar journey. So we did a clinico-pathological correlation there itself, like how to prepare this consensus presentation addressing to the question of confounding factors and overlapping as whether the malignant transformations are because of the diagnostic delay from the clinician point of view. So ma'am told that it will be better, you can utilize this opportunity to showcase your own experience, like that is our own oral medicine department experience of seeing cases. So I feel that this presentation will be like a translation of literature into clinical practice. And I'm not addressing to the controversies. I do agree that based on the experience, the senior professors will have more correct opinion regarding the diagnosis and treatment part. But here I'm just utilizing this forum. It's, as a last speaker, it's just going to be a summary of all what we had discussed in the panel discussion. Already the diagnostic criteria was well explained by Ranganathan sir. I just wanted to highlight in this presentation that there are a lot of diagnostic criteria, modified diagnostic criteria, and every year you have some evolution. And finally, we always, as an academician, we tell the students, do follow the latest concept, be updated with the latest concept. So the 2020 WHO Collaborating Center has recommended that you have to include certain features in histological features. If they are present, yes, you can diagnose it as lichen planus. And there is an umbrella term which we need to keep updated ourselves, that the oral lichen planus, oral lichenoid lesions, and lichenoid mucositis dysplasia, all three are included as oral lichenoid conditions. So adhering to this diagnostic criteria, I would be presenting the cases seen in the Department of Oral Medicine. So over the period of from 2019 till 2025, a retrospective analysis of what is not just seen by me as such, by the entire oral medicine experts in the Department of Oral Medicine. The database, even many experts in the panel discussion was also pointing out, proper follow-up is important, and having a retrospective analysis of what has happened for the patients who have been treated from the year 2019 till date. So here you could see that a lot of patients, mainly the reticular lichen planus, which we say asymptomatic, or again followed by erosive lichen planus, were more prevalent. And there were a lot of habits associated with these lichen planus patients reported in the department. And of course, there were a lot of evaluation of the etiological factor, and we found that, of course, stress and habit association and systemic disease associations were equally prevalent in most of the cases. I am just pointing out what I have analyzed retrospectively in the database available in the DIAS, that is in our patient database system. So few cases which I feel it is interesting, and it will be answering to all the questions, queries, and controversies being created in the panel discussion. This was a case of oral lichen planus. Almost for 20 years, it is still being diagnosed clinically and histologically proven case of lichen planus, still under the treatment. Like we give a topical steroid along with antifungal drug, and it is not still turned as malignant transformation. Still the patient is under regular follow-up. This is a case probably, I think Dr. Arvind was pointing out, this case has been treated by Dr. Arvind, and this was a biopsy taken elsewhere. In 2019, the patient has taken biopsy. It was proven as oral lichen planus. And this was the picture where like patient didn't follow up properly. Like there were, the patient came in 25, and then again patient has also reported in 26. And we do suspect that it is no more just an oral lichenoid condition. It could transform into malignancy, and we are waiting for the report. And a lot of lichenoid lesions, around 115 lichenoid lesions in the database, where you could see little male predilection, and of course, and even we have also seen age-wise also in the 3rd and 4th decade, there are a lot of lichenoid lesions reported in the Department of Oral Medicine. And many lesions are unilateral, and there were few bilateral lesions also, which was diagnosed as lichenoid reaction, both clinically and histopathologically. And there were a lot of lesions mainly associated with contact. And we had also seen drug-induced lesions, around 38 lesions out of 115 cases of lichenoid lesions reported in the department. And there were few graft versus host diseases, which was also reported in the Department of Oral Medicine. And this was a case which we diagnosed it as lichenoid reaction clinically before taking any histopathological diagnosis as such, based on the history that after change of a new anti-diabetic drug, the patient developed this lesion. So we, based on this history, we had diagnosed it provisionally that it is drug-induced lichenoid reaction. And then there was a case which was also because of pan chewing habit. So, and I mean, like when we are not having other possible etiological agents elicited in the history, we had diagnosed this case clinically as dichenoid reaction associated with pan chewing. And finally, we were also treated these cases with a course of topical steroids and even a course of antihistamine systemically. And after 2 or 3 weeks, we keep regularly calling the patient, recall the patient for review. And this was another patient which we diagnosed it as because of contact induced lichenoid reaction because of amalgam restoration. And once we are clear with the etiological agent, as clinicians, we first addressed to the removal of the etiological agent, and then we treat the patient symptomatically. And this was another case which is under regular follow-up by our postgraduate student under the guidance of Dr. Aravind. And we finally found that the patient came a few years back, and then there was little loss of follow-up, and finally the patient was, I think you're not able to appreciate the date. So like we had seen few months back, and this was the OPG picture where we could suspect some bony involvement. And we also got the report from the histopathology department, severe epithelial dysplasia. And finally, the latest report proved that it is a squamous cell carcinoma. And you could see the bony erosion also when you can compare to the previous OPG. So we are regularly following up such cases which we are suspecting malignancy, whether it is lichen planus turning into malignancy or lichenoid turning into malignancy, or it was an early stage of oral squamous cell carcinoma which has been, there was a diagnostic delay, whatever may be. Once the patient is suspicious, any red lesions, any suspicious oral mucosal lesion, actually I adhere to the terminology called oral epithelial dysplasia, whether it is lichen planus or leukoplakia or lichenoid, it is an oral epithelial dysplasia, whatever could be the etiological agent, whatever could be the diagnosis made by expert A, B, or C. Once you suspect malignancy, do not hesitate to do a biopsy and try to convince the patient, and do not put the blame on the patient. That patient is not convincing. And unless you have a proper rapport with the patient and try to explain to the patient, develop that trust, because I personally feel that once my postgraduate student comes and calls me and tells that patient is not agreeing for the biopsy, once I go and talk to the patient for a few minutes, I feel that the patient gets develop that trust in me, and they do agree for the biopsy. So when biopsy has to be done, it has to be done. There's no point like this literature doesn't accept biopsy at the first visit or second visit. If you are finding any suspicious lesion, please do a biopsy. And this was a case like it is like I thought I'll just, though I don't know whether it is connected to the lichenoid lesions or to this particular forum, but I thought I will utilize this forum to share my experience of diagnosing this case clinically as a Crohn's disease or a granulomatous disease. And finally, the report came as, it was taken in multiple sites. So I just wanted to say that there are some situations where you have to do multiple site biopsy, and that will give you more picture, more insight to your diagnosis. So this was another case which was diagnosed as lichenoid lesion in the earlier biopsy, and finally it was, in one site it was moderate epithelial dysplasia, and another site it was a squamous cell carcinoma. So sometimes clinically also we may have certain classical clinical appearance which will make us to give a provisional diagnosis based on our expert opinion, but always we should understand as a clinician we have to depend upon the biopsy, which is the gold standard, and then only confirm your diagnosis, however great you are in your diagnostic knowledge. But still, each patient is unique, and that was thing I learned in the previous case. And this was another case which I mostly emphasize this to all my undergraduate students. Though textbook says that non-homogeneous leukoplakia have highest malignant risk, I will boldly say that equally I have found both homogeneous and non-homogeneous leukoplakia having malignant risk potential to the best of my knowledge. So if you suspect any red and white lesions, Do subject the patient to histopathological examination, no harm if the patient is also willing for it. And this is what happened in this case, which we, clinically it was like deceptive. It was looking like a benign lesion, but histopathologically it proved as a lichenoid with moderate dysplasia. So your line of treatment will vary depending upon the histopathological report. So to summarize, yes, there are a lot of confounding factors addressing to the question of the consensus meeting. There are a lot of confounding factors, starting from your own diagnostic delay, and of course a professional delay. Sometimes if the biopsy has been done, and if you feel that the report is not compatible with your clinical, no harm in repeating the biopsy, no harm in talking with the pathologist, discussing with the pathologist, no harm in discussing with your other experts, which we don't do. We only believe what we think is right. And next is, definitely there are a lot of immunologic, inflammatory markers or inflammation which may mask dysplasia and can also be a predisposing factor to dysplasia. And that is why the panel experts were insisting on oral prophylaxis. Yes, I do agree with that. And we are definitely following in the Department of Oral Medicine. And mainly patients also feel that sometimes it is self-limiting and it will heal on its own. No use in going to the physician because they will confuse us. And that such type of myth among the patient is also one of the reasons as a confounding factor. And whether it is lichen planus or lichenoid, again, if it is going to be habit associated, remember oral epithelial dysplasia can come from either leukoplakia or lichen planus or lichenoid, or even a chewers mucosa also can turn into malignancy if the smoking habit is going to be continued. So this particular article, which was already quoted by Ranganathan sir, I just wanted to say that this is like a latest concept about the malignant transformation rate, where they had given the malignant transformation rate for each of the oral lichenoid condition. And on the whole, the pooled malignant transformation rate is 1.07% as per literature. And what we have to understand is the red lesions, the smokers, HCV positive. It is still in the literature level, but we don't find any, we don't take any steps to see whether our oral lichen planus patients are associated with HCV as such. We start treating them symptomatically, and we are happy if there is, of course, remission. And finally, when there is exacerbation, we try to increase the dosage or we try to switch over to another dosage. But there are, literature says that all these predisposing factors also should be bear in mind, at least for refractory cases, at least for long-standing cases, we can apply this knowledge also. Yes, as to summarize, oral lichenoid conditions overlap oral squamous cell carcinoma, misdiagnosis do happen in many cases for which the patient turns into oral squamous cell carcinoma because early diagnosis was missed out by the clinician. And many confounding factors, especially following different criteria, different experts and faculties sharing their own knowledge but not sitting and standardizing the diagnostic features. That is not happening in many places. First, we need to be standardized and then only we should start preaching the students. And of course, molecular markers, as sir has rightly pointed out, do play a role maybe in future for personalized treatment of lichenoid conditions. And as a clinician for 20 years, I would say that definitely we need standardization, education. Please talk with the patients, create the trust for the patients, remove their cancer phobia, and try to do a biopsy if necessary, and try to do even re-biopsy if you feel that the pathologist's report is not correlating with your clinical report. And of course, a good properly taken biopsy specimen is also important. And referral pathways. Many patients are not being referred to oral medicine when it has to be referred, even from the general physicians also. Like as oral medicine specialists, if we come across any systemic diseases, or first thing we do is we have an opinion with the general physician, but I feel even the general physician also should have a proper referral of oral lesions at a very early stage to the concerned specialist. So I would like to again utilize this opportunity to thank the organizing team, special thanks to Dr. Pratibha and Dr. Ramya ma'am, and my own Department of Oral Medicine, my postgraduate students, who still make us to feel energetic and giving us a chance to diagnose, treat, and follow up. and my own institution, which has given the platform for diagnosing case and to do a retrospective analysis of all the cases seen in the Department of Oral Medicine. Thank you, one and all.
Thank you all very much. Thanks to all the panel members. I've been given the task of quickly summarizing what is...
Thomas, sir.
Oh, he's there. I'll just quickly summarize and then we'll hand it over to Dr. Thomas. What is he talking on?
The last part, the AI part.
Okay. So do you want me to wait or... Okay, let me just quickly summarize because I think a lot of them are here. Very quickly, a lot of important points were mentioned. I'm just going to quickly go through the order in which the speakers presented it. After I presented an overview, Dr. Narayan brought up a lot of points. I'm just going to say 2 or 3 points. And one thing which he drew attention to is we need to risk stratify based on both clinical and histopathology if it's to be clinically relevant. And we should communicate what we find to the clinicians in the interest of treatment. Dr. Tilak made a lot of interesting points with reference to the histopathology. I think some of the most important things were, one, yes, lichen planus by itself is probably not potentially malignant. There is nothing called lichenoid dysplasia and we should stop using the term. It's epithelial dysplasia with a lichenoid reaction. And there is a need for standardization and calibration of your histopathology reports, and this can be taken up by investigators in the future. Dr. Rajiv brought his enthusiasm to the presentation, and he started off with the question, is evidence really evidence when it is just opinions of people? Many patients are on drugs. What impact do they have on our diagnosis and management? And he finished by a very nice idea which has been telling in all conferences that I've met. We should have a universal proforma. And I'm glad to announce that the oral medicine has got a consensus statement of which I was happy to be a part of, and I think it's being published in oral diseases. So we are going in that direction. I should thank Dr. Anand for his very nice clinical expertise, and I think he started off with a very interesting statement. You should be very careful about the difference between a dogma and confirmation of a dogma, and I think this is very important in clinical practice. And he drew attention to the 5 S's, which I was taught when I started histology, and I think it's been forgotten. And he drew difference between the American and WHO criteria, and the fact that the newer drugs like tyrosine kinase inhibitors are going to really influence what lesions we are going to see in clinical practice. This was followed by Dr. Vijay, and he gave a lot of clinical emphasis on management. And I think he made a very relevant point that the infection has to be reduced first before we even start. And he drew attention that corticosteroids has to be used judiciously under supervision. And the new drug, acitretin, if I'm correct, which is a synthetic analog which has been a boon in those cases in which steroids are not working or steroids are not indicated or you cannot use steroids for very many reasons. And he drew attention to the fact of patch testing, which is often asked. He said it works for dermatological lesions but may not be as useful in oral mucosal lichen planus. And please follow up at least annually if there are no high risk factors of lichen planus patients. Dr. Arvind drew attention to management, the role of doxycycline in addition to metronidazole, especially in gingival lesions, role of antihistamines, something which we all know there is lack of Indian literature regarding any of these facts. And when there is failure of therapy, do we tend to overtreat, and is this responsible for cancer or not? And Dr. Uma nicely summed up with our experience of 678 cases from the department and emphasized the fact that diagnostic delay is a very important critical factor in following up these patients, and we need to have a strict diagnostic criteria. And whatever we do, if the patient is referred to you, we should have a list of recommendations to the clinicians, just not opinions, so that they can manage the patient very usefully. Once again, let me thank all the panel speakers, and I'll then hand it over to the next. Yeah, I'll hand it over to Dr. Thomas. Dr. Thomas, thank you for waiting very, very patiently. I think we have just delayed a little bit. We look forward to your talk on AI.
Yeah. Okay, let me share my screen first. Um, good afternoon, everyone. And am I clear? Can you all hear me loud and clear? Yes.
Yes, sir.
So are we good to go? Right.
Yes, sir.
So first of all, I would like to thank you, thank Dr. Pratibha and all the organizers of this international conference on craniofacial pathology and biology for giving me an opportunity to share my views here. And I'm at this point, I think I should say that I'm actually intimidated after hearing all those eminent speakers, and I'm truly humbled to share the same platform as all of the eminent speakers. And I would like to say that most of what has been the major points for discussion has already been covered by all the speakers before me. So I will try to make it as short as possible. And probably since we are running short of time, I would probably not delay it very much. So yes, oral lichenoid diseases, and we have been hearing a lot about the controversy as whether, oral lichen planus is potentially malignant or not. And according to what we have gathered, oral lichen from the discussion so far, I mean, there's a strong view that probably oral lichen planus is not potentially malignant. And here we are, I mean, I've tried to use this terminology called as oral lichenoid diseases, and which basically encompasses lichen planus, lichenoid lesions, which includes contact reactions, oral lichenoid drug reactions, and the less common chronic graft-versus-host disease, lupus, and the recently recognized chronic ulcerative stomatitis. So we have, I think speakers before me have already discussed about the various diagnostic criteria. The first diagnostic criteria for oral lichen planus was published in 1978, and subsequently we had the modified WHO diagnostic criteria proposed by Van der Midge and Van der Waal, which came out in 2003. And the major criteria was to include both clinical and histopathological criteria for diagnosing oral lichen planus and oral lichenoid lesions. Subsequently, we had the American Association of Oral Maxillofacial Pathology diagnostic criteria. Then we had the criteria in 2020 by Aguirre and Oriza. So they basically brought about the concept of the verrucous architecture, and they mentioned that, and they emphasized that lesions with a verrucous architecture should not be included or should be excluded for a diagnosis of oral lichen planus. And then we have the latest criteria by the WHO Collaborating Center, which was published in 2021, and I think we have already discussed that as well. Now, the problem with all of these different diagnostic criteria is they're strict, they are pretty clear, but when it comes to clinical practice, what I have found that probably I may not be able to do justice in a true way. So eventually I end up diagnosing most of my cases as oral lichenoid lesions because they are either clinically compatible with oral lichen planus, or they may be clinically compatible with oral lichen planus and histologically consistent, or maybe the other way around. So the end result is how many true cases of lichen planus or lichen planus that we diagnose. And I was just listening to Dr. Anand with great interest, where he says, like any lesion that does not regress or resolve within a period of 6 to 8 weeks is definitely not lichen planus. So probably there's something that that I may have to reconsider. So because when we follow this diagnostic criteria and we're trying to, um, uh, base our clinical decision based on these established criteria, sometimes we might miss out the finer points. So yes, I'm particularly interested in this particular group, Gonzalez moles. They have been very strong advocates of including dysplasia within oral lichen planus, because previously the diagnostic criteria that we mentioned all have tried to exclude epithelial dysplasia in the diagnosis of lichen planus. But this particular group, they feel that there is a strong need to consider dysplasia exist. They feel that dysplasia do exist in lichen planus, and probably their agreement or argument is lichen dysplasia could eventually develop in the evolution of oral lichen planus. And this systematic review and meta-analysis that was published, they do find that when dysplasia is considered in the diagnosis of oral lichen planus, the malignant transformation rate actually jumps to about 5.13%. So this big, adds to a lot of confusion, so whether we consider dysplasia to eventually evolve or in lichen planus or not, or they are just part of the oral lichen adhesions. So, as I mentioned earlier, because as Prof. Ranganathan said, my talk is not entirely about AI, so it was discussing about the molecular aspects. So, at this point, we definitely know that, probably the malignant transformation rate is maybe underestimated because of the exclusion of dysplasia, or if we don't consider, or if we actually consider dysplasia, it may be overestimated. Secondly, the major problem that we face right now is about the low methodological quality of the studies, on lichen planus. So if we look at studies, majority of them are retrospective, and I can truly understand how difficult it is going to do. It's difficult to do a study with retrospective data because we've not seen the patients in the clinic. We do not know what actually is the clinical presentation. And there are so many factors that we need to consider, particularly of the overlap between oral lichen planus and oral lichen adhesions. So definitely the reason why this, malignant transformation rate, variation in the malignant transformation rate of oral lichen planus could be very well attributed to the methodological quality of the studies in oral lichen planus. And secondly, when we say we need to evaluate epithelial dysplasia, oral epithelial dysplasia in oral lichenoid disease, it's rather complex because there's a lot of resemblance of the key histological features of dysplasia with the features that you see in oral lichenoid disease. So as you can see here, what you see onto the left side is a case of lichen planus. You see a band of inflammatory infiltrate, and there is some degree of liquefaction degeneration. And what you see onto the right is a case clinically consistent or clinically consistent with oral lichenoid lesion, but you'd see a certain degree of epithelial dysplasia. So this was I just would like to draw a light on, shed some light on one of the studies that was done by one of the students in our department. And she was basically trying to look at all the histopathological features in oral lichen planus, oral lichenoid lesions. And we stratified the cases in such a way that, we also we consider oral lichenoid lesions stroke oral lichen planus with dysplasia as a separate group. So we had three groups of cases. We had three cohorts, like true oral lichen planus, oral lichenoid lesions, and then oral lichenoid lesions stroke OLP with dysplasia. So as you can observe here, we did find that some of the features are consistently seen on those cases which actually were graded to have dysplasia. So for example, premature keratinization in single cells, generalized premature keratinization, all those cases which manifested dysplasia had these features. Now, is it actually a dysplastic feature? Because we know the whole process of lichen planus, the pathogenesis of lichen planus. There is an abnormal differentiation of epithelial cells, that there's an alteration in epithelial turnover. So obviously we tend to see, there's a certain degree of keratinization in lichen planus. So do we consider that as a true dysplastic feature? Because if that is the case, then probably, we may be seeing more and more of dysplasia in oral lichen planus. So if we follow the strict epithelial dysplasia diagnostic criteria, then obviously we might end up having some results like this. Similarly, some of the cytological features like increased number and size of nucleoli were very prominent. Similarly, increased nuclear size were prominent. So these cytological features, are they I mean, are they normally seen in cases of lichen planus, or do we actually consider them as true dysplastic features? Is something that needs to be debated. So my point here is when we actually grade dysplasia, we could either underestimate dysplasia, or sometimes when we are grading dysplasia, we probably could overestimate the dysplasia. So generally, I would suggest that at any point when you suspect dysplasia in cases which are clinically consistent or compatible with lichen planus or lichenoid lesions, definitely need to get a consensus diagnosis. So probably we need, grading dysplasia alone or may not be the right way to go. So just a summary of the factors that probably are associated with the higher risk of malignant transformation. Yes, we have already discussed this earlier, particularly association with habits like tobacco and alcohol, and lesions located on the tongue, and very characteristically atrophic and erosive lesions. And Dr. Anand did mention about one of his cases that occurred on the tongue, and which he said is very difficult to treat and eventually transform into a malignancy. So what probably would drive malignant transformation in oral lichenoid diseases? Now, I'm trying to use the terminology oral lichenoid disease because we are trying to look at both lichen planus and oral lichenoid lesions. So we can assume, we can hypothesize that in these group of diseases, there is increased epithelial proliferation, there is evasion of growth suppressive signals, and obviously there's also lack of apoptosis. So why does it happen that way is because the inflammatory infiltrate that you see in the background of these disorders or diseases infiltrates or attacks the basal layer of epithelium, and also the effects, there's also increased effects induced by the chemokines, the growth factors produced by the inflammatory infiltrate. So we are talking about alterations that the inflammatory infiltrate will generate in the basal epithelial cells, as well as the chemokines, the growth factors produced by the inflammatory infiltrate on the basal cells. So how will the basal cells eventually respond? They are primarily being targeted here, they are primarily being attacked here, and they will eventually respond with an increased proliferative activity. And also some of these apoptotic mechanisms will become inhibited, and that will generate a favorable background for the development of cancer predisposing mutations in these group of disorders. So what I was trying to hypothesize, or because this is already generally very well acceptable and probably known to all of you, but we're just trying to recapitulate the mechanisms that probably would drive malignant transformation in oral lichenoid diseases, whether it's lichen planus or lichenoid lesions. So my questions that were posed for the discussion today is, can molecular alterations and biomarkers meaningfully change current risk models? And are we ready to integrate molecular diagnostics into routine clinical decision making? What type of studies are needed to settle the OPM debate, including longitudinal cohorts, molecular profiling, and AI-based risk models? So I just try to gather some information. Probably there's actually very limited number of studies that look into molecular alterations in oral lichen planus, and there are no good systematic reviews, there are no good meta-analysis that looks into this aspect of oral lichen planus. So primarily what we have is all primary studies, so probably they need to be still debated whether the inclusion and exclusion criteria were appropriate, particularly when we are looking at a whole problem of correct diagnosis. So there are some studies where they say cyclin D1s, which stimulate epithelial proliferation, are overexpressed in patients with lichen planus when compared to healthy controls. And this is primarily due to the activation of the MAP kinase pathway and the PIK3 and the AKT pathways as well. So this is quite well documented. So that whether expression of cyclin D1 can be used to stratify cases that probably behave deviantly. Probably we could, try to stratify those atrophic or erosive lesions of lichen planus and see whether there's any overexpression of these different proteins like cyclin D1. As I mentioned, these proliferating cells, particularly, they tend to evade growth suppressor signals, and we should definitely expect to see uh, uh, dysregulation of tumor suppressor genes like retinoblastoma gene and P53, in those cases that probably are not resolving, that probably tend to behave, more aggressively. And actually, there are very limited studies that have looked into the aspect of neoangiogenesis and its influence on the molecular transformation of lichen planus. Because the reason why we bring in neoangiogenesis here is because the inflammatory infiltrate can generate a lot of paracrine factors, and they can produce pro-angiogenic factors, like in a paracrine manner, and that eventually could drive angiogenesis and also probably influence malignant transformation in lichen planus. So this is something that probably needs to be looked into, whether this can evolve as probably a risk stratification factor for cases of lichen planus and lichenoid lesions. As far as a malignant transformation is concerned, probably would need further research. There are limited reviews. There are very few systematic reviews and meta-analysis that have looked into, epithelial mesenchymal transition in lichen planus. So a lot of these markers, particularly E-cadherin, vimentin, the transcription factors like snail, slug, twist, which are all quite well established with EMT, could be studied in cases of lichen planus, and probably we could find out whether they can use expression of these different transcription factors in different groups of lichen planus, lichenoid lesions, can be used as a stratification of can be used for stratification risk. And yes, I need to mention about the role of NF-kappa beta in low lichen planus. We all know that chronic inflammatory conditions, like there is dysregulated activation of NF-kappa beta, and that should occur in oral lichen planus as well. And when there is dysregulated activation of NF-kappa beta, you could expect to see overexpression of certain tumor-promoting genes like COX2, as well as cyclin D1, BCL2, and MMP9, so which are all associated with different aspects like cell proliferation, survival, inflammation, tumor promotion, and metastasis. So this is an area that probably has not been explored much as far as OLP and OLL is concerned. And lastly, we do mention about the role of CD8 cytotoxic cells. We know the role of CD8 cytotoxic T cells in driving epithelial injury in lichen planus. And we also need to understand the role of the FOXP3 regulatory T cells, which is primarily involved in maintaining the immunological homeostasis. So, AI could come here, the role of AI, because we could actually correlate the different densities of the CD8 cytotoxic T cells, the CD8 TRM cells, or the tissue resident memory cells, as well as how they all interplay together with the FOXP3 regulatory cells, could provide some evidence on whether there is in any way this could be used for the risk stratification. And we have seen that the density of the FOXP3 cells, it has been discussed that are more in those lesions which exhibit atrophic and erosive clinical features. So I think that's basically all I have to summarize. Thank you.
Thank you so much, Dr. Thomas. I think there's been a very long wait for you, but I think you have sort of compiled something, a new jogren of lichen planus, this lichenoid reaction sort of thing, which is molecularly still not very much deciphered. Thank you so much, Doctor. Thank you so much.
Yeah. Always welcome, Prof. Pratibha.
Doctor, can we come back to you a little later for the photograph session? You can, I will call you, Doc.
Sure, sure.
Thank you, thank you.
Thanks for that very sincere thought of sharing your own health experiences. It mattered a lot. Thank you so much, sir. Arvind, sir, please come over to the stage. Thank you so much, sir, for your valuable contribution and your knowledge sharing. Dr. Uma, ma'am, please come. Thank you so much, ma'am, for sharing the college data and made us realize the rich data which we have with us. Thank you so much. And let us all gather together for a very important photo shoot. And we hope to publish this as early as possible. Yes. Yeah.
Check, check.
Good afternoon, everyone. I'm very happy to welcome Dr. Isaac Demirel, who's currently an associate professor in the University of Örebro, Sweden, to our international conference of craniofacial pathology and biology. I'm very happy to welcome sir and for him to have accepted to give this lecture on host pathogen interactions. So I welcome Dr. Arvind Babu sir, Professor and Head, Department of Oral Pathology from Balaji Dental College. Dr. Sashidhar sir, Professor and Head from Coorg Institute of Dental Sciences. And Dr. Rajkumari ma'am to kindly moderate the session. Come on stage and moderate the session. So Dr. Isaac, has guided numerous PhD students and has more than 45 publications in national and international journals. And sir has received research grants of more than 34 million Swedish currency. So we are very happy for sir that he accepted to come here and guide us and enlighten us on this very important topic which he has been working on for a very long time, host pathogen interactions, and he's made it as friendly to dental people as possible. So we're very happy to have you here, sir. Thank you, sir.
Thank you so much. Can you hear me well? Firstly, I would like to thank the arranging committee for inviting me here today to give this lecture. So the title of my lecture is Host Pathogen Interaction, from Mechanism to Therapeutic Opportunities. Just a short academic background. I'm not a clinician, and I will stress on that, but I have clinicians in my research team that tell me what we need to do in order to find the molecular mechanisms that the clinicians need. So I started my training as a PhD student at Örebro University, and what I started with was uropathogenic E. coli, and we studied the host pathogen interaction and also investigating multi-resistance. Thank you. So my journey in host pathogen interaction started there, and then I did a short but very important postdoc session with Professor Torbjörn Bengtsson, and it was there where I came in contact with periodontitis and the link to systemic disease. So what we did there was actually to study the link between periodontitis and cardiovascular disease. And then I moved back to inflammasome research in E. coli, and then I became a senior lecturer and an associate professor. And from 2019, I started my own research group, and we call ourselves Infection and Inflammation Group. And what we study is host pathogen interaction, we study kidney inflammation, bacterial virulence, and periodontal disease, the links between periodontal disease and different systemic diseases. And I'll come back to, so many parts of this presentation are very basic, just some examples also why I think this is important and where it will take us. But before I start, I would like to show you the research group, the many people that actually do the work. So, as I said, I'm not a clinician. I have a postdoc, Rongrong Wu, who's a medical doctor from China. Ah, thank you. Can you hear me better now? Yes, thank you. So, I have a postdoc, Rongrong Wu, who is a medical doctor from China. She's actually working in the lab. And of course, we have dentists connected to the group. We have Alessandra Nieves Guaiteres, who is a specialist in periodontal specialty. And my wife, Kartiaini Demirel, who actually studied at Saveetha Dental College and doing her residentship in orofacial medicine. Kartiaini also did her PhD at Örebro University in basic medicine, studying cardiovascular disease and the immune system. And Maria Svensson, who is a biomedical researcher, and two ongoing PhD students, Yvette Kindlund, who is a dentist, and Anna Magnusson, who also is a specialist in periodontal disease. And she's studying the link between periodontal disease and Alzheimer's, and I will come back to that. And two PhD students, Carolina Pettersson, and we are now recruiting Liv Sundqvist into the research group also. So these are the people who are doing majority of the work, but I still try to be in the lab because I think it's very fun to be in the lab. So host pathogen interaction, what is it? It describes the dynamic biological battle between the host and the microorganisms. And this continues in our body every day, and different time points will have a different winner. So the disease outcome will actually depend on who is the winner for the moment, and if we can control these pathogens, or if these pathogens will actually try to modulate, invade, or suppress our immune responses.
Many people have touched about the immune response, and different types of immune responses are important for different types of bacteria. We have the innate immunity. Innate immunity is very important for a urinary tract infection. As you know, we have the barriers, we have the skin, we have the mucosa, we have the epithelial cells, the neutrophils, the very important receptors like toll-like receptors and nod-like receptors to recognize the pathogens and try to eradicate them. And then we have the adaptive immunity also that is more specific, and we have the antigen presenting, the B and T cells, and of course it has a memory. But I will come back to the importance of this. So if we look at the pathogens, why is it so important to understand the pathogens? What can the pathogens tell us? Well, in order to treat an infection, I think we need to understand the pathogens very specifically. What makes them pathogenic? Why are they not commensal? We have asymptomatic infections also. Is this a line between commensal, asymptomatic, and pathogenic bacteria? So pathogens have different virulence factors, and some key virulence factors are, for instance, different fimbria. Sometimes it's very, very important to adhere to the epithelial cell layer. For instance, in the urinary tract, if you don't adhere, you're just peed out and the infection will basically never establish. So you have different virulence factors like fimbria or adhesins. Some bacteria also need to invade the human host in order to establish an infection. As many of you know, some women suffer from recurrent urinary tract infections, and we didn't really understand why these women suffered from recurrent urinary tract infection until we understood that the bacteria actually had an intracellular life cycle. So the bacteria binds to the cells, invades them, and when it's invaded the bacteria, they form something that we call intracellular bacterial communities. Neutrophils cannot kill them, antibiotics cannot kill them, and when all the extracellular bacteria are dead, the bacteria will come out and start a new infection. So this is why some women have recurrences. So we need to understand this in order to find treatments. Some antibiotics are better at killing intracellular bacteria like cephalosporins, and some are not. So we should choose our antibiotics carefully. And different pathogens, of course, have immunoevasion mechanisms. You have the capsule that will prevent opsonization and phagocytosis of the bacteria. You have antigen variation. Not all bacteria are the same. We say LPS, LPS, endotoxin, LPS, but we have the O antigen that is not the same. Hence, we cannot develop a simple vaccine against the O antigen because the O antigen is different due to antigenic variation. And then specific virulence factors. They have toxins, they have secretory systems. Toxins, I was just talking before my presentation that I have a colleague in Umeå. He's trying to convince us that we should have guava extract in toothpaste. Why? The guava extract blocks toxins. It blocks the activity of pore-forming toxins. So would that be interesting to give it locally in the bladder, or maybe in a toothpaste, or maybe in a mouthwash to try to block the toxin? And why is the toxin important? Bacteria need micronutrients. It needs iron. So that's the purpose of lysing cells. And of course, host manipulation, altering signaling, metabolism, inflammation. And the bacteria are extremely smart. They block what they need for the moment. And this could shift very quickly within minutes to hours, depending. And I'll come back to some examples of this after. So what is the outcome? We can clear the pathogen and we will be healthy. We can control the persistence and we'll get a chronic infection or inflammation like periodontitis. Or we can have a dysregulated response and we can have tissue damage. So we need different types of understanding and different types of treatments for different occasions. So why does this field matter? Why do we think that host-pathogen interaction is interesting? So we can understand why different individuals have different types of infection. It's not only the individual's immune response. It's not the single nucleotide polymorphism. It's also the pathogen. Which strain is it? So we have to understand it in order to treat it. And also to link it to different chronic infection to systemic disease. I said that I did my postdoc, and Kartiaini also studied periodontitis linked to cardiovascular disease. As you know, many of you, you're dentists, diabetes, rheumatoid arthritis, and so on and so on. So the effects of chronic infection is very important of systemic disease. And also to guide us in developing treatments, vaccine development, antimicrobial strategies beyond antibiotics, like antivirulence treatments, and also host-derived therapies. Should we boost the immune response? Should we suppress it? Or should we do both at different time points? These are different virulence factors. I don't remember exactly what they're called in the full name. But I'll give you an example. You can inhibit the toll-like receptors to reduce the induction of the immune system so they're not recognized. You can inhibit the P-selectin rolling. You can inhibit the transmigration through the endothelium. They have proteolytic enzymes to cleave the receptors and also to block ICAM1. So one bacteria can severely suppress the recruitment of phagocytes. If we stick with Staph aureus, it has also developed different additional virulence factors to block phagocytosis. It has a virulence factor called SPA, and this virulence factor, what it does is that it binds to the Fc region of the antibody. So if you bind to the Fc region of the antibody, the phagocyte cannot bind with the Fc receptor, and then you will have a suppressed phagocytosis. So it blocks the recruitment, and it blocks the phagocytosis also, or reduces it. If we move on to modulation of the cytoskeleton, we can take Yersinia pestis as an example. This is a cropped picture. It has actually many mechanisms to try to suppress actin polarization. And one of them is an outer protein H, UpH, that is a tyrosine phosphatase. So it dephosphorylizes this FAC and paxillin. And basically by doing this, it inhibits the initial phagocytosis because the actin is not polarized. And then, of course, we have Mycobacterium tuberculosis. And Mycobacterium tuberculosis have developed different strategies, and many of them to actually survive in macrophages. So it has different virulence factors like PIM, LAM, PI3P, and all of this is to just arrest the phagosome maturation. And it can also inhibit the acidification, it can inhibit the fusion, and it can also inhibit the reactive oxygen species by inhibiting NADPH oxidase. So then why is this important? If we can block some of these virulence factors, maybe the macrophages could actually kill the bacteria. We don't have to kill the bacteria, the immune system will do it for us. But we need to understand how the bacteria is actually subverting the immune response in order to try to develop different therapeutical drugs. So that was just a short introduction why we are doing what we do. So in our group, we do different types of research. Of course, I started in urinary tract infection, and this is still a very interesting research area for me. And the research question is, how does uropathogenic E. coli interact with the urinary tract, and which virulence factors does it use to actually colonize the bacteria? And we are continuing with how Porphyromonas gingivalis and Agricobacter actinomycetum comitans, AA, I will call it from now on, contributes to oral disease and systemic disease. And I will talk a bit about that to give you a perspective of what we do and how we also could collaborate, hopefully, in the future. And a new research area that we have developed the last couple of years is that we have shifted our research focus. So we always talk about how our immune response is sensing the bacteria through toll-like receptor, NOD1 receptors, and so on and so forth, to try to mobilize a control immune response to try to kill them. We have reversed the question, and what we ask now is, how does the bacteria sense us? Because bacteria are smart. They don't always express their virulence factors. It's a fitness cost. They shut off and turn on different virulence factors with riboswitches just to preserve energy. And what we're focusing on is pro-inflammatory cytokines. There was a very nice paper a couple of years ago who showed that human pro-inflammatory cytokines can actually work as transcription factor in bacteria. They will take them up, and those pro-inflammatory cytokines will regulate the bacterial expression. And other things that we're also interested in is hormones, especially estrogen and testosterone. Can the bacteria sense human estrogen and testosterone, and can this be a trigger or a suppression of their virulence? And we recently got a grant, an external grant that we're very happy with. And in this grant, what we're trying to do is to see if the microbiota-derived metabolite that we call TMAO is contributing to the development of kidney disease, cardiovascular disease, and periodontitis. And what we try to see with this dietary metabolite is that if it's actually a common link between these three diseases. And if I have time, I will continue. The project just started, and we're very happy. So I will give you some examples about the research that we do at Örebro University. We're very molecular, so we're trying to understand the molecular mechanisms of it, and I'll give you some examples of some papers. So we were discussing, the previous talkers were discussing titanium. And of course, there is coming more and more evidence that titanium could actually induce particle-induced inflammation, and especially titanium ions. And they have seen that in Umeå University up north. And what these titanium ions actually do is that they induce the NLRP3 inflammasome. And this is a multi-protein complex that is very interesting for cytokine production. So we wanted to understand if this NLRP3 inflammasome is important for urinary tract infection, and I'll tell you why. So sometimes you have an infection, and of course the infection causes disease, but the infection will actually initiate an inflammation that will aggravate the infection. So in cystitis, we know that if the immune response, especially IL-1 beta, is activated, at the late stage it will aggravate the infection, because the bacteria will go deeper into the epithelial cell layer. And this NLRP3 inflammasome is the contributor to IL-1 beta trigger. So the aim was to study and elucidate which virulence factor in uropathogenic E. coli, UPEC, can actually trigger this NLRP3 inflammasome and IL-1 beta release. And if NLRP3 per se can actually contribute to the colonization and bladder of bladder cells. So just short about what NLRP3 is. So the NLRP3 inflammasome is a multi-protein complex, and it's intracellular. So what it does is that it actually reacts to cell stress. So if you have an infection, what will happen first is that you will have an upregulation of the NLRP3 complexes at an mRNA level. Later on, if there is like a toxin that creates a pore in the cell, you will have a calcium influx, you will have a lysosome rupture, and this will also lead to the mitochondrial ROS production that will lead to the NLRP3 inflammasome assembling. This NLRP3 inflammasome will assemble, and it will activate caspase 1. Caspase 1 will cleave pro-IL-1 beta and pro-IL-18 from their pro form into their active form. And only then are they pro-inflammatory. And then IL-1 beta and IL-18 are very interesting. They don't have the secretory mark on them to be released by the ER or the Golgi. How they come out from the cell is actually through pyroptosis. Not apoptosis, but pyroptosis. And the difference is that pyroptosis induces inflammation. So the way for it to get out of the cells is for the cell to die. So I will show you some of the data, and these results I will go through. It's very simple. These results are based on bladder epithelial cells. So we asked ourselves first, can pathogenic E. coli, CFT03, induce IL-1 beta release from bladder epithelial cells? Yes, they could. We have a strong induction of IL-1 beta release, but A commensal E. coli does not. MG1655 is just a commensal strain. So there's something in the pathogenic bacteria that triggers the bladder to induce IL-1 beta. And as I said, it's linked to cell death. So you have lactate dehydrogenase. If it's extracellular, it's linked to pyroptosis. So we see that the bacteria actually kills the cells in the same time point where we have an inflammation, but the non-pathogenic doesn't. We also wanted to know, when you do experimental studies, you need to be very thorough to understand the molecular mechanism. So we did a caspase-1 activity assay where we have an amino acid sequence with a fluorescent dye. And if the amino acid sequence is cleaved, the fluorescent dye will increase, and we saw that caspase-1 activation is increased. And we also saw with Western blot that the protein is actually reduced, and you see the different bands that it's cleaved, caspase-1, and that NLRP3, the NLRP3 that we think is mediating IL-1 beta, there's different inflammasome that it's actually consumed. And this tells us that caspase-1 and NLRP3 is probably what's inducing IL-1 beta. So we know that pathogenic E. coli induces IL-1 beta and non-pathogenic bacteria don't. So what is it in the pathogenic bacteria that triggers? So we created knockouts of the different virulence factors in the bacteria. The PUP is the type 1 fimbria that is very important for the kidney infection, pyelonephritis. We have FIMH that is a knockout of type 1 fimbria. If you don't have type 1 fimbria, you cannot colonize the urinary tract because it binds to the bladder epithelium. And then we had hemolysin, alpha hemolysin. And when we knocked out hemolysin, we saw drastic reduction of IL-1 beta. So basically what this tells us is that the IL-1 beta released from bladder epithelium is alpha hemolysin driven. Okay, so maybe we should try in the future to block alpha hemolysin. And when we complement it, we see that it reduces. And an additional thing that we saw that was very interesting, and I'll come back to it, is the fimbria. So E. coli is very smart, exactly like Porphyromonas gingivalis. It doesn't always activate all its virulence factors, but here we did a ribosome lock that the type 1 fimbria is always active. And when the fimbria is always active, it also suppresses IL-1 beta. And in this phenotype, alpha hemolysin is still there. So although the pour is happening, we don't have IL-1 beta release. And we just had a quick talk now before I presented if we use CRISPR-Cas system. We use the CRISPR-Cas system to knock out the caspase-1 and NLRP3. You can see the NLRP3 here. And we did a knockout to really, really prove that it is NLRP3 dependent. And what we see is that when we knock out NLRP3 in the bladder epithelial, a stable knockout. So this cell line is just frozen in liquid nitrogen and we can use it forever. That IL-1 beta release is completely dependent on NLRP3. And as I said, women have recurrent urinary tract infection. So to study intracellular invasion of bladder epithelium is very important for us to try to understand the mechanism and in the future to block it. So what we saw when we generated these CRISPR cells was that when we knock out caspase-1, there's no difference in colonization or invasion of epithelium. But when we knock out NLRP3, we see a 50% reduction or a complete reduction in invasion. So NLRP3 is driving the inflammation, IL-1 beta inflammation, and it also contributes to the bacteria's ability to actually invade and colonize the cells. So what could we conclude from this? We can conclude that it's quite complex to understand the host-pathogen interaction. The bacteria uses different virulence factors alone, in combination, at different time points to do different things. So you have the alpha hemolysin. Alpha hemolysin triggers the inflammasome activation. Type 1 fimbria that is so important to binding, so the bacteria doesn't get flushed out, actually blocks IL-1 beta. But why is this important? If you block IL-1 beta, the infection will not get aggravated. But in the beginning of the infection, what do you want to do? In the beginning of the infection, the bacteria wants to suppress the immune response to be ordered to colonize. That's the primary. Bind, delay the neutrophil influx. If you can delay the neutrophil influx, those 5 bacteria will become 10,000, 1 million, a billion bacteria within a couple of hours. So first block and then activate the inflammation to aggravate the infection. So what we hope to do here is to understand it and try to develop different strategies here. For instance, alpha-hemolysin. Interesting, when our Anders Johansson in Umeå told me to try to use guava, what he also told me that his hypothesis is that the guava extract could, in theory, also block alpha-hemolysin, because the toxins in the AA bacteria and alpha-hemolysin are from the same family. So we will also try to see, because it's quite easy to give locally if you're in the urology department with the catheter to try to block alpha-hemolysin as a treatment. Okay, let's move on to something maybe a bit more interesting and related to this campus. So Anna Magnusson, my PhD student, she's studying the link between periodontal disease and Alzheimer's. And we have published a paper quite recently where we studied Porphyromonas gingivalis and how it triggers microglia activation and neurodegenerative processes through NOX4 in microglia cells. So what we aim to do is try to understand the interaction between the bacteria and the microglia cells and also see if it can contribute to Alzheimer's disease pathology. So a couple of years ago, there was an American group who said that they actually found the bacteria in the brain of Alzheimer's patients. Did it contribute to disease? Did the bacteria come there after the patient deceased? Nobody really knew. But the research kicked in. A lot of people started to do mice trials. They started to do cellular experiments. And what they found was actually that the bacteria and its outer membrane vesicles could actually penetrate the blood-brain barrier. The gingipains of this bacteria could actively pass the blood-brain barrier, but also damage it in its way to enter. So what happens that they have seen in mouse studies and on cellular levels, tau pathology, amyloid plaque accumulation, and neuroinflammation. So this is where we started to try to see if we can see something. And in this paper, we try to understand the molecular mechanisms, but we have an ongoing clinical study where we have gotten biobank material from people under investigation for Alzheimer's disease, that they leave their samples, their cerebrospinal fluid, and it's in the biobank. So we kindly asked if we could use the leftovers to try to see if we can find bacterial DNA. We are trying to see if we can find bacterial virulence factors and also to link these levels to clinical parameters, x-rays, dental tooth numbers, and so on and so forth. So the work is ongoing. She's actually writing the manuscript now. So we usually say in biomedicine that we go out for a fishing expedition. We don't know what we're going to find, so let's start broad. So we did the microarray analysis where we look at the whole genome expression of the microglia cells. So we infected the microglia cells with the wild type Porphyromonas gingivalis strain, W50, and gingipain mutants, because we wanted to know if the gingipains are important for the interaction. And E8 is an arginine gingipain, and then we have K1A that is a lysine. And what we could see is that we have an induction of genes that have been clustered to be linked to Alzheimer's disease. And then when we have the mutants, we see that the arginine gingipain probably is what mediates this induction. And something that we got stuck with when we started to read the literature after seeing this data was NOX4, NADPH oxidase 4. This is an isoform that has been linked to Alzheimer's disease, and we know that it's actually in the pipeline that they're trying to develop drugs to try to block NOx4. So NOx4 produces reactive oxygen species, and we wanted to evaluate this, and we did an assay with a probe for intracellular ROS production, and we saw an induction of the bacteria of ROS after 24 and 48 hours. Then, just because we have a ROS production doesn't mean that it's NOx4 dependent. So we bought a commercially available drug that blocks specifically NOx4 and not NOx1, NOx2, and NOx3. And what we saw was that the ROS induction was suppressed, both by the bacteria, the P. gingivalis LPS. We use LPS as a positive control, and also PMA. PMA is a PKC inducer and produces ROS. And we also validated through Western blot that the protein expression of the NOx4 is actually upregulated after the infection. Okay, so ROS production is induced. As we work very molecular, we also wanted to understand the downstream regulators. We want to understand which pathways are induced to be able to block them. When I got my basic education 10, 14 years ago, I never thought that we would have these immunomodulatory drugs that we have today. So who says that we will not develop drugs against these pathways in the future that could benefit also Alzheimer's disease? So what we saw was that if we block P38 of the MAP kinase, we had a reduction of ROS and also ERK. These are the same family, and then PKC also, but not NF-kappa B. That is a major driver of inflammation. So it's the MAP kinase pathway that is more important, NOx4 and the MAP kinase pathway. We also wanted to see if this NOx4 induction triggers inflammation. You have neuroinflammation, and we chose two cytokines, IL-6, that is a pro-inflammatory cytokine, and IL-8, that is a chemokine for neutrophil, just to visualize this. And the biggest problem with working with oral pathogen, especially Porphyromonas gingivalis, is that it has these gingipains. The gingipains will cleave every protein you're trying to investigate. So you can basically not see it. The protein will be expressed and quickly it will be cleaved. It will mediate effect, but you will miss it automatically. So you need to study the gene level and have other controls like P. gingivalis LPS. So to prove this concept, we stimulated the microglia cells with P. gingivalis LPS, and we saw that when you add the NOx4 inhibitor, the inflammation was reduced, completely abolished. So the inflammation induced by the bacteria is NOx4 driven. So this was also very interesting. Okay, we have the microglia cells, but what about the neurons? Can the milieu that the microglia actually affect the neurons? So what we did is that we infected the microglia cells 24 and 48 hours. We took the medium of everything the microglia cells release. We called it conditioned medium. We sterile filter it. When you sterile filter it, you get rid of every bacteria, but you'll have the bacterial components. You will have everything that the cells have released. So we took this conditioned medium and we stimulated neurons. When we stimulated the neurons, we saw that the viability of the neurons actually reduced. So whatever the bacteria is triggering in the microglia cells is killing the neurons. And when we block NOx4 in the neurons, this cytotoxicity is completely abolished. So whatever is killing the neurons mediated by the microglia is NOx4. So now NOx4 is becoming an even better candidate to block as a treatment in our eyes. We also wanted to look at tau pathology, and we saw that total tau was increased by the bacteria and LPS, and again, total tau and phosphorylated tau. Again, when we block NOx4, we see a complete reduction of the tau pathology. So in our eyes, we do see that there could be a possible link between oral pathogens like Porphyromonas gingivalis, because it can actually contribute to these mechanisms that aggravate and maybe initiate Alzheimer's disease. And so we believe in this hypothesis that the oral microbiome could probably contribute to Alzheimer's disease. It may not trigger it, but definitely contribute through systemic inflammation, by going into the brain through the blood-brain barrier. And our unpublished data that Anna is writing right now shows that almost all individuals, every Alzheimer's patient, we found gingipains in their cerebrospinal fluid. So there's traces of these bacteria in every patient. So we hope to submit the paper and publish it soon. We have also, of course, different studies linked to cardiovascular disease, but I'm just giving you some examples of the research that we are doing. And now I will shift to this cross-kingdom interaction, our new field, where we ask ourselves if the pathogens can actually sense us. Can they sense us? Can they adapt to us? And can they regulate their virulence depending on us? And we have studied estrogen. We have studied testosterone, both in E. coli and in P. gingivalis, and we're also moving on to AA. So as I said previously, we have host pathogen, we have these pathogen recognition receptors, toll-like receptors, like toll-like receptor 4 is specific for LPS, endotoxin in bacteria to recognize it. But the bacteria also have a set of sensory systems to recognize us. They're not necessarily there to only recognize us. The PHOP, PHOQ system recognizing magnesium. It recognizes levels. It recognizes antimicrobial peptide. It recognizes cholesterol. We have QACC, another system, and we have CPXA in E. coli bacteria. CPXA just recognizes primarily membrane stress. Is something happening to the membrane stress? But probably through evolution that we have developed side by side, they also started to recognize human molecules in order to adapt to us. So this is a bidirectional sensing by the pathogen and the human host in order to regulate infection, and also for the pathogen to regulate its fitness, its virulence factors. So what we try to do in our research group now is try to think differently. Every time we put selection pressure on a pathogen, it will more or less develop resistance. This is what happens. E. coli divides every 20 to 30 minutes. One small mutation will always happen in that billion bacteria, and that bacteria will grow and continue the infection or spread to the next person. So what happens if we don't put selection pressure? Instead, we do antivirulence treatment. We try to block the virulence so the bacteria doesn't get stressed by us. In my head, there's an evolution. You have commensals. I think the commensal bacteria have evolved the most. You have the asymptomatic that cause asymptomatic infection, like urinary tract infection, and then you have the pathogens. I mean, what reason does a bacteria, a parasite, have to kill us? We're their host. If they kill us, they will not get nutrients. So I think this is about that evolution has not taken its path, and I think they're moving slowly against commensals. Why not live in symbiosis instead of killing each other? So why do we study estrogen and testosterone in E. coli, in urinary tract infection? As you know, estrogen is extremely important for the woman, and when she goes into menopause, she'll get more recurrent urinary tract infection because estrogen boosts the immune system, the epithelial thickness, the gag layer, it induces antimicrobial peptides and everything. When this disappears, everything will be reduced. The thickness, the gag layer, the antimicrobial peptide, the tight junctions between the cells. So of course, more urinary tract infections will happen. Testosterone, on the other hand, testosterone actually aggravates infections. Testosterone has an immunosuppressive effect. It blocks NF-kappa B, it blocks antibody production, and so on and so forth. That's why some men, although we have less urinary tract infection, they're more severe when we get them. So, if estrogen boosts the immune response and testosterone actually suppresses the immune response, we asked ourselves, could we see this? Could these hormones actually affect the bacteria? So our hypothesis from the beginning was that estrogen should make the bacteria less virulent. That would make sense because that's what we see in the patients. High estrogen levels protects the host. And is it only the immune response? So we have published a couple of data, and I just want to show this side by side. So what we found was that estrogen reduces the virulence of E. coli. And we did a very simple assay with the C. elegans worms. This is a very simple cytotoxicity assay where we stimulated the bacteria with estradiol, different concentrations, premenopausal and postmenopausal concentrations. Then it's important to wash the bacteria because you don't want the estrogen to affect the worm. So the estrogen has worked on the bacteria for 24 hours. You wash off the estrogen, they're just primed. And what we saw was that the pathogen without estrogen killed 80% of the worms after 10 hours. After they've been exposed to estrogen, almost all the worms survived after 10 hours. So something is happening to the bacteria that makes them less virulent. If we look at testosterone in the same level, in the same way, we see that testosterone does the opposite. It actually increases the virulence of the E. coli bacteria, dose dependent. The higher concentration of testosterone, the quicker the worms died. And right now we have a big study ongoing to try to understand what is it that is actually happening to the bacteria. I can tell you that what is happening to the bacteria is huge. Everything has changed about the bacteria. And it's linked to these systems. These are master regulators. Each of these systems regulate approximately 600 genes by themselves. So we have seen that these systems are affected by the hormones. Okay, I told Kartiaini, can you tell me, would these hormones be interesting to study in oral disease? She like, yes. I asked her also, is there any differences between male and female? She like, not that I really know, if I understood her correct. But then she's been telling me for a couple of years about the African population that had this aggressive periodontitis, if I'm saying that. They lose their teeth very quickly in puberty. So this made me quite interested. So I convinced her that we should do this also, to look at Porphyromonas gingivalis. And Yvette, our new recent PhD student, is studying this. So what do we know today? We know that estrogen levels vary. Of course, in pregnancy, people have promoted gingival inflammation and so on. And then also postmenopausal, you have declined, this alveolar bone loss is also increased. So there is links to why we should try to study this. We also know that Porphyromonas gingivalis can actually metabolize androgens, and by metabolizing them, maybe it uses this for its fitness. So due to these hormonal fluctuations in puberty, pregnancy, and menopause, we thought that it could be interesting. And I also had an interest to see, is all bacteria reacting the same to hormones, or do different bacteria react differently? So this is just a summary of the published data that we have. So what we saw was opposite compared to E. coli. When we stimulated P. gingivalis with estrogen, the virulence did not reduce. The virulence actually increased. The hormone increased the bacterial growth. The hormone increased the biofilm formation. It increased the release of these gingipains. So all of this is key virulence factors in this bacteria. And we also took gingival epithelial cells just to see if the bacteria will increase the binding and the invasion of the cells. And we saw that also. So this was a bit surprising to us, that it actually affects different bacteria differently. But if you think about the clinical setup, if what Kartiani says is true, that there's really no differences between male and female, why not? Why not? So what we are doing right now is trying this on testosterone. So is there any difference between estrogen and testosterone, like we see in E. coli? And I can tell you the data is unpublished, but estrogen and testosterone react the same in Porphyromonas gingivalis. They don't have opposite effect. So both of them make the bacteria more virulent. So hopefully we can get our hands on a clinical cohort that is there in Umeå in north of Sweden from African population to try to see if we can link the levels of these hormones to the outcome of aggressive periodontitis in this population. So if we move on a bit to why this is important. So as I said previously, if we put selection pressure on bacteria, I went to Dubai. I always fall sick when I come to India, every time. So Kadi said, please take some antibiotics prophylactic. In Sweden, to get antibiotics, go to the doctor. If you're lucky, you should pray to God that you will meet the doctor. It will take a week to meet the doctor. And then he will say, no sir, why take antibiotics? 10 days antibiotic, you'll be cured. 10 days without antibiotic, you'll also be cured. So keep off the antibiotics. I went to Dubai, I said, can I get metronidazole? Yes sir, no question why, I just got it. So I'm very happy for that. Very simple. Same thing in Dubai, probably same thing in India, Africa, China. So we have an increased problem with antibiotic resistance here. So in the Western world, they talk about this a lot. So the mindset is to try to avoid this and think about new strategies. Try to block the molecular pathways. The immunomodulatory drugs that we have today, anti-TNF and so on and so forth, as I said, I never thought this would actually come to clinic. But we're thinking in the same way, but for the bacteria. Block the bacterial pathways. If you block the bacterial pathways, the bacteria will become less virulent and you don't have to kill it. It will become like a commensal and you can live in peace with each other. So shift the thought here. So this cross-kingdom interaction is very important for us in order to understand which pathways should we actually focus on to try to develop this. And this precision medicine is very popular right now in EU. To get EU grants in Sweden, you have to talk about precision medicine. How do I treat you, but not you? How do I treat a child compared to a grown-up? Not just levels, but also which type of treatment. So that's where we are trying to go, but we're quite far from it. We talk about it a lot in our research grants to get money, but reality is a difference. However, we have come far in microbiology because we can sequence the bacteria. We have come rather far in oncology also, where we can sequence the tumor to see what type of expression, what type of tumor it is. And by integrating these research fields of immunology, microbiology, this cross-kingdom approach is a new way to think about it. Not just think at they and we, to try to see how we interact and make this interaction favorable both for the pathogen and for the host. So we can live in a symbiosis together. So basically what we want to do is restore balance. So just a couple of last slides, just to give you a perspective of what's in the pipeline. So there's different therapies that are being developed based on this type of research. As I told you, for the urinary tract, it's very important to have the type 1 fimbria. 99% of all E. coli bacteria have type 1 fimbria to be able to bind to the bladder. So you can try to develop antagonists to FimH, the adhesion of the type 1 fimbria, to block the binding. If you block the binding, the bacteria will just go out with the urine. You can give diamanose, it blocks the FimH, Or you can use this type of research also to develop vaccines to it. E. coli vaccines have been quite problematic to develop, but there are some promising ones now. And okay, urinary tract infection, I mean, how important is it? But imagine the cost that this costs society for these women to go to the doctor all the time, have this infection ongoing, probably for the majority of their life. When we look at the oral bacteria, we have quorum sensing, the way the bacteria talk with each other in the biofilm. If we can block this quorum sensing, we can actually block specific type of bacteria. What is it now? More than 700 different bacteria that they have found in the oral biofilm, probably in the thousands. We can just not differentiate them with good resolution. But if we can block certain type or key pathogens to disrupt the biofilm, maybe we can prevent the biofilm. You know, in some parts of the world, I think even in Sweden, you just think, take away the biofilm, take away the biofilm, take away the biofilm. But maybe we can take it away in a different way, not just scrape it away. And also they are trying to develop these type of enzymes that can quench the quorum sensing and also disrupt the biofilm. So these are some of the mechanisms that are trying to be developed, but hopefully we can I have a collaborator in Max Planck in Germany who's trying to develop different inhibitors of these receptors that the bacteria have, and we call them master regulators. So we can really block not one virulence factor, but the whole virulence phenotype of the bacteria, because that will be very hard to protect yourself against. I will come back to that. I think I can take 5 minutes just to present our project. So we are very happy to have gotten a nice big grant the last couple of months, where we are focusing on a dietary metabolite called trimethylamine N-oxide, TMAO. So when you eat meat, egg, crayfish, your intestinal bacteria will metabolize them through L-carnitine, choline, and so to produce a molecule that is called TMA. TMA will move to the liver, and there it will be metabolized by an enzyme and form TMA. This metabolite has been linked to chronic kidney disease. It has been linked to cardiovascular disease. It has been linked more and more coming with periodontitis. I had a prior PhD student, Stefania. She is a nephrologist. What we did was to study the molecular mechanisms of this TMAO molecule to try to understand what it does to kidney fibroblast. Everything is done on mice. Everything is done with epidemiology. But what actually happens? I mean, not every time you can translate mice data to human data. Whatever they do in mice when it comes to this molecule, if we try to repeat it in human cells, we don't see anything the same. So what we saw was that TMAO actually increases proliferation of fibroblasts. It increases fibrosis. It together with TNF have a synergistic induction of inflammation. And then and it's linked to cardiovascular disease, endothelial dysfunction. So what we tried to do in this grant was to see if this molecule could be a common denominator between these diseases. We know periodontitis is linked to cardiovascular disease. We know that chronic kidney disease, all of you know this better than me, is linked to periodontitis. Periodontitis is linked to chronic kidney disease. I don't know really how the way goes, but I think it's a circle, what I have understood it. So we were very happy to get this grant. So we will do this in 3 different sub-projects. We have 3 different cohorts, clinical cohorts. We have a cardiovascular cohort from Örebro University that we will screen for biomarkers, for different inflammation markers. We have, through our collaborators with Karolinska Institute, with Kåre Berlin and Anders Gustafsson, gotten our hands of the Prankort cohort, where they found that there was a link between periodontal disease and myocardial infarction. So we're very happy to get that cohort also to screen. and with the kidney researchers in Karolinska Institute, we also have a clinical cohort of chronic kidney disease. So we will screen these cohorts. We will screen the proteome, the microbiome, we will screen the transcriptome of them to try to see if there's any common links between them on a clinical perspective. If we can find the common links, then we can back to the molecular mechanisms to try to see what is actually downstream of them. So first we will screen the cohorts, then we will use in vitro system, basically cell systems, to screen and see which molecular pathways are activated. Is the same molecular pathway activated in all different oral cells, kidney cells, and endothelial cells or smooth muscle cells? Then we will move on to create a common in vivo mouse model to be able to study the path of these diseases in a system to try to validate what we have seen in the in vitro system. And we will have a huge bioinformatics team to try to help us to combine all of this into a predictive model. If we block this, if we activate this, could we affect the progression of these three diseases or block one of them, or is two linked rather than all three in this strive to see if TMAO is a shared factor. So in this collaboration we also have the pharmaceutical industry helping us. We have probiotics companies that are very interested to see if we can treat. And why did we get interested in periodontitis regarding TMAO? So everybody has talked about the gut microbiota. It's the gut microbiota that converts choline, L-carnitine into TMA. But recent years have actually shown that the oral microbiome can also convert these molecules and contribute to the burden. So it would be interesting to see the locally produced TMAO and also the systemic effects. And if you treat and if you change the oral microbiome, what will happen to the systemic effects? So hopefully in a couple of years I can come back and tell you that TMAO is very important for periodontitis also. With that said, I would like to thank you for giving me the opportunity to present our research group and what we do. And we have, as I showed you, the research group and a lot of internal collaborators and also a lot of external collaborators and medical companies that help us. And of course our funding agencies is probably the same in India, but it's very hard to get external funding. And in Sweden it's extremely expensive to employ somebody. Thank you so much.
Thank you very much for creating interest in microbiology, which most of us are not interested as such. So my first question is there any difference between commensal and when they become pathogenic, like after antibiotic treatment? Like we get candidiasis.
Yeah.
To become candidiasis, that normal commensal, it has to change its...
You mean, we do of course have commensal bacteria, and we have opportunistic bacteria also, that if you're immunosuppressed, they can get triggered.
Yeah, but then they change that.
I think like this. I think if you have, so different bacteria have a different set of virulence factor. They don't have all of them. You can acquire virulence factor through plasmid, exchange with other bacteria. So if you don't have a set of virulence factor, you will probably not be pathogenic. But you can be an opportunistic bacteria that if you're immunosuppressed, all of a sudden you can get an infection by this bacteria or by candida. Not everybody has candida infections, isn't it? When you give maybe immunomodulatory drugs, then it will flare up.
Yeah, thank you. And second question, do you think that these knockout organisms can be developed and can be used as a non-pathogenic bacteria in treatment as a competitive inhibitor? Like you took out these knockout organisms and I'll put it in patient's mouth so that...
You mean to compete out the pathogenic bacteria?
Yeah.
Maybe, I would say maybe, depending if you have one virulence factor that is the cause of the infection. So in E. coli, we know, and this is why we don't have a vaccine today, it's not one set of virulence factor, it's the combination of them. And as I said, type 1 fimbria, 99% of all E. coli have type 1 fimbria, commensals and non-commensal. So why doesn't the commensals cause the infection? it's because they don't have the other ones also. So it is very complex in the interactions. It's usually never one virulence factor. It's usually not only the bacteria, it's also the host. How does the host react? Are you predisposed? Are you immunosuppressed? Are you in your menstrual cycle in a certain point where we have less estrogen and more testosterone? It's really complex to try to know exactly.
Thank you, dear. Thank you.
Doc, can the host influence the virulence factors in the bacteria?
Yes.
Because we were working on gingivitis and we were working on strains from periodontitis patients, and we found we had an inhibitor which was doing very well. In a few people, it was working well. In a few, it was not working well. So, is it possible that the virulence factors expressed by strains in different individuals have different virulence factors?
I would say yes. If we go back to the paper where we studied Porphyromonas gingivalis, so if we just added, and this is just estrogen, we just added estrogen and we saw that the growth, the biofilm, and the gingipains are increased. We added testosterone, we saw the same thing. I told you previously that pro-inflammatory cytokines have been shown to work as transcription factors in E. coli. So could be that the human host's response could be different in different individuals. So it's definitely the interaction between them. And this is what also makes this field very hard. You cannot focus on one. So ideally, in my perspective, ideally, postmenopausal woman, she comes in, she has a recurrency. Give her antibiotics. And in this pill also give estrogen. Don't be afraid of cancer, just a short time treatment also to suppress the virulence of the bacteria, and maybe we could increase the eradication of the bacteria. So definitely I think it should be the host also.
It was a very mind-opening presentation, Isaac sir. I thought it was post-lunch session would be a bit confusing. But really, it has thrown a very vast light among oral pathologists. Probably you may not be a practitioners. My perception, I personally got benefited with these things. Almost we are in the stage of immunomodulators and targeted therapy. The concept of normal flora of everything, UTI, oral cavity, or GIT has changed post-COVID. It's not like same thing. Now the tablet of antibiotic is going to be reduced and tablet of probiotic is going to be introduced. And it's high time this understanding will throw some more interest in concept of biosimilars. And we have done a sort of preliminary research over oncolytic viruses, where it goes and binds to the nucleus of the cell, where I can target my medicine. It is sort of totally synthetic.
Yeah.
So if I go totally into a synthetic way, I don't have to bother about virulence or active of disease or a disease phase. No. So this is a really concept. Probably in India we have not focused much over there. Your knowledge, it could have been eye-opening message for postgraduate students among over there. This is going to be biosimilars, oncolytic viruses, targeted therapy, like precision medicines. That's the future. Probably you gave a very nice presentation.
I believe so.
Biosimilars.
Definitely. Precision medicine is the way forward. Of course, it's going to be a matter of money. Rich countries can do it. But of course, eventually the methodology will develop. Sequencing cost thousands of dollars previously. Now it's very cheap. So it will come. Of course. It's cheaper to try to do prophylactic. Of course, you need money for that also, but what doesn't it cost when an individual, we come from, in Sweden, a socialist country where I would say healthcare is free, but of course we pay taxes for it, so that we can focus on prophylactic there.
Understanding the concept of right over the post-graduate, there's a different path, not sitting behind microscope and seeing straight.
No.
We are some more far ahead of what we think we are.
Yeah, absolutely.
Sort of a big industry, big factory, big
exactly. And I think that, the mouth is so easily accessible if we compare to the bladder and the kidneys and so on. And that's why Probi, that is one of the world's biggest probiotic companies, are interested in this project, because they have a pill for the oral microbiome.
Actually, the normal probiotics, they concentrate more on GI microbiome. We don't have a proper probiotics for oral cavities. When we take oral cavity, it will go through intestine.
Exactly.
Intestine absorbs, then only it comes to the place oral cavity. So I think recently few pharmaceutical companies, they came with a sort of absorbable. If you put the sachet, it won't go beyond my throat. A sort of thing.
Yeah.
But so many things are going on in probiotics.
And I
in
think
India.
that's very important. I think the oral microbiome is very forgotten.
And lack of knowledge about normal bacterial flora, it has created so much of chaos in treating patient, or a sort of complications or more of side effects and all. I say that don't write antibiotic below, don't write probiotic also. In a prescription, same prescription will have antibiotic for 3 days and probiotic for 3 days, saying that this will go and do nullify or antibiotic induced diarrhea or some other things. And also very good topic, sir.
Thank you, sir. Thank you, sir. I request our chairpersons to kindly felicitate our speaker.
Thank you.
You look smarter this way.
Thank you. Thank you so much.
Ma'am. Sir.
Thank you. Thank you.
Felicitate us. Stage question.
Thank you for inviting me. Thank you.
Very, very informative. Thank you for introducing us to microbiome. It's usually always what a pathology.
Thank you so much. Thank you. Thank you.
I request Rajiv Desai, sir, to kindly felicitate our chairpersons. Rajakumari, ma'am. Arvind Babu, sir. Sashidhara, sir. Thank you, sir.
We now move on to plenary session 3 on biomaterials. We have 2 speakers in this session. The chairperson for this session is Ashok-Kumar Veeramuthu, sir, one of our most sought after names in the field of sustainable energy and many other interesting areas. So we have an expert with us as a session chair. So please come over to the dais. And I now hand over the mic to Radha to introduce the speaker for plenary session 3.
Good afternoon, one and all present here. First, I would like to thank Dr. Tamilmani to accept our invitation to deliver the lecture today. She did her PhD in Inorganic and Physical Chemistry, CSIR and CLRI lab. She has postdoctoral experience in many reputed institutions such as University of Madras and IIT Madras. Currently, she is working as assistant professor in the SSN College of Engineering. She has more than 20 publications in high-impact journals to her credit. With this, I would like to invite Dr. Tamilmani to deliver the lecture. Thank you.
A very good afternoon to everyone present here. So let me thank the organizer for giving me this opportunity to present my research work in this forum. So basically my research is entirely different from the earlier lectures. So I basically try to touch upon the basics about how the molecule can be tuned for various applications, specifically imaging applications. Therefore, I combine my topic to from upconversion to magnetic resonance imaging, that is by harnessing lanthanide nanostructures for imaging applications. So before getting into my research work, I like to discuss the basics behind my research. So medical imaging is nothing but the visual representation of the structure and functions of different tissues and organs in our human body, and which aims to identify the biological systems at both cellular and molecular level using non-invasive procedures. We have invasive procedures as well, okay, which is to address the abnormality in cells and molecules. Therefore, we can identify the which part is being diseased. Okay, so this will lead us for the treatment procedures. Therefore, because for many diseases there has been a common symptom, so therefore diagnosing the particular disease is being a challenging task. Therefore, imaging plays a major role in addressing the particular disease. So we have various biomedical imaging techniques like PET. We all know that it is a positron emission tomography imaging and computer tomography imaging. Both these imaging utilizes the radio tracers, that is they utilize radio molecules for imaging the particular tissues. Okay, but it has a severe risk like radiation risk, because when you keep on using this imaging, it leads to the it will split your cells and it may harm your cells and it may lead to a cancer disease. Okay, as well as if you go to the PET imaging, it has a poor spatial resolution. And we have other imaging, magnetic resonance imaging, where you will use a magnetic molecules which has a high spatial resolution and but it has a very less tissue penetration limit, but it has its limitations like sensibility, high cost and long imaging time. And you have ultrasound imaging which has a high sensitivity and it can be used at a very low cost. Okay, but it has a drawbacks like poor resolution, and it is basically it is based on the operator. Okay, next is the SPECT imaging. Okay, there is a single photon emission computer tomography. It has a very limitation in penetration depth and it has a very good sensitivity, but it lacks from spatial resolution and radiation risk. And we have other one is the optical imaging, which is the most important imaging. Nowadays we have been using this optical imaging for all kind of disease diagnosis. Like it has a very good sensitivity and it is also a very cost effective, but it has a very low spatial resolution and small penetration depth. Okay, why spatial resolution is most important factor to be considered is can be explained from the image. On the left side, you can see that when you have a very low spatial resolution, we cannot diagnose a particular disease at a very good way. Okay, therefore spatial resolution is very important to diagnose the disease, how the cells is being, how the size, shape and morphology, and those information can be very well get only if you have a very good resolution. And as well as the sensitivity is an important factor. If you have a very good sensitivity and a high sensitivity, it indicates that most of the information you are getting out from this imaging is being a correct results. Okay, there won't be any kind of a false result or a negative result. Okay, but every imaging has its own merits and demerits. Therefore, we have to couple two imaging technologies. Okay, so in that way, my optical imaging is very well compatible with the magnetic resonance imaging. Okay, because optical imaging has a very good high sensitivity, but it has a very low tissue penetration. Whereas in the magnetic resonance imaging, it is even though it is a non-invasive technique, it has a very low sensitivity. Therefore, coupling MRI with optical imaging will be a very good imaging modality for the disease diagnosis. So if you look at the global market, it has been the compound annual growth rate has been increasing from 20 to 30%. So it indicates that there is a scope for multimodal imaging market. So with this lead, I just give a touch upon what is nanotherapeutics. You all be aware of. So it is nothing to do with the conventional therapies. It is being designed to carry the drug. Mainly the nanotherapeutics is where you will utilize the drug molecules in a nanometer range. Okay, because of utilizing these nanometer range molecules, it will increase the dissolution rate, and it has a very specific target of interest, and we can also use the higher concentration of these nanoparticles at a very low dosage. And also it has a many important property. It has a nucleus targeting property. Okay, because of its very large hydrodynamic size, and it can also be functionalized with several peptides. Therefore, it can target the specific molecule, a specific site of interest. Therefore, this entry of this nanoparticle is not just because of its size, but shape also influences the entry of these nanoparticles into the system. So the basic behind this fluorescent probe is, it is a kind of a dye molecule or any kind of fluorescent molecules which will give the chemical information about the complex biomolecular assemblies, that is the live cells, to detect it in a very good sensitivity, high sensitivity and selectivity. And the basic requirements, it should have a very good photochemical stability, and it should not be toxicity, as well as it should have a very good less phototoxicity, and therefore there should not be any kind of photo bleaching or photothermal effects, and it should have a very strong absorption at a given excitation wavelength, and it should have a well resolved emission spectra with a narrow bandwidth. And we have so much of fluorescent molecules like quantum dots, organic dyes, and rare nanoparticles or graphitic particles. But these particles is being suffered from photobleaching. Photobleaching is when you keep on using these dye molecules for longer time, this emission property will be decreasing. Therefore, the fluorescence of these molecules will be keep on decreasing. At one point, it will vanish. Therefore, it will lead us to a false results. So the existing molecules, you might be aware of dye molecule FITC, that is fluorescent isothiocyanate. It is also a kind of a dye molecules, and it is been suffering from photobleaching thresholds, and it has a very different excitation wavelength, and you have a broad emission spectra. If you have a broad emission spectra, it cannot be useful to identify a particular molecule. Therefore, next is the quantum dots. You might be aware of graphene quantum dots or polymer encapsulated quantum dots. These quantum dots have a very narrow emission band with a full width of maximum of 20 to 30 nanometer, but it suffers from in vivo cytotoxicity and fluorescent intermittence. It is a kind of a blinking. Okay, it will not give a continuous emission pattern. In order to, if you want to diagnose a particular disease or a portion site of interest, continuous fluorescence should be emitted. But this lacks from continuous emission. Therefore, in order to overcome all these drawbacks, lanthanides has been a very good nanoparticle using as a luminescent label for its very good photostability, colloidal stability, and it has been have a very deep light penetration depth, as well as it has been a very less toxic and a less scattering factor. But it has a challenge in the surface chemistry. That is, we need to modify the surface with a biocompatible ligands. So my aim, so this is the overall picture why lanthanide nanostructures is being adopted for the optical imaging, like high optical sensitivity, upconversion luminescence, and deep tissue penetration, excellent photostability, and a low background signal. It is the most important thing will be considered for the imaging applications, and it can be used for the multicolor and the multiplex imaging. That is, we can visualize the molecules at different wavelength, at different color pattern, color region, and it can also be used as a multimodal imaging applications. And the challenging task is we need to tune the molecules with a very good size, shape, and surface phenomena. Therefore, we will adopt that natural products as a ligand for preparing these nanoparticles. So, the research problem what I am going to discuss here is how the structure of the molecule, shape, and size and the surface coating will affect the multimodal imaging applications, and how one molecule can be used for a different functional imaging applications. So this is about the synthesis methodology. We all know about, we have conventional solid state thing where we'll just grind a material and we'll prepare nanoparticles, but it leads to a different side products which leads to the toxicity issues, and also lot of energy should be utilized for the preparation of these nanoparticles. And we have a soft chemistry methods. Nowadays we are being using the soft chemistry methods like hydrothermal, salt gel, spray pyrolysis, excuse me, co-precipitation and microwave assisted heating method. Throughout my research work, I will be adopting only hydrothermal method for preparing these nanoparticles, because it will consume a less temperature. That is, maximum it can go till 200 degrees Celsius, and we can get the uniform morphology or uniform composition, and also we can get the different morphology like spheres, rods, square nanoplates. I'll show my work where I have prepared so much of materials. Okay, so basically for this application we need to choose a host lattice. We have different matrices like fluorides, oxides, vanadides, phosphates and those things. These host lattice is an important factor to be considered when we using these materials for various applications. So the material what I'm going to discuss today is a lanthanum orthovanadate. It has been different structures existing, but we specifically prepare a material in single phase by adopting the hydrothermal methodology, where I have been adopted catechin as one of the flavonoid for preparing a particular material in a single crystal structure. Okay, by varying the concentration, how the nanoparticles is being prepared in a single pure phase. Whenever you are using some molecules for kind of imaging or in situ, in vivo or in vitro, the molecule should be a 100% purity. So therefore, I just played a role on how the concentration of the catechin, hydrothermal temperature, time and pH in tuning the crystal structure from one phase to other phase. So this is all about the XRD, X-ray crystal structure. So this is the method. This is a method by which we can predict how the what kind of structure, crystal structure, is being formed for the particular molecule. So this is the slide where I have prepared different morphologies of the same particle using different concentrations of the catechin. Okay, I have adopted the same catechin, but varying the concentration, I can able to prepare a spherical, rod-shaped and a square nanoparticles. So just because of the conformers, the molecule existence, how the molecule has been oriented, based on that we can tune the morphology. So this is how the from spherical to rod conformation, and how the rod shape is been transformed into square nanoplates, and the mechanistic details has been presented here as graph. And this is the luminescent spectra. Okay, so whatever you are seeing, whatever you are being using optical microscope, so there you will be seeing some image, right, in color. So that is basically arising from this kind of spectrum. You call this spectrum as a fluorescent spectrum. Whatever you say, that window you talk about, like whether it is blue region, green region, red region, that is basically originate from this luminescent spectra. So this is the how I have been used this europium dope lanthanum orthovanadate as a fluorescent red label. So basically my molecule will absorb light at the red region. Always we used to suffer whenever we are viewing some cells. If the molecule is emitting green emission, it is very difficult to differentiate the debris from our own molecules. So therefore green emission material is not that much important. So everybody is doing research on the red biolabel. So I can so by using this methodology, I can prepare the red biolabel. So this is the MTT assay. So I can use a material. It is not that much toxic. I can use this material for the red biolabel for optical imaging applications. So this is I have taken this is a confocal image. So I can say that I have taken it at 6 hours and 30 minutes, and this nanorods, specifically nanorod shape molecule, has been penetrating into the cell, and it can be used as a nucleus targeter. So this is a DAPI staining image. Using a negative reverse mode, we can say that it has been a nucleus targeter rather than the cell membrane targeter. And right side you have a mechanism by which this catechin forms a hydrogen bonding between the lipid bilayer, then thereby it enters into the nucleus and therefore act as a nucleus targeter. By same methodology, I can use these molecule for a MRI contrast agent just by tuning the morphology. So basically, if you planning to use any MRI contrast agent, this magnetic property is most important property. So if you want to use, we have two type of contrast agents, T1 and T2. If you are using a T1 contrast agent, it should be a paramagnetic material, and if it is a T2 contrast agent, it should be a super paramagnetic material. So by tuning the, by varying the concentration of the cation, I can able to prepare both T1 and T2 contrast agent. Just this is a vibrating sample magnetometer where we can say that whether the prepared material is a paramagnetic or super paramagnetic. So this is the cell viability studies. So these molecules, that is basically gadolinium doped lanthanum anodate, can be used as a MRI contrast agent because it has not that much toxic. So whatever the cells I have been used, the immortalized human carotenoid cells, and this is the phantom and relaxivity studies. So this is both T1 and T2 studies, how the crystal structure is been influencing the MRI studies. So when you compare these two crystal structures of lanthanum anodate, so that TGL, that is tetragonal phase, is very much superior for T1 relaxive contrast agent, and this is how the morphology can be varied. So if the morphology is tuned, is varied from rod to square to sphere, this contrast agent also is property is been changing from T1 to T2, and therefore we can use it for both T1 and T2 contrast agent. So this is the table. Okay, so by see when the 0,1 ZL can be used as a T2 contrast agent, and 5 GL can be used as a T1 contrast agent, and 1 GL, which is in a spherical shape, can be used as a T2 contrast agent because of its super paramagnetic behavior. So basically this luminescent process can be used in a two ways. One is like we are giving a energy in the visible region, and we can visualize it in the higher wavelength region. In other way is we can give a low energy, that is in the NIR region. So when you look at the penetration depth for NIR region, that is 980 nanometer on the right side, it has a very high penetration depth. Therefore these molecules under upconversion luminescent phenomena can be very well studied for any kind of imaging applications. Excuse me. So this is how the molecule can be prepared for upconversion luminescent phenomena. So this is first thing is we need to confirm the crystal structure, how pure the material is being prepared using the Rydberg analysis, and this is the luminescent spectra. These materials can be used as a red biolabel, and the most important thing, this is a color chromaticity diagram where by varying the concentration we can tune the material from the red emission light to the blue emission light by the concentration variation. Therefore with a single molecule we can prepare a different modality, imaging modality. So, and main important thing is these molecule has a very good lifetime. Therefore these molecule can be used for emission for a longer time. So these molecules will give a continuous emission spectra in order to diagnose the particular diseases. So this is a overall picture to show that it's the same molecule and a different excitation wavelength. It can be used as both down conversion and up conversion luminescent material, and with the nanometer range size. So with this I will conclude my talk. So I would like to thank the organizers for giving me this opportunity, as well as I thank my financial assistants like DST Inspire, ECRB NPDF and UGC DSK PDF for carrying out this research work, and I also thank the CSIR, CLRI, IIT Madras and University of Madras for the facilities, and I also thank Professor Jayashree, Sri Tirunelveli Institute of Medical Science and Technology for MRI imaging, and Professor Vinith Kumar Roy for the upconversion studies, and also I thank the SSN College for the seed grant. Thank you all. It's open for discussion now.
It's a very nice presentation, ma'am, and well structured. Let's go with the audience. Audience, any questions, please? Because this is time, you know.
Oh, yeah.
Okay, so I have one concern, ma'am, that what is the wave number when you go for this? It's 480.
This one.
Okay, 9. And okay. So, and this is very good study, and one more concern is that when we come to the environmental, perspective, for example, mining and refining, in this process like lanthanum,
Yeah, yes, yes.
it gives a lot of, hazardous and, like pollute the environment. Particularly, it pollute the soil and it pollute the water.
Yes.
So in this case, how can we address?
So basically, so currently we have MRI contrast agent as gadolinium DOTA, that is a kind of gadolinium complex, where the usage of gadolinium is in a milligram level. But whatever we are going to adapt here is kind of a microgram or nanogram level, so that it will be used as a dopant. Okay, so it will be like a very minor quantity. So therefore, the quantity of these lanthanides will be very less, but its efficiency is very good. Even we can use it in a very low quantity. It is not like bulk quantity or gram or gram scale. It is kind of a micro or nanogram scale is enough, sufficient is that.
But coming to the cost of issue also,
Currently, whatever in the market is being a lanthanide. If you go for MRI imaging contrast, the most thing used will be the gadolinium complex. But we have some negative effect on these complexes.
Yeah.
When you using these complexes for a long time, the gadolinium molecule will start coming out from this complex, and results is not been that much good. So we need to go for another take and so much of trials. So in order to avoid this, we can use this gadolinium as the dopant inside the particular hose, so that it will be capped inside. It will be a very safe thing.
Anyway, good. Thank you very much for your nice presentation. So now, yes, ma'am, please. Okay.
I request now Dr. Ashok sir to facilitate the speaker.
Okay. Question எல்லாம் முடிஞ்சது. Second speaker.
கொடுத்துட்டீங்களா?
கொடுத்தாச்சு ma'am.
So we now move on to the speaker number 2 for preliminary session 3.
I hope I'm audible. I hope I'm audible.
Janani ma'am, just a second. We are just connecting.
Yeah, sure. I mean, I'm just checking if I'm audible and visible.
Yeah. Now it's ready. We have a short introduction of you.
Yeah, sure.
Yeah. Over to Dr. Radha for introducing.
I'm happy to introduce Dr. Janani Radhakrishnan to deliver the lecture. She completed her MSc in Biomedical Science from Bharathidasan University, where she secured first rank, and she pursued PhD with DST Inspire Junior and Senior Research Fellowships. Then she has been awarded Founder Chancellor's Award for the Best PhD Dissertation of the year 2017 for Sciences at the Shastra University. During her PhD, she had short-term international visits to Tokyo City University and University of Connecticut, US. Further, she worked at Indian Institute of Technology, Madras, as postdoctoral fellow. She has been awarded with the prestigious DST Inspire Faculty Fellowship. She has 2 Indian patents granted and publications in top biomaterials high-impact journals. She has joined NIAB as scientist in August 2022. Thank you, ma'am. I'm happy to invite you to deliver your lecture.
Yeah, thank you very much. So before I begin, thanks to the organizers, especially Dr. Ramya, who's been pushing through and inviting me for this conference. And I'm sure I'm not a dentist, neither a clinician, but I work on biomaterials, which anybody can relate with, and especially dentists are the first ones to adapt any biomaterials for that matter. So I hope this lecture is of interest. And there is an update after the introduction, from NAB as a scientist. I've recently moved to Naipur. Again, it's in Hyderabad, in the medical devices department as assistant professor. So to begin with, yes. So what I've been doing during my times from PhD and postdoc fellowship, and now as a faculty, and earlier also as an independent Inspire faculty as well as a scientist. I've been developing a lot of biomaterials, with special interest towards 3D biofabrications, and I've categorized them into two categories. So the major interest is we develop and design these biomaterials in such a way that they are going to modulate the cellular responses and then in turn bring about a tissue response for a regenerative perspective. And I've categorized these constructs, whatever I've been developing, as preformed scaffolds and injectable hydrogels or 3D printed. So the basic difference is in a preformed scaffolds, there's a lot of difficulty in geometry. It comes in a specific size and shape, and distribution of cells in the matrix will be very different. Whereas injectables and 3D printed will be customized. It can go towards personalized medicines where constructs are designed according to the pathology. So one such example of preformed for cellular responses is just an alignment of random fibers, two longitudinal axial sections will actually wrap up the Schwann cells. When we culture nerve cells into them, they become myelinating Schwann cells. This is an example of a structural cue. You just align the fibers and the cells will respond differently. In another study, we've developed a very hard hydroxyapatite based composite scaffold, and here we evaluated them in rabbit for regeneration. So that was a compositional and a mechanical cue. In another study, this is the injectable hydrogel that I'm talking about. So the osteochondral tissue, which is there in the arthritis. The arthritis is a tissue where cartilage and the bone is affected. So the green region shows the soft tissue and the red region shows mineralization. So we were able to fabricate this injectable gradient hydrogel, and we were able to understand how it regenerates the tissue, the osteochondral tissue in a rabbit model. Further on, the interest in injectable hydrogels made me, move forward with injectable hydrogels for stem cells.
Sorry.
I hope.
Yeah. Can you do you have the presentation slides?
What happened? Is it not coming up?
No. We didn't see that. Only we can see your face.
Oh, really? I thought I'm sharing it.
No, you didn't share.
Okay. Should I reshare again?
Yes, ma'am.
No.
You have to
share. Should I stop and reshare? Should I? Just a minute. I'll try resharing the slides.
Okay.
What about now?
Yeah.
Is that fine?
Yes.
Oh, all right. Never mind. This is the first slide, so it shouldn't be a problem. So yes. So these are the aligned fibers that I was talking about, and this is the gradient hydrogel that I'm talking about, mineralized, deeper sections and a soft cartilage section. And in another strategy, we co-delivered stem cells with these injectable hydrogels for a cardiac application. However, in this talk, I'll be talking more in detail about two strategies. One is a core shell fibrous matrix that we developed, and another one is a 3D printed electrically conductive matrix. So these are the two things that I'll be talking about. Why core shell and why immunomodulatory materials? So where have the biomaterials moved towards? Basically, any material, for instance, is a foreign body. And what happens to the foreign body is, we all know that macrophage recruitment happens, protein absorption happens, fibrous capsule formation happens, and the implant get rejected. That is why we keep talking about biocompatible, biocompatible, biocompatible. So when we talk about biocompatible biomaterials, so far this has been the traditional strategy. Where biomaterials are inert, it doesn't evoke any foreign response. Basically, it doesn't do anything to the cells. And thereby we actually prevent rejection. Currently, we move towards immunomodulatory biomaterials. Here, what happens is the biomaterials are trying to interact with the macrophage cells, the immune cells, which is responsible for the inflammations and things, so that any response will be triggered. In other ways, we can say that these are mostly integrating with the tissues. Earlier, we were saying that biocompatibility is, they should not interact with the tissues and cells. But now it's different. They have to interact with the immune cells. So a classic example where immune cells are playing a big role will be a chronic diabetic wound. So what happens in these cases? In the normal wound, the monocytes will be recruited, and then macrophages will be in their M1 state, and this is where the pathogens are engulfed. And after this pro-inflammatory period, for some time, the pathogens are cleared off, and then that M1 transitions to M2. Whereas in the diabetic wound, what happens? This is a leaky pipeline. So there are a lot of monocytes that is recruited, and this macrophages are also not functioning properly. For some reason, the phagocytosis is also decreased. So they don't move from this M1 to M2. So they are still in the pro-inflammatory, and they don't move towards the anti-inflammatory. That is where there is prolonged inflammation and there is no healing. So then we decided to develop an immunomodulatory biomaterial, which is also going to interact with these macrophages. So there are two ways of interacting with the immune system. One is the macrophages. So we thought we'll have an anti-inflammatory drug which can actually modulate the macrophages. And that is an acute condition. Once the chronic condition moves towards acute, then there is another thing that will hinder the healing process, which is the ROS, reactive oxygen species, that is there in the wound environment. So for this, we decided it's not enough to deliver one drug, we'll deliver two drugs. One is an anti-inflammatory drug, which is a crisaborole, which is used for topical applications. Another one is a eugenol, which is derived from clove oil, and it is an antioxidant. So we decided one goes to the core, one goes to the shell. So the core has a sustained release of eugenol, and the shell has a very burst release. Immediately there is, a release of crisaborole. Inflammation is moved from acute phase to, chronic phase to the acute phase, and then the healing will take over. So for this, we decided the biomaterials. So crisaborole is a boron-based biomaterials, and we have a genetic code expanded. Silk protein expressed, the spideroin protein was expressed, and to that, for the interest of time, I am cutting down some part of that, but I'll try to be more brief also. So what happens is, in a normal protein, we have tyrosine. In the genetic code expanded protein, in the place of tyrosine, we are incorporating DOPA. So what this DOPA will actually help? The difference between tyrosine and DOPA is this double OH group. So this diol group is a catechol group which will be involved in conjugation with this boron group in this drug. So this way, there is a pH responsive conjugation of this drug, which is an anti-inflammatory drug, with the boron, with this DOPA-based silk biomaterial. So in this silk, crisaborole is now conjugated. So these are all the characterizations where you see that the molecular weight of crisaborole has increased, silk has increased when the DOPA is incorporated. And these are typical, conjugations where during the different pHs, we say that the conjugation has happened. There is a shift in the peak. So I'm not going to get into those details. So here is a structural detail where it says that the core shell fiber. So this is a core shell. This is the fibrous mat that we developed, and we can say that the core and shell. This is a fluorescent image which shows the core and shell. This is a TEM transmission electron microscope which shows the core and the shell. And we also say that the degradation was there till 5 weeks. So there is a gradual degradation which will support the regeneration of new matrix. And eventually, we also have to understand how much of drug is encapsulated and all. So the encapsulation was almost 88% and 52% of crisaborole. And we were also able to see that they had a very good antioxidant property. So this was evaluated in vitro, and the release was also burst in the, see, we can see that within 1 day, there is a lot of 80% release of crisaborole. And in the case of eugenol, which is now inside the core, one drug is in the shell, another drug is in the core. From the core, there is a sustained release, and this goes beyond 15 days. So this is what is required for us. And what happens looking at their compatibility with cells and things. So this core shell fiber had a very good compatibility and very good proliferation of fibroblast cells with them. And the viability was very prominent. We can see this green morphology of cells. And we were also able to see the cytoskeletal expression and the cellular morphology in these fibrous matrices, which is compatible, which proves their compatibility. And this is another important perspective of vascularization. Any wound healing should also be supported with neovascularization, which means that blood vessels should sprout out, which requires a lot of endothelial cells to be cultured. So this is an EA is one endothelial cells, and you can see that VEGF is known to be a vascular endothelial growth factor. And this construct of ours had very good vascularization in comparison to VEGF. You can see the branching of and nodes formation. This is a indication that the specific matrix has probability for vascularization and new blood vessels can form up. So these were some of the quantifications of these, like the number of branches, the number of tube length and things. These were all in supportive of the silk dopa crisaborole and dual drug delivered matrix. This is another study where we create an in vitro wound, and we see this white blank is an in vitro wound in a culture dish which is completely confluent of cells, and we see that these are now being filled by cells. So if you can see, the dual drug delivered matrix actually heals this wound. So at a faster rate compared to the other groups. So these are all the in vitro characterizations with cells that we try to understand what happens, and importantly the role of these drugs for anti-inflammation. So for this particular study, we try to use LPS, which is known for causing inflammation. So THP1 cells are macrophage cells. So we try to understand what happens, and this was also supporting that the macrophages could actually transition from M1 to M2. So the markers IL-6 and IL-10 are known to be, IL-6 are known to be pro-inflammatory, but IL-10 and IL-13 are known to be anti-inflammatory. So there is a significant increase in anti-inflammatory molecules compared to the pro-inflammatory, which means that this biomaterial that we have developed is immunomodulatory. It can induce some activity in anti-inflammatory activity in the wound site. So this is an in vitro study which involves the macrophage cells. Further, we try to understand what happens when a diabetic wound is, when a wound is developed in a diabetic rat. So here we again developed a 2 centimeter wound, and we compared these different matrices with single drugs, dual drugs, with that of a commercially available duoderm, which is actually a collagen based matrix. So we were able to see that in 18 days, there's almost complete closure of the wound in this duoderm, in the dual drug delivered group. So this is where the wound contraction rate has been higher. It's not enough. We also have to understand if epithelialization has happened properly. So that also has happened properly. This is the dual drug group. As early as 7 days, a proper epithelial lining was formed, which was absent in the other groups, where still the intragranular tissue was more prominent. And as you see in day 21, there's a proper, beautiful reepithelialization in the core shell group, where we are delivering 2 drugs. Similarly, a lot of collagen fiber deposition around in the dermal matrix, dermal region. So this was also very predominant in the histology analysis. So this actually concludes that a core shell strategy successfully serves as a strategy for delivering 2 drugs and acts as an immunomodulatory biomaterial. It has anti-inflammatory activity. It has macrophage polarization potential, antioxidant, vascularization, as well as reepithelialization. And in an animal model, we could also prove that chronic wounds can be healed. So this again is in the patent filing stage, and this is also published in ACS Biomaterial Science and Sciences, one of the prominent journals. And another study that I'll be discussing now is a 3D printed construct. So, when we started with 3D printed construct, we were thinking of just cross-linking the hydrogel once and then print that. But then the stability was not very good in these constructs. So then we thought we'll go for dual cross-linked approaches. So what do? We do a minimal cross-linking. So this is a particular polymer gelangum, which has a minimal, gelation, which is thermal-based gelation. So a kind of a hydrogen bonding induced gel will be formed and then this gel will be loaded into the extruder of the bioprinter. And then what we do is after printing, we will now, another polymer is polyvinyl alcohol, which is methacrylated for photo cross-linking potential. So after printing, a photo cross-linking will happen. So dual cross-linking, a weak gel to make the print stable and a strong gel to make increase the fidelity of the gel so that the structure becomes robust. So this was the strategy that we thought we will go ahead with. And this was also recently published in JMCB. So, the idea behind this, the importance or the rationale behind this study is to address the cardiac tissue. So for a cardiac tissue, the cardiac is one of the electromechanical tissues. So the matrix actually has some charge balances, which is involved in conduction. So we decided the extracellular matrix that we will be developing should have interconnected porosity for cell integration, and it should also have some conductivity. So for this, what we did, we incorporated reduced graphene oxide to them. And these are their conductivity measurements. And then these are the viscoelasticity measurements. So what happens, I'll discuss 2 important properties. One is the shear thinning. When the hydrogel is subjected to injecting or extrusion through the 3D bioprinter, they have to thin down. Only then they can pass through the syringe, right? So for this, the hydrogel should have a very good property, which is known as shear thinning. As we increase the shear rate, their viscosity should come down. Another property is when you shear, their strength should come down. When you remove it from any shear stress, their strength should come back. So that is what is called the thixotropic property. See, their strength is high. When you subject it to a pressure, their strength reduces. Remove the pressure, their strength increases. So this is called self-recovery. So the material should also have a self-recovery, a self-healing process. So these are important characterization, and this is just a fancy image which shows that these hydrogels, this is the hydrogel, this is the conductive hydrogel that we developed, and this actually can illuminate. Both these works were carried out by me at CLRA when I was an Inspire faculty there. And so this you can see that just with single cross-linking, the structures are not strong enough. You can see the structures are collapsing. Whereas in this case, the structures are very strong. And so you can see these are the 3D models and these are the printed structures. So after the dual cross-linking, the prints are very good. And further, we went on to understand if these constructs are compatible with cells and they can actually be involved in differentiating cardiac cells. So this is a compatibility of these. The green cells show that these hydrogels, the printed hydrogels, could accommodate a lot of live myoblast cells, which is H9C2. And this is their proliferation. In fact, the presence of RGO has significantly increased the proliferation of cells over the 7-day period. And importantly, we have to understand if these H9C2 cells over a period, maybe 7 days or so, the H9C2 is a myoblast cells, and eventually they have to differentiate towards the cardiac tissue. So what we understood was the cadherins, alpha-actin, connexin 43 are important markers of cardiac differentiation, and the presence of RGO in these constructs, 3D printed constructs, actually has expressed or significantly expressed higher amount of these markers. And this is the stain which shows the cytoskeleton. The red shows the cytoskeleton, and the blue shows the nuclei. So this study again shows that this is a electrically conductive hydrogel that is 3D printed, and it can be printed to any shapes, and it is compatible with cardioblast cells, and it is also differentiating the cardioblast cells. So far in this study we've done till in vitro. Let's see if we could move forward with in vivo. So I've been discussing two work, but where I started, these are the institutions that I've been involved, and both these works were started or initiated when I was in IIT Madras, and most of it was carried out during my time at CLRA. So very thankful to my PhD students, to the PhD students of CLRA who were involved with me directly, my mentors, collaborators, lab members, and colleagues so far. So far, I've been fortunate enough that I've got Inspire Faculty Fund. There was a SERB Power Grant that was also involved in the silk work. And then I also have international funds like from my IGSTC and also a IRAC grant going on. So the institutions, the funding, and the people from mentors to students who are involved with me. Thank you very much for your patient listening. I'll be happy to take up any questions if there is any.
Well, presentation, ma'am. Can you hear me now?
Yes, I can hear you.
Okay, fine. Okay, nice presentation, and you well explained about the biomaterial in immunomodulatory. Okay, and first I would like to ask.
If it was clear, because for some reason, because of the delays and time, for the interest of time, I had to be very crisp. Otherwise, I would have been even more briefer.
Anyway, it's good, ma'am. Presentation is very good. Audience side, any questions? Okay, since it is evening now, so it's nobody's ready to ask. Okay, anyway, I have some concern because you are developing the biomaterial, isn't it? So did you bother about the environmental related, like when it released or thrown to outside to the soil or like water?
So we actually are working on these materials which has to be safe. These are biocompatible, biodegradable materials.
Okay.
So when we say that it is not going to cause any toxicity inside the body, it is very less likely that it is going to cause any environmental issues. One issue that may happen is during their fabrication, we do use a lot of solvents and things. That is a common problem with all chemical and biomaterial based labs. But mostly the materials are by far very safe. If it is not safe, it's going to be toxic or so, we will not begin with those materials. We will try to choose materials, mostly 95%, the ones that is approved by FDA and for some application, and then we will try to modify it for our application. As you know, dentists use a lot of PVA and alginate.
Yes.
Right. So most of our materials, we will use that and then do a different fabrication and do a different application. So that if that is taken care of, I don't think environmental toxicity will be there in these materials. I'm not very sure of how it goes, but yes.
And another one question is that the immune response, it's like can we predict to the person, or it may varies from person to person regarding this your biomaterial.
Sorry, I'm not able to hear very clearly.
No, regarding can we predict the immune response because the material is synthesized, isn't it? So can we predict this immune response to a particular person, or the response may vary to person to person?
Yes, that's true. So that's when these personalized medicines will take care of, and that's when a lot of 3D in vitro models may help. Because what happens, the immune responses, we are saying that we are now focusing only on macrophages, but then it involves neutrophils, it involves a pool of immune cells, and the response of immune cells will vary between patients for sure. That is also one reason why research is moving towards replacing animal models to 3D in vitro tissue models. So bringing in a chip-based model and actually having the blood cells, blood channel flow and understand how these cells will be recruited in different blood pools. So these are the kind of advancements that's happening in research, more towards personalization of therapies. So I think chip-based strategies and tissue models would actually solve this person-to-person and patient-to-patient variations.
Yeah, you're right. Thank you very much once again, and nice presentation. And I will hand over the mic to the organizers. Thank you.
Thank you. Thank you very much.
Thank you, Dr.
Thank you,
Janani.
Dr. Ramya and the entire organizing team again for
Thank you.
inviting me.
And to the participants, I met Janani at a very random meet at IIT Roorkee.
Yes.
And I'm so happy that I met you. We were really happy seeing your presentation and your work. Looking forward to connect more and collaborate more.
Same here, my pleasure. I wish I come to Saveetha in person once, definitely.
Yeah, please do visit, and you'd be really impressed by the level of research infrastructure we have, and we can do a lot of collaboration work, because I can see that you already have validated a lot of preclinical data. So all of them can be taken over to level in vivo, or it can even be, if it is very well established, we can even help you to validate, take it to phase 1 clinical trial. So that is the environment which we have. It's a very proactive environment. We would really want you to come in person. Thank you so much, Dr. Janani. Thank you.
Thank you very
and
much.
apologies for the delay, and thank you for patient waiting.
No, that's okay. Still, it is on time. I can still manage.
Great.
Thank you very
Thank
much.
you so much. Yeah. Thank you. And I request Ashok sir to please receive the certificate for chairing this session. We have finally completed successfully day 1 of International Conference of Orofacial Pathology and Biology. And there are a lot of takeaways from today's session. We would love to you to again please see our videos, which has been live streamed, and it will all be available in YouTube. We'll post those links again. And definitely the consensus session is something which you should go again and visit it again. There are a lot of takeaways from that. And thank you so much for all your participation. So looking forward to meet you again tomorrow at day 2 of ICCPB 2026. Signing off for day 1. Thank you.